We're going to go ahead and get started. My name is Nick Beckett. I'm the events coordinator for the Center for Community Health and Engaged Research, also known as SHARE, not the singer, the department. But these workshops are actually sponsored by the Arizona Biomedical Research Center. This is the third of 6 free public health workshops that we do each academic year. This is actually the second one we've done with Dr. Sam Sabo and Luisa. And so the first one we actually did record. That one I'll let Sam go into a little bit more information on. But yeah, this is technically part 2 of their workshop series. But we do have a SHARE YouTube channel. It has all of our ABRC workshops going back, I want to say 9 years. And so a ton of different public health issues, public health concepts. And so we've done things with body BMI, we've done things with addiction, we do workshops every year down in Yuma, which is on border health. And so just a lot of different diverse free public health workshop series. And they range anywhere from 3 to 8 hours. And so you don't have to watch the full videos, but they're great resources. We have the presentations up there. There's contact information for some of these speakers. And even though 4 or 5 years ago, a lot of these topics are still very relevant today. But some that are coming up, we have one on April 2nd. This one's going to be down at Banner University Medical Center in downtown Phoenix. It's AI for Good, Advancing Care and Improving Lives. And we're working with a couple of radiologists from Banner University Medical Center, and they're basically going to show us how they're using AI in the healthcare system. It's moving really, really fast, as you all know, and so it's just exciting information to see. It seems like it's going to be a 3 or 4 year AI boom, and so just as much information as we can get. That one will also have a Zoom element to it, so you don't feel obligated to go down to Phoenix, or if you're in Phoenix. But I have that registration on the second to last page of your program. The 4th Annual Culturally Centered Addictions Research Training Conference, also known as CCART, that one's coming up April 9th and 10th. April 9th will be a dinner, actually just right across the street at 1899. And April 10th, we're going to have a scholars reception. They're going to do presentations. We'll also have a keynote speaker, and then we'll do a kind of a celebration post-scholars presentation, actual reception. And so all these scholars will actually be graduating with this certificate. So it's a really exciting event. And then to wrap up our workshops, we're going to be down in Yuma again on April 14th. And this is our 8th annual Yuma conference. A great group down there. We work with Amanda Aguirre, who used to be a state senator who represented Yuma County, and she's doing incredible work. She built a hospital down there. I should say hospitals, plural. They have so many like community health centers. It's really great what they're doing. But on that second to last page on your program, we have registration links to those. Unfortunately, that one is in person only, but the other 2 will have a hybrid Zoom element if you wanted to join online. But that's all I have. I'm going to turn it over to Dr. Sam Sabo. She is the one that you want to hear from, not me. But enjoy. I'm glad you all came out today. Feel free, help yourself to breakfast. We've got lunch coming around 11:30. Yeah, just a full day loaded with lots of information. So enjoy.
Is there a way to see? Cool. Awesome. Thanks.
Oops.
Just use the.
Turned off. Here you go.
Okay. Okay, cool. Good morning, everybody. It's so great to see you all. How many of you drove a couple of hours this morning to get here? All right. Okay. So you're waking up. Make sure you stay on that coffee. Thank you so much for waking up so early. So many of you have been coming from far distances, and this is really an exciting day. We've been talking about community health worker workforce development for many, many years. As long as I've probably lived here, so at least 25 years, this is a topic. But I think it's a relatively new and exciting topic for this region, for the Northern Arizona region. And so it is so heartwarming to see how many people in this room got up at probably 4 a.m. to drive all the way over here to be able to be part of a big conversation as a collective, as a really unique, beautiful region. So I'm really grateful to you all. My name again is Samantha Sabo, but I go by Sam, and I am at Northern Arizona University. I work here in Flagstaff, based here, and I work with Nick, and I just want to thank him for helping us make sure everybody has food and coffee and a chair to sit in. And he's really behind the scenes in terms of making all of the logistics happen, so we really appreciate him. So my job today, I'll be your MC, and I have the real privilege of getting to introduce and facilitate conversations with some incredible thought leaders, powerhouses, hardworking people that are really trying to move the needle in the area of health equity and addressing social determinants, structural determinants of health through engagement of the community health worker workforce. So I'm so excited, and all of their bios are in your agenda. So please feel free and know that we are a family. These folks that are they have told me this explicitly. They are here to serve. That is who they are. They have knowledge and experience and wealth of time to spend with you to help in any way. So please ensure that they are here for you. And we've tried to build the conference today with plenty of that time and space to connect, time and space to make friends, to figure out something to kind of problem solve together, because we really want you to leave knowing that you're part of a big community with lots of people that are willing and able to support the direction that you're headed in. So I'm going to talk about, I'll do a couple things in my talk. I'll try to give you all some really good information about CHWs and the science that is behind this incredible workforce. I'll try to introduce you to how we got to this point and the incredible people in this room that are behind this conference. And then I'll tell you a little bit about you and who is in the room today and what types of information you all are seeking and the way that that connects with the agenda and the day that we've hopefully tried to build for you today. So you all know this because you're here, that CHWs they connect people to systems. We have a very diverse group. Some of you are just starting out, and some of you are old goats or OGs that have been there, done that many times. But this is a bit of a level set for all of us. If you didn't know, CHWs are a global workforce and have been in existence for many, many years. There are CHWs in 50 of 99 countries across the globe. So this is a workforce that you can feel they are connected to us, and they all share very similar core competencies, roles, characteristics, and essence, truly essence. CHWs in the United States are essential, and they have been named in the Affordable Care Act. They are named in Medicaid and Medicare policy. They are seen as an evidence-based practice by some of the major scientific and professional organizations across the U.S. And there are opportunities for billing and reimbursement in over 20 states through Medicaid. And just recently, CMS has offered the opportunity to bill for CHW services through Medicare nationally. And these are just some of the things that we'll be able to hear today. So I'm kind of keeping it high, keeping it light, but you'll get to dig into some of these areas. You can't start off a CHW science conference without a definition, a working definition. So CHWs are recognized by the Department of Labor. They were recognized in 2017. They have many titles. So many of you might see yourself in this definition of somebody, or see staff that you get to work with or you hire because you want these skills in essence. CHWs are trusted people, often with an unusually close relationship with their clients that they serve. So they are able to establish that level of trust that many of us in the room who maybe are trained in health education or social work or in other spaces, nursing, don't necessarily have that type of relationship. And they have that trusted relationship and connected relationship because they have shared lived experience as that individual. They come from the community and they get you. They know who you are. They have been you. And therefore, that creates this special trust and bond between clients and CHWs. And that CHW, that essence, that trust really allows CHWs to be able to serve as that link, intermediary, that glue that connects people to the big, daunting, complicated systems that they need in their lives to be able to live at their highest level. So I'm going to use words like community health workers. That's the official definition recognized by the Department of Labor, but there's many CHW titles. And so some of you over the day will be like, oh, I think I am a CHW. And I didn't know that's all I am. So you have heard things like patient navigator. I know we have a lot of community health representatives. Those are tribally employed CHWs. Community health representatives are CHRs. Can I get a shout out? Any CHRs in the room? Boop, 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 boop. All right, cool. How many CHWs do we have in the room? Non-tribally employed. All right, we got CHWs. Sweet. You may have other names, care coordinators, outreach specialists, there's lots of different names, but the core competencies and qualities really hang you together. And we're going to learn about that during the day. I'm not going to talk about that per se. So all you need to know, you could leave right now. You don't even have to stay for the rest of the day. Just understand that CHWs have superpowers. They really, truly do. And I always use this joke, this t-shirt that I want for everybody. This is for community health representatives because we work closely with tribes. But if you can't see it, it says community health representatives. We solve problems you don't know you had in ways you don't understand. So that's all you need to know is they have superpowers and a lot of evidence behind them. So some of the evidence that CHWs have, and this is kind of a slide that we made, it's actually a poster that a lot of community health representative programs actually print out large and put in their office areas, put in clinics to really raise awareness among all folks that might be interested or not totally understand the superpower nature of a CHW. There is at least 35 years of scientific evidence, robust evaluations that have really proven that CHWs are an effective workforce and that they add value to both health and social care teams. So a lot of you know this information, so I'm not going to go through all of it, but I want you to know that CHWs in these times, it has emerged that they contribute to that quadruple aim, meaning that they not only are very effective across many different types of health outcomes, so you can think across any type of disease status. They also are able to reduce the costs of care. So that's part of that quadruple aim, reducing costs of care by addressing and understanding how to support individuals to use emergency care services in a way that's appropriate. They reduce hospitalization or readmissions. They also are able to support people in that kind of space. So there's a lot of return on investment. So any of you health finance folks out there, they contribute to this. They also contribute to the patient experience. So really encouraging that patient, making sure that they understand that they belong in whichever system that they are seeking support from and that they are able to navigate. But the cool part, and this is some of the emerging evidence that I think that most of you who are not a CHW, is CHWs contribute to making the healthcare team better. So they improve issues like burnout. When you have a CHW on your team, you have a healthier, behaviorally healthy group or team. So that's some of the cool stuff that's really coming out because everyone with a CHW is able to work at their full scope and they're able to really do and stay in the lane that they are trained to do and not kind of spread out and become overburdened and thin. So you can leave now. This is the second one that I want you to know. They have superpowers, and they truly make people know that they matter. And this is essential. All the clients that you're serving are struggling with something. And CHWs are those individuals in their lives that just look at them, see them, and say, you belong, you matter, you're important. And that's why we're going to work together to work on X issue, right? Because you matter and you belong. I get to work with CHWs and have worked with CHWs since I was 28 years old, and I am nowhere near that age. And I love it because my job as an academic, as a university partner, is a person that tries to like follow CHWs and CHW programs around all the time to document all the amazing, cool stuff that they do in a way that is believable and defendable to big organizations like CMS, right? So we try to make sure that we do that work. But the real reason why I work with CHWs is because they've helped me, you know? Their love and generosity is just contagious. It brings us all up as humans. And so what a way to have I love my job that I get to learn and follow and be influenced by that type of energy and love and commitment. So why are we talking about CHWs in northern Arizona? And I kind of mentioned it a little bit. The majority of the workforce is really concentrated in the southern part of the state, having been born from real strong leaders like Amanda Aguirre from the Regional Center for Border Health and Campesinos Sin Fronteras, and places where in the border region, CHWs, which are called promotoras de salud, so in Spanish, you would hear that, really serving immigrant, migrating, and relatives from predominantly Mexico here in the U.S. and also in Phoenix. So there's a big concentration in Phoenix. Lots of urban organizations are really understanding how CHWs can make a difference in that connected care. But up in the north, there is a real opportunity to grow this workforce. The largest workforce in the northern part of the state is really tribal. So with Navajo Nation having the largest CHW program in the country for tribal. That's 110 or so CHWs across this region. With the tribes, I know Wallapai's in the room and others that are, host anywhere from 9 to 20 CHWs. But in non-tribally employed context, there is just kind of this real opportunity, a bubbling up of CHWs that are in real need. So apart from not having the workforce up here beyond the tribally specific workforce, which is so essential in tribal communities, we are an incredibly rural and frontier region. So we're so unique in this space where we're all interconnected. Our agencies are interconnected, our clients are interconnected, and we have this real opportunity to build out that social safety net through CHWs in the region. So we're expansive in rural, and then I also mentioned we have such wonderful multi-jurisdictional partnerships with tribes. So we've got federal, tribal, state, county, city level actors all across this region that depend on each other for services. So many of you, and I know you all, many of you are working across a huge region, right? An incredibly vast region. The other reason is that we have a deficit in opportunities and spaces to get medical services. And CHWs are really essential at connecting and being able to navigate some of those services. So medically underserved areas is a real space for CHWs to be that intermediary, that glue, that link that helps to link organizations together. So why this matters for CHW, and I keep looking at Louis 6, I don't know how long I've been talking, but I'm good, okay. Why this matters, and this is this is an evidence slide, and I'm not gonna read it to you, but I want you to know that there is science behind the effectiveness of CHWs in rural areas and tribal areas. So we know that based on what I just said, CHWs have really an incredible effect in care coordination and patient navigation, and we'll be learning a lot about that today and highlighting and uplifting some of our local programs, how CHWs coordinate very complex care for complex individuals that are having to navigate multiple systems. So there's tons of evidence in that space. We also know that CHWs are effective at supporting people just physically get to where they need to be. And in this region where you're driving anywhere from an hour to 2 hours to 4 hours to a medical facility or a social service facility that you might need for yourself or your family, that is essential. So they really support that just physical getting somebody to where they need to go, not transporting them, but in that space of building capacity and supporting. They also are very essential in this new kind of terminology. Public health uses social determinants of health, and we're hearing some really good information around health-related social needs. So they can do screenings and really understand what's going on in someone's life and be able to connect them to services. They're also very supportive in and highly effective in three main areas, and this is just the three: in chronic disease prevention management, cancer screening and treatment, and maternal and child health, as well as behavioral health and warm handoffs. And so there's a lot of evidence behind them in these spaces. And this presentation, we'll make all of these available to you, and we try to make things so you can use them, like you can advocate in your own organization, like be like, this is what's going on. So I think I've got like 5 minutes left, but I think oh, thank goodness. Okay, I was like, dang, that's fast. So we'll make sure that we get this all to you, but in this, I just want to sit here for a second since I can't see that far, even with my glasses on, clearly. I need to go to the eye doctor. But that chronic disease prevention management is really essential, and where a lot of evidence is coming out is cancer screening and treatment adherence. And so thinking about all of your clients who maybe you're serving your clients for a very specific issue, but underlying they've got some health things going on. CHWs can really be part of that team to care. So this conference is really about, hopefully, getting us to think about how do we get a CHW on our team? How can I better integrate with an organization that I know already has CHWs working with them? So it's really thinking about coordination, and care coordination, as we'll learn from Megan later when she talks, is really an essential core competency. So CHWs are highly trained in how to coordinate care across very difficult systems of care where the care might just not be available. So there's some scrappiness involved in CHW's ability to coordinate care. And when you integrate CHWs into a health or social team, that is an evidence-based practice. So if anybody tries to say, well, why would I want to do that? And you can say, it's an evidence-based practice. And I always think that is a funny term, and sometimes I am flip about it, but it really comes in handy when you got to prove a point. It's an evidence-based practice. This is what science says that we should be doing. So CHWs and health and care social teams, this is just for some of you that might not be aware. Care coordination really is around integrated model of healthcare delivery. So CHWs are members of the team. So this is kind of an official definition. They're members of the team that provide coordinating care to address health and social needs. So it can be super flexible too. So we work very closely across tribal nations that have multiple departments and clinics that are in-house versus large systems that individuals have to travel to. So nothing is like perfect, right? And all the innovation that can come out of this room is essential. So what could care coordination and what does CHW integration look like here in a rural region where we're all dependent on each other across vast geographical spaces? So think innovatively in the way that you want to do and design innovative integrated care. Just as a caveat, we wanted to make sure, and I'm not going to go over this because this is something that you'll learn throughout the day, but sometimes people start to get bristly. Some of the clinicians in the room will be like, wait, what's going to happen? What is the CHW going to do? So CHWs, I'll just start with what they don't do. CHWs don't, just in case you're getting kind of twitchy, make clinical decisions. That's not their role. That is not their lane. That is not what they do. They do not provide medical advice to patients, and they definitely don't do administrative work for the care team. Okay, just heading that off. and they conduct clinical procedures or administer medication in some senses under the direction of somebody else. So that's not what they do, but what they do is enact their core competencies or their core scope of practice, which is assisting with care coordination and supporting chronic disease management, really identifying those social drivers of health and making those linked referrals and in building that capacity of your client to be able to, next time I can do that for myself. So it's not that they're doing things for people. They're working, they're accompanying, they're working together, they're walking down the path at the same time to be able to build that capacity and ability for individuals to advocate for themselves, right? That's empowerment. And Megan will go over this a lot today. So health and social care teams, this is one of Louisa's slides, so I stole it and I'm not prepared to talk about it. But basically, I think what she's getting at is we all belong on the team. And this is what maybe more of a medical team could look like. But think about your team. Think about who you want on your team and CHWs as a member of that team. So you can think about a team-based care model. And I know so many of you in this room are not clinical, and I'm not talking clinical because the clinic can do what the clinic does. But most of what goes on in our lives is well beyond the clinic. It's really what the nonprofits, the community-based organizations in this room, the county, the tribal health departments, the services that they have to offer. So this is just a reminder of that. All right, so now I'm going to get to how did we get here? Why are we here now? And this is where I get to talk about an incredible group of people that have come together across the region. And I don't have everybody's probably logos on here, but we have about a year and a half ago, we started to come together as a group, and we call ourselves the Northern Arizona CHW Network. And this is really specific to this region of Arizona to try and pull people together that might have similar common desires to know more about CHWs, and link organizations to opportunities for learning and establishing new partnerships. This is a low-key group. Everyone's invited. You don't have to show up on time. You don't have to put your camera on. You can show up late. We don't care. And you can come whenever you have availability or time. And so many of the folks that are in this room, and I'm going to have you guys raise your hands, so just prepared for a second, we're part of, making this conference be what it is. But I want to shine light on them first before you. Well, actually, I do. Maybe if you're in the room, would you like to stand up or raise your hand if you're part of the Northern Arizona CHW Network? All right, look at it. All right, cool. All right, so this is why we're here, because everybody decided that we needed to have a conference and get everybody together. So I'm going to tell you, we did some strategic planning. So we came together back in April to really think about organizational needs and readiness and really what the region, based on the experiences of the individuals that you saw their hands and the organizations that I just showed you, thought that this region could benefit from. So we asked ourselves, what does CHW work currently look like in our region? Because we know we're unique and different and special. And how do we envision CHWs being better integrated or expanded in our communities? How are we currently paying for CHWs now? So we really had to have those kinds of hard conversations, like how are we funding this initiative? And then based on all that, what are our priority areas? So when we came together, we also wanted to root ourselves, and this was really Pearl Santian, regional director for First Things First, really walked us through a value kind of seeking and strategy kind of conversation. And it was really clear that our group was rooted in some really powerful values that can carry you beyond any one grant, any one funding stream, right? So we're coming together with hope and joy and bravery and fearlessness, and and innovation, really thinking about how we can stick together and work together and overcome a lot of the barriers that we're going to be experiencing as we kind of navigate new territory. So we also thought about what does CHW work currently look like in the region, and you can kind of see there some of the outreach and education in chronic disease mainly, and other areas that agencies are currently working on. But then we thought about, okay, but what's getting in our way and what could be better? And a lot of these barriers are really around, understanding and provider admin buy-in, not understanding scope of work and fragmented referral processes. And but there's so much opportunity, around advancing the workforce. So we started to think about how can CHWs be better integrated into our communities. And we thought about this from both community-based and clinical systems, because our partnership is really representative of both clinical and community-based organizations. And we really thought through what that could potentially look like together. And we said, okay, and this is how we're paying for them right now. So a lot of grants, a lot of hustle, right? How many people are writing grants right this second? Probably at this meeting right now, ready to submit it. We get some fantastic funding through ADHS and Access, McVie. Indian Health Service is a major payer of CHWs. The federally qualifieds were starting to take advantage of the PPS rates, which we'll look later, but there wasn't a lot of direct billing for CHWs, and this is what this conference is really about. So we started to think about what we wanted to build together, and we identified goals. And some of the goals that we're meeting today is really around awareness and education, training and capacity, and that essence of coalition and collaboration, and how do we bring people together. So we were like a little group of probably about, would say there's probably about 15 to 30 organizations that can show up over time. And we wanted to that group really wanted to bring the broader groups that might not be in the fold at this point in time. So now I'm going to tell you, so that is an incredible group of people that meet monthly. You are welcome to come, and we'll put it up on the thing and you can sign up or whatever. Show up. It's on Zoom. It's really easy. You can eat your lunch. It's at 1, Thursdays at 1, right before the weekend. So now I just want to turn in my last 2 minutes is to just think about why we're all here today. And if you remember, we asked you a ton of questions because that's what universities do. We're really it's just in our nature to ask you a bunch of questions and try to figure out who you are so we can best prepare a day that meets those needs. And so I just have a couple more slides. So we asked you really about organizational readiness. And for us, CHW certification is a big deal. Do we actually have CHWs certified in this region? And about 30% of you said that you I'm sorry, this isn't certification, it's a program. So do programs exist? And about 30% of this room said, yeah, I've had a CHW program. It's been established for more than 3 years. But the large proportion of you, 70%, said you all are in the early stages. You just kind of learned about this and you're starting to identify CHW kind of essence in your teams and starting to train. And so that's really exciting. So we're kind of in that world. So we've got opportunity for growth, and we've got an opportunity for mentorship, right? So we've got those old GOAT CHW programs that can mentor or be a link or support to those new ones. We also asked you about certification. So certification is required to be able to bill for Medicaid services. And I'm looking at her, we have Karina Butters back in the back room from ADHS, who's going to talk to us about certification, as well as Dr. Luna this morning. So about 40% of you have certified CHWs, and about 40% of you don't. So we've got room to grow and explore this space. And so there is room for technical assistance. There's room for engagement with folks like ASCHW and the state to be able to advance that for you. We also asked you about engagement in Medicaid and reimbursement services. So about 80% of you were interested in this. And so that's why we've got, our folks from I keep thinking access, but we don't have access here. But we've got folks that are going to tell you how to get that going. We've got Luis is going to be talking about Medicaid reimbursement and Medicare reimbursement. We have Pear Suite here that has a beautiful platform that can help you stand up your billing process and your care coordination. And we have Community Cares here in Alex Demian, who was at Access and was our biggest champion. And now he's over at Community Cares that can really talk about how to get this kind of stood up in your organization if that's your interest. The other priority service areas, and this is my last slide, that we're going to hit in the afternoon sessions is really around care coordination, billing, financing, program design. So we've got lots of opportunities for you to ask questions and be part of standing up something that you care about, that's innovative to you, that works well in your communities. So I want to be cognizant of time. So this is my last slide. So just know that we've got a really nice, diverse group of folks here and lots of opportunity for learning. And in our the way that our conference will go today is we'll kind of stay together in this room until lunch, and we'll have lunch. And then after lunch, we'll break up into smaller groups so you can have a little bit more one-on-one kind of training. So this morning will be kind of something that everybody would benefit from, and then in the afternoon sessions you get to kind of choose, but you can choose. There's plenty of time for you to go to all of the sessions in the afternoon. So I think that is where I want to end, and I want you to know that we've tried to build in lots and lots of time again to be able to network and to, if I was telling Armando that we all have like full-time jobs and they're very busy jobs, so if you have to check email, so we just really wanted to respect the fact that you're taking a whole day out of work, so we tried to build in a really long lunch so you can like maybe check out NAU and walk around and or work. So that's up to you, however you want to go. But I'll be your MC, so I'm going to go ahead and transition to our first, what we have in this session is we want to highlight two really exciting local programs. So we have an incredible program first called Community Health in Action, but I think they have a different title, but that's the title that we were like, Community Health in Action, a health systems perspective. So some of you that are coming from the hospital or some of the health systems, this is how a health system has integrated CHWs into their work. And we're going to hear from Mark Domingo, Director of Mission and Community Health, John Gibson, Community Health Worker, and from Dignity Health Yavapai Regional Medical Center. And then we'll invite the Pathways program. So this is going to be a county-based program that is run by Coconino County Health and Human Services in partnership with the Coconino County Jail System, really supporting individuals involved in the justice system. And so we get to hear from Angelis Guzman, Pathways Program Manager, about another local program. So we'll look at a health systems perspective and as well as a county level system. And then we'll hear from Alex Demian, really to try to, he's going to try to, I told him to riff it. He's going to try to bring us together because Alex has been our #1 advocate for years in his role at Access and now at Community Cares, and really can speak from the heart in terms of systems innovations for connected community care and how we got to this point a little bit and what we have left to do together. So that's kind of what our morning will look like. So I'm going to go ahead and invite if Mark and John would like to come up to the podium, and then if any of the other speakers would like to come and sit, or you can stay where you are, that's totally up to you, and I can bring you up. And they'll each talk for about 15 minutes, and we'll try to we'll have some questions at the end. Yeah.
Thank you. Thank you, Sam. You always have these very incredible and inspiring presentations, so thank you. Tough act to follow, but good morning, everyone. My name is Mark Domingo. I am the Director of Mission and Community Health, and I'm proud to present with the very first community health worker for Yavapai Regional Medical Center. That is John Gibson. Before we dive into how we started our CHW program, I like sharing the story any platform I can. It's the Ubuntu story. There's this anthropologist in Africa, and he was studying this tribe, and on his last day, he had this excess amount of fruit, and he didn't want that to go to waste. So he called all the children from the tribe. He told them to line up on one side, and then he put the fruit basket on the other side. He told the kids that the very first person to run the fastest and touches the fruit basket wins it all. So when he said go, he witnessed something incredible. Instead of seeing a race, each of the kids started holding hands and they walked towards the fruit basket, touching it all, and they were able to win the prize together. And he was puzzled by this. He told them that, the first person could have won it all. And then one of the kids says, Ubuntu, I am because of we. How can we be happy if we know someone else is going to be sad? I love the story so much for two reasons. The first reason is that the word Ubuntu, it is a Swahili word. It means I am because of we. And there's one thing that each and every one of us here in this room, in this community, in this state, in this world, each one of us has this humanity that connects each and every one of us. And then because of that recognition, we could see each other for the talents, for the gifts, and the blessings that we bring. And those are the things that we don't hold on to just ourselves. It's what we do to push for the common good. And that is the sentiment of Dignity Health, and our mission statement is Common Spirit Health. And then the second part of the story really talks about what community health in action looks like. The older kids from that story, they had this advantage. They were stronger, they were taller, they were bigger than the younger ones. And instead of using that in their advantage, they uplifted the younger ones. They held their vulnerability and they walked towards the food basket. And that is community health in action in every means. And I think that's what we do as community health workers. We use the talents and the blessings that we've learned throughout time in the way that we serve people, and we use that to uplift other people, or very least of our brothers and sisters, and that's what we do to serve. So how did this program start for me, at least, right? It all started with meeting Maria Montes, right? We all meet people that changes our lives, and Maria changed my life where she aligned my purpose and my passion together, and soon her journey became this North Star for me. Right, I met Maria during a class I was facilitating for people living with HIV. It's a self-management, evidence-based program, and I saw this innate light from within her, the spark of joy right at the very beginning. And as soon as I started teaching more and she started coming more and more and more, that light became brighter. At the very end of that program that I taught, she came to me and she said, Mark, I want to teach this class. I want to be like you. And that's when her journey started. Right. And as soon as we developed this partnership between the hospital and the College of Southern Nevada CHW program, Maria was the very first person I had in mind. So we enrolled her to get her certificate. We enrolled her to get the expertise and skill sets, and game over. Right. This is when the journey started for her. Right. The light that I saw within her started to shine bright to the people around her. She started to transform lives. We connected her to serve people living with HIV and people who are out of care, who refuse to receive services and get care, started joining and started receiving medical health services because of her story, because of her passion, and before who she is. And she inspires me every single day for the work that she's doing. And now she's proudly serving as a North Star at the busiest freeway in Las Vegas, Nevada, in a billboard that is right over there representing undetectable means untransmittable, destigmatizing HIV for the culture in Las Vegas. That is truly inspiring. And I am very grateful that I've just been part of that journey along the way. And that is my why, and that is my North Star. So as Common Spirit Health, we make up 17 different religious congregations. We're driven by this rooted faith-based ministry, and it's always framed by the three pillar that is faith-based, meeting the needs of the people and following the signs of the times. Right? Faith has always been an anchor for us as a ministry. We're seeing healthcare get sliced and diced, and faith has always been that anchor for us to continue the challenges ahead, to fight the hurdles, and to continue serving our people. Next is meeting the needs of the people. Maria we particularly positioned her to work with people who are out of care living with HIV. And because of that magic, those people were able to receive services and get back into care. And John will talk more about our substance abuse program, working with people who present that uses substance abuse in our emergency department. And then lastly, responding to the signs of the times, being able to always be agile. We have our community health needs assessment that we have every single 3 years, and that becomes our North Star when it comes to determining the goals and strategies and what we need to continue to serve our community at its best. Now I'm going to hand the mic to John Gibson to talk more about our MOVE program and how we started this for Yavapai Regional Medical Center.
Thank you, Mark. Good morning, everyone. It's a pleasure to be sharing what I'm doing as a community health worker, or as Dr. Sabo mentioned, community health work in action. So again, my name is John Gibson. I'm a community health worker, the first community health worker at Dignity Health, Yavapai Regional Medical Center. So yeah, it's been a really fun and enjoyable experience so far, and I'm looking forward to what the future holds. But I'm going to stick this in here. All right. And so the next couple of slides, oh, there we go. All right. So basically, I want to start off with just asking anybody if they've ever seen the movie Apollo 13 or familiar with the story of Apollo 13. Wow. Okay, so a handful, great. Yeah, it's a great story, true story of history. And so there's this iconic phrase, and it's Houston, we have a problem. And they had a legitimate problem, life and death. And locally, we have the same issue, but ours is opiate related. And so I have the honor of getting to work with our neighbors who are struggling with substance use disorder, in particular with opiate use. And I just want to go over just kind of some stats. And so we're one of the highest opioid related I guess, saturated hospitals in the county and in the state of Arizona. I think we average something like 30 emergency department visits a month is basically what we're finding between our two hospitals. And we're also the eighth highest drug-involved overdose death rate per 100,000 residents. Again, just to follow that up with, we're approximately 3 to 4 times. We have a higher mortality rate than the Phoenix Valley. And there's also, and then the 4th highest rate of opioid misuse. Gosh, I should put my glasses on. Oops. There we go. That's much better. But anyway, so knowing that this problem exists, internally we have a team that's come together. That's emergency department folks, our care coordination, social workers, and honestly our community health as well. And so we've come up with this solution that we're calling the MOOD program. And what that stands for is Medications for Opiate Use Disorder. And the way the program works and where I'm integrated into that care team is so a patient comes into our emergency department, the staff in the emergency department stabilizes the patient, identifies the patient, and then if the patient is open to receiving rehab and help, they're then referred to our care coordination social workers. They come in and do an assessment. And then after that, I come in and do a lot of the follow-up. So once these people get discharged, I go outside the 4 walls, I follow these people, I connect with these people, and then make sure that they get connected to our community partners for that long-term care, not just acute care, to kind of end that vicious cycle of coming in and out of our hospital system. So we want to get them plugged into where they're getting that wraparound care and not just addressing the use disorder, but also screening them for any barriers to social determinants of health. So we help with that, connecting them with services and programs that really treats the whole person and getting them back on their feet. Oh, and then I like success stories. And so I find them encouraging and beneficial. And I think it just reinforces the work that we do is important. It works. And so one of the patients that I had the honor of coming alongside and assisting through this MOOD program. It was an elderly gentleman, isolated, living alone in his mid-70s, no family, disabled, and he was about to he'll be losing his lease in the apartment he's at in June, and lower income, and what he really needed was to get connected with the Arizona long-term care system, and that is a cumbersome application to fill out, as many of you may know. And so I was able to connect him with some resources to get that filled out so he could be basically eligible to get into the assisted living facility that he was trying to get into. So I share that just again to say that what we do, it matters. It's appreciated and it works. What we're doing works. And then on this slide, this is just covering some of the other areas where I'm being integrated into our hospital system. So at YRMC, we have what's called our Human Kindness Council. And underneath that umbrella, there's several subcommittees. And so I'm on two of those subcommittees. And the first one is what we call our CHAMP subcommittee. And that means the Community Health Advocacy, Mobilization, and Planning. And essentially what that is that's us kind of looking outside of our system into our community and looking for needs where we can come alongside and really be a good neighbor and lift some burdens and help our community out in providing volunteer opportunities of service within our Dignity Health team to go out and assist people. Within that same vein, through that same subcommittee, I'm also connected with the Weaver Mountains Health Initiative. And so there's a lot of rural communities out in the southwest corner of Yavapai County. So that's like Yarnell, Kirkland, Skull Valley, Wilhoit. But it's very rural and there's not much of a built community. So there's no resources, especially with regards to healthcare, that are readily available to these communities. And so they kind of banded together, created this nonprofit organization, and I've had the opportunity to connect with their president. And really, I became inspired because there's a lot of uninsured folks out there. So part of that, I was inspired to become a certified access application assister. So I'm trying to get people connected to insurance, and then we're also trying to come up with some ideas where we can overcome barriers to that access to health. So whether that's trying to get a mobile clinic out there or a fixed facility clinic, I don't know. But what I do know is we're looking to the future, we're working at it and trying to come up with some solutions for these folks that live in these different communities. Some other areas where I'm being integrated is community outreach and engagement. So I go to a lot of public events. I table at these events. I do provide some education opportunities, teaching just classes on self-care and health-related topics. And then I think probably going back to the CHAMPS, probably the most recent engagement aspect of that is we had a warmth and wellness event, and that was in December of last year. It was our first time doing this, and the focus was to meet the needs of our unhoused population. And in the Prescott area, I think we're a little over 300 folks. And so that day we ended up serving about 70 people, and that ranged from babies all the way up to the elderly. And so we provided warm weather equipment, clothing, as well as a soup kitchen. So we're excited about doing that regularly every year, and hoping that it will grow. And I'm sure it will. But that's just an example of engagement with regards to that committee. The other committee that I'm a part of it's new. We just started this. It's the Health Equity Subcommittee. And so unlike the CHAMPS committee, which is more external to our organization and looking out into the community where we can meet needs, this is looking internally at just stats and data that we have on at-risk populations in our hospital system. And so the three of the main ones that we've noticed are Native Americans. For whatever reason, we have a high readmission rate for Native Americans. The other one is we keep getting a lot of sepsis patients, predominantly males, 18 to 44. And then the SDOH screening, we have a lot of folks who have these needs, but the screening is it's not as effective as it could be. So we're trying to figure out ways to be better at screening folks for these needs. And then lastly, I want to touch on Unitas. Big fan of Unitas. Hopefully everybody in here is using it. But it is integrated into our electronic healthcare record system. So you go and you look up a patient, it's there. There's a tab for it. And so if they are in need of getting that referral going, we can just go and pop it in there, get the patient going, and then find a resource and then send that referral. So it's there. I'm always putting out a good word for the Unitas platform to the different organizations and people that I network with, and try and encourage them to join and to do it. Because right now the numbers are, I would say, small compared to as far as like in-network users versus those who are out-of-network users. So there's a lot of resources listed in there, which is great, but a lot of them are outside, not really utilizing it. So you have to kind of go out and around and do follow-ups. But so definitely trying to use it and encourage others to use it as well. On that note, I'm going to hand the controller and mic back over to Mark, but thank you for your time. Appreciate it.
Thank you, John. So we're going to talk super quickly about the future of CHW for YRMC. Of course, sustainability is the number one goal. I think this is something that we're trying to foster, working with our building department, working with other departments in the hospital to sustain CHW, go beyond into this braiding funding capacity into now making it more sustainable. And in an expansion of CHW role, shout out to David Barca, who's our Family and Resource Center Director. Hopefully we get some grant funding so he's integrating more CHW in the maternal child health field. Next is our Partners for Healthy Students. We have this giant mobile unit that goes into different schools and they provide basic healthcare services to uninsured, underinsured kids. And we want to integrate community health workers to serve the families and the parents as well. And then now integrating our CHW into the ambulatory space. So in the primary care setting with the doctors, how can they work alongside chronic care management with the patients that we're seeing in the medical group? And then lastly, a partnership with NAU, continue fostering that, continue building on some of the initiative that we're planning. Hopefully more funding comes across with some of the grants that we wrote and being able to support the services and serve our community in Prescott and Prescott Valley. So we want to say thank you to everyone. I'm always so inspired learning from the different experiences and being around like-minded people. And thank you for having us here.
We'll do questions at the end. Does that sound good? Okay. Thank you both. I loved how I love the vision and I love yep. And then I loved how John really explained, if you think about CHWs, and this is something that Megan will really share with you in terms of the core roles and competencies, but you could hear a lot of the competencies, right? The roles like care coordination, you got that. But did you hear also advocacy? You know, that organization, Yavapai Regional Medical Center, understands that CHWs are the pulse of the people. They know they have the pulse on the population. They have the pulse on the community people that they're serving. And so they position John, and John positions himself, probably advocates for himself, to be able to be at these larger coalition meetings where bigger decisions can be made, and that voice of the people can really bubble up into those spaces. So I think that was something that really hit home for me, John. I appreciate that understanding. So the next presenter and we're going to do a panel afterwards. So the next presenter that we'd like to invite is Angeles Guzman. Hi. From Coconino County Community Health Services. Good morning. Do you want me to put it back? Yes. Okay. I think that's good. Let's see. Do you not have slides? No, I don't. No. Okay, cool. Let me, I'll put that up.
Thank you. Like, I might need to bring this down just a tad here. Good morning. Talk about a tough act to follow. My name is Angeles Guzman. I oversee our jail reentry program here in Flagstaff. So I'm employed by Coconino County Health and Human Services, and we lead this program in partnership with the Sheriff's Office. So our team does have limited access into the correctional facility. For our community health workers to connect with inmates that have recently been booked into our jail. So how did our program start? So our program started by opioid settlement funding that became available through the Attorney General's office. So right now we are funded under 2 different grants with the Attorney General's office. And because of all the advocacy and the huge push for reentry support throughout the state, our sheriffs throughout the state have really advocated to the legislation, and we've recently been approved for legislative funding to support our program for the next couple of years, which we are very, very excited about. So why we chose community health workers? Again, because we do have a public health lens, and we know that folks coming through our jail settings have a lot of barriers, a lot of needs, and a lot of support to navigate the really complex systems that we have in our communities, and really identifying where to go and for what. We wanted to center the support that we provide people around building relationship, because they are engaging with us. This slide keeps, I have no idea what's happening. We want to center relationship building right with our folks. They have so many other organizations and agencies that they might come into contact with, like law enforcement, our court systems, our probation, community supervision systems that are telling them what to do, when to do it, how to do it. We didn't want to be that, right? We wanted to be a neutral organization that is supporting their needs and what they feel is best for their life. So again, community health workers are really at the core of the work that we're doing. They are the first folks that are engaging with the individuals in the intake setting inside of the jail and connecting with them. What we find, some of the needs that the folks that are in jail have is they don't have an ID. A lot of times they don't have insurance, or maybe their Medicaid coverage might be suspended because they were in jail. Maybe their Medicaid coverage lapsed while they were in jail. So again, they're coming out of jail without insurance coverage. And what is one of the first things we ask, right, when we're working on getting folks connected to behavioral health services, or if they need immediate connection to detox, is, do you have insurance, right? Because that really is the flow and journey on getting to the next step. So connection to access is super important. Our staff is also certified to be access assisters, so that is super helpful to ensure that folks have the coverage that they need. We're often engaging with folks that have untreated significant behavioral health needs, significant substance use needs as well. It's not uncommon for our community health workers to be engaging with folks and asking them questions in our screening, as they might be like actively detoxing or not feeling well in their bodies. So that can be pretty difficult when along with their journey and the needs that they have, they also have a lot at stake, right? That is hanging over their heads, and pretty significant consequences if they're not checking the boxes and meeting those requirements that either probation or the court might have for them. Oftentimes, and the biggest need that we find is lack of transportation. So we do live in a rural county, a huge, huge county. So getting folks back home can also be a challenge, right? Our community health workers have a system set up with Hopi Transit so that we can buy the Hopi Transit tickets in bulk and provide them to folks as they're being released to help them get back home. And again, often we see folks that don't have a lot of community support when it comes to the lifestyle, right? When folks might be interacting with law enforcement or jail systems and suffering from pretty significant substance use disorders. A lot of times they have some broken bridges with families, and so that support is often not there, and our CHWs step in pretty quickly to provide them with what it is that they need. So what we see our community health workers do on the day-to-day, again, first is communicating and building that trust in an environment that is not great, right? They're talking with folks inside the jail. There's a door in between them, and they're talking to them through a rectangle food trap. So again, very quick to build relationships with them. And they're often starting their conversations with, I work for the public health department, I don't work for the jail, I'm not a detention officer, and that can also help us in getting the information that we need so we can identify what resources are going to be best beneficial for them. They provide service connection and navigating systems. So along with maybe needing connection to Medicaid, connection to behavioral health services, primary care, we also have to balance any court order requirements that they might have, any ongoing court hearings that they have, because if they're not showing up or meeting those court commitments, then oftentimes that leads to them being incarcerated again. And so if they're incarcerated, they can't engage in those services. So always having that criminal justice lens, because our goal is also for folks to remain in the community and not go back to jail. We oftentimes are engaging with folks that might be taking medication in the jail. And so really following up and getting them connected to primary care or behavioral health services so they can continue that medication is a number one priority for some of the folks that we see. So our goal is to provide those warm handoffs to the community-based resources and services so they have what they need embedded in the community, because that's when we see that folks have the most success. In addition to providing folks with information and educating them on how to connect with the services, how to navigate the services, We are also providing folks with education. So our community health workers are having conversations with individuals, meeting them where they're at if they might not be ready to stop any substances that they might be using, educating them on overdose prevention, providing them with Narcan. We will also do a Narcan training with folks if they're still incarcerated. We can pull them out into a professional booth and bring our little nasal spray and show them how to use that so that they're prepared if they run into a situation where they might need it once they've been released. Um, Another huge part of the work that our community health workers do is providing advocacy. Because they are engaging with the justice system, they have opportunity to advocate for them when they're having that first initial court appearance in front of the judge. So if our community health workers are engaging with somebody prior to their first court appearance, if we can identify in a very short period of time of like, hey, we can potentially get this person into a detox program, into residential treatment, with their permission, we can provide that information to the judge and crossing our fingers that that can result in them being released so that they can go to that appropriate level of care in the best setting and environment for them so that they can be successful. Oftentimes, we're connecting with folks that have pending cases out of multiple different court systems. And so, again, ensuring that we are navigating that, helping them, and walking side by side, and sometimes even attending those court hearings with them to, again, provide the advocacy and sometimes confirmation and verification to the court that they are, in fact, participating in services. So ideally, they can have better outcomes in their cases that will allow them to remain in the community and with their families. Um, so again, we really value building that relationship with folks, especially when we're engaging with them in a system that often has a lot of mistrust, right? So again, when our community health workers are able to start their conversations with a community health worker, with the public health department, not with the jail, that is also extremely, extremely helpful. To provide you with a bit of an idea of the day of a community health worker, right, and what that can look like. So our community health workers come in at 6 o'clock in the morning and they have a list of folks that were booked into the jail within the last 24-hour period. And at that point, they're going into the correctional facility and conducting screening. So we're asking questions about mental health, substance use, transportation, access to primary care, housing, employment, right? All these social determinants of health that we have access to connection for on site. So we do operate a one-stop shop model at Pathways. I would invite all of you to stop in if you have the opportunity to. What's great is that because we are not inside of the correctional facility, we're in the same building, folks that have been released, we can provide them with connection and support up to 30 days post-release. So our community health workers, again, when they're coming in, they're identifying what some of these needs might be. It can look like providing advocacy to the judge that morning, and again, crossing our fingers that they get released. We find that about 50% of folks that are seen in that first initial court appearance are released and the other 50% are held. So that can get tricky, right? When we're identifying needs that people have, but they're going to be incarcerated for an unknown amount of time. So because we do operate the one-stop shop at Pathways, the partners that we have on site, like Catholic Charities, Southwest, Nation's Finest, and Hope Lives for those community-based services, they can meet with folks prior to their release to start building that relationship. And we find that that helps with that long-term engagement, even post-release. So that's been super helpful. You know, we might be engaging with somebody whose kids were removed, which was a result of the arrest, right? And so we're talking to them. They might not know where their children are, and they might have now lost their job. So we're engaging with folks when a lot of big life events have happened. And again, very, very stressful. And on top of all of those super stressful things, we add the criminal justice involvement that can be very, very scary for folks, especially if it's their first time coming through those jail doors. So our community health workers are often communicating with employers to inform them that their staff member is incarcerated, again, with their permission. We might be notifying case managers that they're incarcerated. They might have had a bed date to enter residential treatment that same day. So again, we're informing any agencies or organizations that they're already engaging with or we are working on connecting and submitting those referrals and really walking side by side them between that gap, right? We're identifying the need. They might not have insurance. They're not yet connected to the behavioral health service where they can benefit from case management and therapy and counseling and groups, but they're not quite there yet, right? And so these are times that our folks lack a lot of stability in their lives. So the ability of our community health workers to walk side by side them, they're very compassionate, patient, persistent. They do not give up until they get the answer and find the resource that they need. As we know, in Coconino County, we have a huge rural community, which is beautiful. On the other hand, we have one residential treatment program that is covered by Access in our county. So often what that looks like is reaching out to our neighboring counties to find placement for somebody that might need it right now. They might not be able to wait, 2 weeks to get into whatever programming that might look like. So again, in addition to building relationships with the folks that we're engaging with, building relationships with other community-based resources and any other partners is also equally important to our team. And again, we super value our community health workers. They are the core of the work that we do, and super grateful for them. When we have a lot of success stories, right? But we will sometimes have clients come back a few months after they've been released and come back telling our community health workers, like, I want to do what you do. Like, how can I do that? How can I get connected to peer support services? And so just another way to not only provide the resource navigation, but also that hope that there is like opportunity for folks outside of their justice engagement. It is not the end of the world. And so something that we do also value with building our community health workers is valuing that lived experience. So when we're posting for our jobs at Pathways, there's like a special clause at the bottom that really invites folks that have lived experience with substance use or with the justice system to apply for our jobs because of how much success we've seen in that, and just like the empathy and compassion and that level of understanding that brings to the work that we do at our jail systems. Thank you.
Thank you, Angeles. What an incredible program. And it sounds like as well, we think about what the power of the actual organization, the hiring organization is in the way that CHWs can really live and work at their top of their scope with all of their lived experience. And so I just want to commend both Yavapai Regional as well as Coconino County Health and Human Services, because it really does take a team of people behind that CHW, because it's not just that one individual, right? It's like these are complex systems, and I just want to say thank you for letting us see how organizationally we can be prepared to really support the CHW at their fullest. Our last presenter in this session, and then we can open it up for questions if people want to say, well, how did you do that? What was your first step? Is Alex Demian, longtime advocate, Vice President, Government Affairs for Contexture. So we'll let him talk now.
I might have to down this.
Try something. Like the millennial I am, my notes are all on my computer. So I want to make sure I have those. We have these
Oh, that's not going
handy
to.
dandy trays that are meant for your garbage, I think. So it's going to be,
I'm not sure I
Or
can
my-
get this to like a presentation mode.
that's okay.
Okay.
I think we're all friends here, right? If I don't have it in presentation mode, you guys are all right with that?
Whoops. Maybe. Possibly.
What's that? I do.
Just in case. What's going on with this?
Can you hear me? All right. As Sam mentioned, I'm Alex Demian. It's nice to see all of you. She gives me way too much credit, I think, but I have been kind of involved in this space and in this sandbox for quite a while now, so it's really an honor and a privilege to be able to continue to come up here and talk to you about the things that I'm continuing to do in the space, but also the things that all of you are able to do and to push the programs that you're administering forward, to push the CHW community forward, and to work towards sustainability ultimately for this really critical workforce that is still not as well known as I think it should be. So I'm going to go through a couple slides here and spend most of my time, like Sam is hoping, I think, just winging it, and then hopefully we can have a discussion here in a little bit for questions that you all have. So, no, my computer went black. Hold on one second. All right, so just as a little bit of background on me, Sam mentioned I spent about 7 years at Access, and we were talking about the first meeting that we had up, that at least that I was a part of, that we had up here in 2023. And one of my favorite things and kind of intros to the CHW community is, if we go back in the Wayback Machine, it was right after COVID. It was the very first presentation that I had done in person throughout the pandemic, and I was like super nervous and like said so on stage, and the whole room just like wrapped their arms around me and was like, "You got this, we can do it, we're gonna be fine, we're all in the same spot, this is weird for everybody, we've been locked in our house for 3 years." So it was an awesome on-ramp to the community, and I always love coming back here and kind of updating folks on what's going on and helping. I mean, I think that a theme of what I'll talk about today is going to be, there's a couple things left that we really have to do to get ourselves to a point where CHW programs are sustainable, where CHWs are paid what they deserve, and fully integrated into the healthcare ecosystem in a way that that you all deserve to be. But we have overcome a lot of hurdles already, and I think we're right there. And I think that that's maybe the most frustrating part, is we can see the light at the end of the tunnel. We can see what this could look like, and we've seen some successes in the community. And I'm hoping that that's what the conversations today, throughout the rest of the day, can produce for all of us. That said, I spent 7 years at Access, and then I moved over to the nonprofit technology side of the world. So I have a little bit different seat on the bus, and I figure it's probably a good idea to give you a little bit of background on what that seat is, why I'm here. We're going to be running a workshop a little bit later, and I think we play, one small part in the spectrum of what is needed for sustainability, but I think it's a really important part. So a little bit of background on the program that I oversee. It's called Community Cares. I know Unite Us was mentioned earlier today. They're one and the same here in Arizona. So if you hear about the Unite Us program, you hear about the Community Cares program, that's all us and my team in partnership with Unite Us as our technology vendor, in partnership with you all as a community, implementing that program. If we go back into the Wayback Machine again, the program started in 2019, and we administer this program on behalf of the state. And in its initial kind of, when it was a star in someone's eye before we implemented anything, Access at the time took a look at their data and said, we're not really seeing the health outcomes that we were hoping to. All this investment we're making in physical health services and behavioral health services, there's obviously something missing here. And when you look at the data, if you've seen this slide before, you've probably seen a slide similar to it that says only about 20% of a member's, an individual's health and wellness outcomes are attributable to the actual clinic visits, the actual health care that they're being delivered. The other 80% is attributed to all of these other factors that impact each and every one of our lives, right? housing, sustainable, affordable housing, access to healthy foods, access to a stable income or education attainment, any legal issues that you may be experiencing. Do you feel safe in your home, et cetera, et cetera. And this is really the bigger bang for the buck when it comes to, if we can address these things, then those health outcomes in theory are going to start going in the right direction. And that's what science is telling us is happening after all of these investments. So Access looked at all of that data and said, we're going to make some really specific investments in housing and food insecurity, some transportation, social isolation. They've done a ton of work in the justice in-reach space, and there's a ton coming for that justice population pre-release. But they also said, okay, so we're asking people to screen for these needs. We're not just asking about physical behavioral health. We're saying providers, you need to be going out and screening for things like housing. Or, do you have access to food? Do you need a food box? Do you feel safe in your home? But to what end, right? That conversation usually ended with a worst case kind of standard scenario. Here's a pamphlet. Good luck, happy hunting. We'll see you next time you come in, and see if that need was addressed, with no idea whether those resources were still valid, if they still had their doors open, et cetera. Or, best case scenario, let me sit you down with our case manager, care manager, or if they had a community health worker, amazing. Don't think a lot of providers probably had them back then, but a lot of time on the phone. Hey, do you have a food box? Hey, do you have a shelter bed? And that's kind of the issue that Community Cares was created to solve for. So in its essence, it's a single statewide technology solution to address exactly that. It's intended to connect providers with community-based organizations across those sectors, because there wasn't really a well-oiled path for providers to refer somebody to a food need in the same way that they could refer somebody to an orthopedic specialist if that need was present, right? And these needs are present probably at a higher clip than than some of these specialists' needs are as well. It's intended to streamline that referral, receiving, and ascending process, which is really, really important. And I'll get into that in the next slide as we move towards sustainability. And that's kind of the scope of where we can help the most, I would say, when we're talking about sustainability. And then it's intended to track outcomes. So not just outcomes in the individual level, right? That the idea of a closed loop referral system, which is what Community Cares is to make sure that that referring provider is able to see that the loop was closed, that need was met, and confirm that using this system. So it's really amazing at tracking outcomes at that individual level, but what it also provides is tracking outcomes at a community level, at a provider level, at a county level. So you can see who are the members we're serving, what needs do they have, what are the age brackets that we're seeing this one specific need. That's really interesting. Let's dig into that a little bit so we can go maybe back to our county partners, our policymakers, the big health systems in our community, and say, hey, we should probably invest a little bit more specifically in this need, because we're seeing a lot more over here and not so much over here. So maybe let's think about allocating those resources a little bit more specifically using data that can be gleaned from a system like this. So this slide is one that, I don't know, I tried my best to put it together to show you kind of like where in the workflow of Medicaid billing, which I know is going to be a big conversation today when it comes to sustainability, can Community Cares really help? Because you're going to need a lot of different systems, unfortunately, in order to really effectively and interact with a lot of different systems, even if you're not using it on a daily basis, in order to effectively avail yourselves of sustainable sources of income like Medicaid billing, like Medicare billing, and the like. You probably have a ton of grant portals as well. If you want to become an Access registered provider, you're going to have to deal with the APEP portal that Access has to enroll effectively. Each of the managed care organizations likely have a different system that you're going to have to enroll through. So lots of different systems, Community Cares being kind of one of those that hopes to bring down some of the administrative burden as it relates to having to kind of manually track where a member is, what services they're engaged in, what happened to them with that one housing need, maybe on a spreadsheet or something like that, which I know are a pain to juggle. And if you're utilizing community cares for the referral, receiving, and sending process, all of that is kind of taken care of automatically just by virtue of using the platform. That middle blue box is really where we come into play. I think it's really critical in this workflow because, one, in order to be a sustainable business, a sustainable practice, you're going to need new business, theoretically, right? You're going to need to find new members to serve. You're going to need to find a way to connect with organizations across your community so that you're able to continue to scale and build your kind of book of business, build the individuals that you're serving, and expand your services so that more people are able to access the amazing services that you're providing. But it's also important because in order to bill Medicaid, there's a requirement that CHWs have on file a referral from a licensed practitioner of some sort, saying that CHW services are medically necessary, and that is kind of what gives you the in to provide that service and then turn around and bill the Medicaid program or one of the health plans. So we can help support that part of the process. The other part here in light blue, we can help with within our system, but I actually have some later, really hot off the press news when it comes to that claims submission and claims payment process, and everything that is. Everything's kind of bottlenecking there is what we're hearing from the community, right? We've seen folks enroll with health plans. We've seen folks enroll in organizations enroll with Medicaid, but how do we get an actual claim submitted to the health plan or submitted to Access and get paid for it? So some really exciting news is that we heard that need. We've heard that need for the last couple of years, and we've also been meeting and coming to these kinds of meetings and interacted with organizations like Pear Suite. So we heard this need, and we started some conversations really early on with our colleagues over at Pear Suite, and we're actually now able to announce that Community Cares and Pear Suite will be moving forward with a partnership where these platforms can actually integrate with one another moving forward. So if you're using Community Cares to receive referrals as a community-based organization, you can also link it up with Pear Suite to have that information land in the Pear Suite ecosystem so that you can kind of convert all that work and all those referrals that you're receiving and taking care of through Community Cares into medical claims that can be submitted to the health plans, et cetera. I know Pear Suite offers a ton of services when it comes to helping contract with the health plans themselves, which is a really daunting task. So just wanted to make sure that, and we'll both have workshops later this afternoon, so we'll really be able to dig into the details there. But wanted to make that announcement early on today because it's really exciting and I think has been a big missing link when it comes to kind of that last mile. Specifically these two things that are not checked off, because that's what we're trying to address with this partnership. This slide, and Sam gave me the 5-minute notice like 2 minutes ago, so I'll wrap it up here in a sec. But I really wanted to spend some time here. I think I would be remiss if I didn't say we're standing on the shoulders of giants in where we're at today. There's been a ton of work that's been accomplished. And again, I think there's kind of like a futile mindset sometimes when we're like, we're so close. It feels like it's never going to happen. We've done all this work. We've been at this for a decade plus, and it just feels like it's never going to happen. And I wanted to put a slide, do my best to put a slide together to say, I don't think that that's true. We are right there. There is light at the end of the tunnel, and it's not like we haven't done anything, right? There's been a ton of milestones that we've hit along the way. This community banded together to pass legislation to create a voluntary certification and then work with ADHS to create that voluntary certification. That's the first step towards billing healthcare for services that you all provide to your communities. We had to work with Access while I was there, I had the privilege of working with this community to do a ton of different things to get all the policies in place that Access needed to in order to open up the floodgates for Medicaid billing. In the meantime, Medicare published rates and codes for you all to bill Medicare if that's a population that you're serving. And then we saw the first CHW organization successfully enroll as an Access CHW provider. We saw the first CHW organization successfully contract with a health plan. And we've seen successful referrals be sent and received throughout this process. The last two things are getting those dollars that you all deserve and are entitled to by being Medicaid. If you're a Medicaid enrolled provider delivering services to Medicaid members, you're entitled to those dollars. And there's just a couple more things to get you those dollars for the services that you're providing. Those being, we still need to see the successful submission of a claim by a CHW organization and that first organization actually get paid. I want to end this slide with saying, we have actually seen, believe it or not, success on all the things, and organizations get over the hump on all of the things that are checked off. Some of them will be presenting today. I know Sam put a bunch of time in for networking. Please attend those sessions, listen, and ask those questions. If you're interested, hopefully by now you've already been sold on the pitch that you should employ CHWs if you're thinking about it, or partner with another CHW organization if you want to integrate their services, but you don't have the capacity, time, or bandwidth to hire on a CHW. There's a ton of ways where you can set up a business infrastructure to still plug into the CHW community. But if you're thinking about it, this is really critical, and that's, I think, why we brought folks together here today, was to allow for y'all to ask these questions so that you can similarly get over these barriers that might be like right in front of you, banging your head against the wall. Man, how do I just get over this hump? It seems like it's right there on the other side. It really is, and we have seen success there. Last slide here, which look better. Like, AI is moving so quickly that, like, when I made this the first time, I was like, that's an awesome graphic. And now I'm looking at it like it could be better. So anyways, yeah, you have to get the next GPT or whatever it is, I guess. But hopefully the point of this slide still is digestible and resonates. I think a lot of what we're talking about and we'll talk about in these rooms and throughout the day and moving forward is again, how do we move towards financial sustainability? That's the end goal. And for a long time, I think we, as a, in these rooms, associated Medicaid billing with financial sustainability as like a one-to-one equal. And I don't think that that's the case. And I think we've, come around to realize that in order to be a sustainable business practice, having all of your eggs in one basket is probably not the best approach, right? Medicaid billing is a sustainable source of income. So is Medicare billing, excuse me. But grants are also still going to be there, still going to be a very viable option and resource that can be integrated and braided in alongside these other sustainable funding sources. There's philanthropic dollars, donations. You all are no stranger to the work that goes into identifying these, to monitoring your budgets on a week-to-week, month-to-month basis. I think that Medicaid, Medicare billing can really help to, buoy and raise all ships, but I don't think it's the end-all be-all. And I think that really getting to the other side of that coin will allow for, okay, so what does this actually mean for my organization? What does this actually mean? How much of an impact is it going to be? How much do I really want to go headfirst into this world and become more and more of a provider? So I think it's really critical to continue to have that conversation. We're going to have a lot of discussions today on toolkits that you can use to help yourselves make those decisions, help your organization make those decisions. So really looking forward to that. I think the last thing I'll leave with here, I know I'm a little over, is people in this room are no stranger to hard work. We're no stranger, CHWs, CHRs specifically, no stranger to hard work within ambiguous circumstances, without clear direction, and like having to figure things out on the fly and make do with the resources that you have. I really think that that's kind of what we need to do as far as the next step is just kind of go head first into this and try it and see where we fail. And then pick each other up as a community to say, oh yeah, I actually tried that too. Here's a more successful way to do that. Or I actually went through the same thing. Please learn from my mistakes. So it's not going to circumvent hard work. I don't think anybody was anticipating that getting to financial sustainability was going to be easy. But I think that just moving forward with that idea that it's going to be ambiguous and we need to not let perfect get in the way of good, but we can't let good get in the way of better as we're moving forward is going to be really critical. And I think collectively we can all get there and raise each other up as well. So thanks for a little bit of time today. I'm really excited to hear the rest of the conference and really appreciate your all's time and for the invite.
So of course we ran out of time because your MC is not, I'm not on my A game quite yet, but what I'd like to do is just invite you all to take a 10-minute break. We'll come back at 10:15 for our one more plenary session. And if you have specific questions for our speakers, I'd invite the speakers to just come up to the front, just to hang out for a couple minutes if you want to come towards and talk to them specifically. I really appreciate all of the speakers today. They really inspired me and I learned lots of new things and I appreciate you. So go take your break. There's bathrooms on that side as well as that side. And there's beverage service right out in front. Okay, well, and stop by the booths. We'll see you back in 10:15. So this is our last big room plenary kind of session, and then we'll have some lunch and we'll break out into smaller rooms. And I really appreciate everybody, mingling and talking with the previous presenters. So this mid-morning session is really thinking about some of those basics that we talked about, that we kind of highlighted in that beginning session. We will have Dr. Arturo Luna, Director of the Rural Arizona CHW Network, or RASCHOW, along with Karina Butters, a Health Disparities Program Manager at the Bureau of Chronic Disease and Health Promotion at Arizona Department of Health Services, walk us through CHW voluntary certification and core competency training. So these are the agencies that really govern and support training CHWs in those core competencies which are required for certification. And then we'll move a little deeper because of the audience's real interest in understanding how to establish a sustainable CHW program in your community or strengthen the one that you already have. We have Megan Wilson, who's coming from the city of Tempe. She is a community health program manager and has lots of experience setting up, standing up community health programs in both clinical and community-based settings. Her presentation will be interactive. She's got some fun things to do, and some of that information is on your table. And then we'll end it with my girl, Luisa O'Mara. So Luisa O'Mara is a research coordinator senior. She works at NAU, Center for Community Health and Engaged Research here in Flagstaff. She and I are partners in crime, and she is a total expert and powerhouse in the world of CHW, Medicaid, and Medicare reimbursement. So she'll kind of walk you through that, but mainly this is really about tools. So yes, you're gonna learn what the thing is, but what we hope for in this session is really giving you all of these incredible tools that have been built and developed that you can use in your own setting. So that is what this morning session is, and I will turn it over to Arturo and Corina to get us started. Thank you.
I'm a little shorter than everyone else. Oh. Yeah. All right, there we go. Hi, everyone. Good morning. My name is Karina Butters. As Sam mentioned, I'm with ADHS, so I have a couple different roles over there, but for today's presentation, I serve as the CHW program subject matter expert. So I'm going to whiz through this presentation. There's a lot of information on there, but I will be here all day. So feel free to come up to me. We can chat. I can also do this presentation within your organization if you guys wanted like a little bit more one-on-one, either with your CHW, CHR supervisors or with your CHR, CHW team. More than happy to do so. So for today's objectives, we're going to be talking about increasing the understanding of Arizona CHW voluntary certification, overview of the certificate requirements and the renewal process, resources that are available to you through technical assistance, and then connect how certification connects to Medicaid reimbursement and sustainability. All right, so I have an update for this slide. I had numbers for February, but as of yesterday, we have 852 CHWs who are certified throughout the state of Arizona, so that number is rising, and it's super great to see. And then as of yesterday as well, too, we have 187 who have recertified their certification. So for all of you who know that the CHW certification is valid for 2 years, so when that comes up, you go through the recertification process, which we will talk about today, but it's nice to see that those numbers are also inclining and that we have 187 who decided to renew and hold on to their voluntary certification. And so certification started back in November of 2022. That's when the final rules had came into effect. We also have a couple of different resources for you guys that are available. We have a database that's called the AZ Care Check, where you can kind of go and type in your name or someone else's name to see their voluntary certification licensure through the state, and it also mentions their start date and when it's going to expire. So if you're not sure, 100% sure, you can go on, type up your name, and that's where you'll see your date that's coming up for expiration. Aside from me, so my role at ADHS, I serve as the subject matter expert, and I'm more of the technical assistant, kind of face-to-face liaison that you can meet with. But aside from me, we have our Bureau of Licensing department, where they're a team who actually process the certification licensure application that you submit. So they do a little bit more of like the technical application side of it. So if I'm not able to answer your questions, they can. There's a team where you can email them or you can call them directly, and they'll help you with your application as you're going through the portal process. We also have a couple of different documents available for you. We have our CHW voluntary certification document that's available in English and Spanish, and that's a live document that we try to update as much as possible, so that way you're receiving the most up-to-date information. All right, so some reminders on eligibility for certification. So you need to be 18 years of age or older. You have to have documentation of citizenship or alien status. You have to have your high school diploma, equivalent diploma, or higher education degree, which also includes outside of the U.S. And I will say that's one area that is a little bit tricky, especially too for folks who their high school is no longer around or they may not have that certificate. So if these are some items that may be a little bit tricky, to start working on those now. Documentation of training and or paid volunteer experience, which we will talk about. And then completion of the certification application and a submission of non-refundable fees. There is no examination or testing that you need to do. It's just submitting all these documentations into a portal application and then paying the fee.
Hello, everyone. Good morning. My name is Arturo Luna. As Dr. Sam Savo just mentioned, I work with the Arizona Community Health Workers Association as the network director for the Rural CHW network. And to be honest, I'm really excited and happy to be here and see some familiar faces, some friends and colleagues that I have met through different core competencies training, digital story training, and other capacity building trainings that we have provided here in the region. So also, I want to quickly acknowledge that this opportunity, this space that Dr. Sam Savo, Luisa, Nick, and the whole team put together for us to get connected, to learn, to share our experiences, and also our challenges that very soon will potentially will come into opportunities for our organizations, health systems, and for the workforce, for the CHW workforce. And first, and as a knowledge phase for this presentation, excuse me, Corina and myself will be switching because we just divided the slides, but I want to mention about the core competencies training that is required for the certification. And as you can see in the screen, there are 11 core competencies that CHWs need to have in order to complete or in order to do their work good. And they're based in values and attitudes, in abilities and behaviors, and they go from communication skills, interpersonal and relationship building, skills, capacity building, outreach, knowledge base, and all of that you're seeing right now. But it's always tailored for your community and competent to your cultural and your background. So with that, I'd like to mention as well that the core competencies are based on the CHW National Consensus Framework, which is, you can see on this diagram, the triangle, it goes from the qualities, skills, roles that ultimately will impact the individual, the families, the community health and well-being. And this C3 consensus framework includes affirmations from more than 15 national public health organizations and professional associations. So it's really, as Dr. Sam Savo mentioned before, it's really science-based, and it's really something that every CHW, every CHR needs to have and to know in order to complete effectively their work. And at ASHA, we provide a 20-hour comprehensive training that is available in both in-person and virtual. This virtual version is live online. And since ADHS endorsed this certification training program, every individual in the call has to have their camera on because of ADHS and our guidelines, and be participating and collaborating throughout the course. This is an interactive and skill-based learning approach. It's delivered by certified CHW master's trainings, and if you want to request a training or learn more about the upcoming dates, you can always email Leonarda at asha.org. Leonarda oversees the CHW Institute of Excellence at our organization, and she can offer more help. But also, I want to mention that recently, Arizona Complete Health, the health plan, provided us a sponsorship to deliver a virtual training back in December 2025. And it was a great training for the Northern Arizona region, where we had 25 participants really engaged, really knowledgeable. We really enjoy having the training with all of them from different organizations. I'm seeing some familiar faces, as I mentioned before. And yeah, with that 20-hour training, they are set to get the certificate and then apply to the ADHS certification. Along with that, every individual needs the diploma, the high school diploma, in order to apply for the certification or a higher education degree. Documentation from countries other than the U.S., including Mexico, are accepted as long as the department can clearly identify the document as such. In some cases, the applicant will receive a request for information. That means that they need more information to collect and see if actually you have the high school diploma in other country, or if there are any other concerns within that department. If the high school diploma is not available, the individual can always get the GED, the US GED. More information can be found on the GED Testing Service website. And this resources list for GED support is the Rio Salado College offers in-person and online GED preparation in English, and Chicanos por la Causa in Spanish and Espanol. So, and Friendly House, Avid, Wilson School District. So these slides, you will have these slides for you to review after, and perhaps review the information and get these resources for you all. Okay, I move on to Corina.
All right. I just dipped out on that last slide. I was like, okay, it's Arturo's turn. So CHW is certified in other states. So we do reciprocity within Arizona. So I've had CHWs come from like New Mexico, Nevada, from other states that have had licensure and they want to come to Arizona and be certified here. So we do accept that. They need to be certified in that other state for at least 1 year in order to qualify for reciprocity, and they need to provide either a copy of that certificate and also an attestation form. So it's a little bit less tedious than the actual initial application process. So if you have any CHWs who have questions about that, you can reach out to me and we can walk through their specific scenarios. So documentation and training and experience hours. This is where the process does get a little bit tedious as far as documenting all of the either paid or volunteer experience that you have had in the past couple years before you apply for your certification. And in order to apply for a CHW voluntary certification, there's 4 different pathways that you can take. And again, I'm gonna whiz through all this stuff, but if you have questions later on, you can reach out to me or come chat with me. So for pathway 1, it's either 960 hours of paid or volunteer experience, providing CHR or CHW services within those core competencies that Arturo mentioned, specified within the rules and completed during the previous 3-year time period. So if it's before that, it unfortunately will not count. Pathway 2 is completing a CHW certification program that includes core competencies trainings that's provided by an accredited college. So some colleges do offer CHW training program courses that you could take, and you can use that to become certified. Along with that, you'll also need 480 hours of paid or volunteer experience, again, within that previous 3 years. Pathways 3 and 4. So pathway 3 is completing a CHW training program provided by an organization, which is usually ASCHW. Number 3 is pretty much our easiest and top way to go when you're providing your application, and ASCHW is one of the main agencies that does provide this training for you. And then along with that, you have to either pick 480 hours of paid or volunteer experience within that 3 years. And then for pathway 4, this one is specific for CHRs, completing a CHR national training program that's provided by IHS, and either choosing basic training program and 480 hours of paid or volunteer experience within those past 3 years, or choosing an advanced training program and 380 hours of paid or volunteer experience. And so in order to go through the process, you only have to choose one of these pathways. So whichever one is easier with the experience that you have, that's what you'll use to move forward. So this is just a couple screenshots of what the documentation looks like in your portal. So you'll go to AZDHS website, you create your portal on there, and that's where you go in and you start submitting all of these documentations. Again, if you want to have some technical assistance with that, let me know. We can walk through that, or we can also connect you with our licensing team who can help you with that as well. These are some of the documents that you have to fill out: the attestation form, your paid voluntary hour form. Again, it's very tedious to fill these out, and sometimes CHWs have so many hours that they need multiple of these forms, just because the spaces on there are a little bit tiny. So application certification fee, it used to be that there was a $1 option fee, which is no longer available as of June 30th of 2023. We do have a fee waiver form for those that are applying for the very first time. So if you have not got your CHW certification yet, we do have a fee waiver attestation form for those who are do not exceed 200% of the federal poverty guidelines, are an active duty military spouse, or if you're an honorably discharged veteran no more than the past 2 years. So if you qualify for one of those items, you can sign this attestation form and you will pay $0 for the very first time that you're completing the CHW voluntary certification fee. When you go to recertify within the next 2 years after that, you unfortunately will have to pay the fee because, again, this is just for the very first time. So documentation of experience hours. So as Dr. Luna mentioned, sometimes you will get a notification saying that there's a request for more information or something's not filled out correctly. That does not mean that right away that you're denied for your application. It just means that there's something that's missing or they need a little bit more clarification. And we have a live licensing team who will work with you guys through this process. If there's anything that you guys may have questions on, again, you can reach out to me. So maintaining your certification. So again, it's valid for 2 years, but during that time, I want to caution you guys to kind of start working towards that process if you are interested in becoming recertified, because the main thing that you need is 24 hours of continuing education hours. That is the part where a lot of CHWs are becoming a little bit nervous about, because what is a CE? What is a continuing education hour, and what qualifies as you're becoming recertified? I do hear a lot of times like CEUs, it does not need to be an actual continuing education unit itself. It's more so of training just to make sure that you're continuing doing the training that relates back to your core competencies. And so when you're recertifying, it is a $200 fee, so your initial application is $300. When you're renewing it, it's only $200. and it's a little bit less tedious with the application process. You're only paying the fee. You're submitting an attestation form saying, yes, I have done the 24 hours of continuing education, and that's it. So again, I'm going to breeze through this one. Continuing education courses, what counts as a continuing education for those 24 hours is training that has directly relate back to the core competencies of a CHW that relates to services, skills, knowledges that facilitates access to quality of care delivery, health outcomes for clients receiving services, expands health and wellness in diverse communities to reduce health disparities. 2, it can have educational objectives that exceed an introductory level of a knowledge related to health and community services. Or 3, which is the easiest one, it relates back to the core competencies. And that's pretty much one of the easiest ways to go about it. If you look at the core competencies and you know that training, yes, promotes health promotion education, it most likely counts. But if you have questions, reach out to me. Some approved education courses that are already available. This list is also on our website, and like Dr. Luna said, you'll receive this Excel sheet or PowerPoint, so you'll get these as well too. These are some of the agencies that have the training courses available. The only caveat is they don't specifically list that out. So if you go to their website, it won't say that this is a CHW, CHR specific training education, but again, if it relates back to the core competencies, it's probably safe. Some other ones are trainings that I have been able to endorse. So if you see a training that comes up that says this training has been endorsed by the Arizona Department of Health Services, it's more than likely that I've reviewed it, I've taken a look at it and said, yep, it does relate back to CEs, you're good to go. These are some additional ones. Any CE course that's offered by an accredited college, any that are approved by a training program that has gone through the ASCHL CHW training approval process. So there's a couple agencies listed out there. And then again, the ones that I've been able to endorse. I do want to throw out too, if you guys have trainings within your agency, trainings, webinars that you do think that will meet towards a CE requirement and you want to get it endorsed, reach out to me. I can very easily, again, go through the materials, provide that endorsement, and then you're able to not only provide that to your CHWs internally, but also to your external partners as well. I think it's ready.
And I'm not, excuse me, I'm sorry. I'm not spending a lot of time on this because I think Sam and Luisa will talk about it, but why certification is crucial and very important because it's the backbone for these sustainability efforts that organizations and health systems are trying to implement. So ADHS certification enables organizations and CHWs to participate in the access Medicaid reimbursement, as Alex Damian mentioned it before, including the billing for education, outreach, and care coordination service. And CMS, after the CMS approval, the Access State Plan Amendment in 2023 became effective on April 1st, 2023. And after that, in 2024, Access has established a new provider type called CHW organization. This type of provider allows community-based organizations, localities, tribal agencies, and other institutions or health systems that are employing CHWs or CHRs to enroll with Access and be eligible for the Medicaid reimbursement. So that's why it's very important to have this information and go through the process of certification. And again, you are talking about this. Yeah, Access 2 pathways for billing. One is through the access provider type. In this corner, those are the access provider type, behavioral outpatient clinics, providers, physicians. But the other one, and that's the one that we're trying to get more people, more organizations informed, is billing through the CHW, CHR community-based organizations, where CBOs has to become Medicaid enrolled provider. And then with their certified CHWs providing services, they can actually bill, submit claims, and successfully bill. These are the reimbursable service codes that Luisa will take during this conference, but these goals are for education and training for patient self-management by a qualified non-physician healthcare professional using a standardized curriculum, providing this type of training or education face-to-face to patients, could include family members or caregivers, and each built in 30 minutes increments. And it's the 98-960, 98-961, and 98-962. The last ones, the two last ones are for groups, small groups of people, and the first one for education and training for an individual. And you can find more of this information within this link. Now, ASHA and RASHA resources. ASHA provide the core competency training, as I mentioned before, with the ADHS certification alignment and workforce sustainability priorities used across the state for CHW programs. Also, we provide capacity building initiatives, strengthening CHWs and CHRs in health systems through core competencies, specialty trainings. Not only ASHA does not only provide core competency training, but also capacity building in different topics, self-management, chronic disease, behavioral health concerns, and all of that. The majority of our trainings are endorsed by ADHS and counts towards the continuous education credits. And also we provide technical assistance and try to talk and meet with different organizations that are willing to expand or implement CHW programs to kind of see what the level of understanding and readiness is to move forward in towards the sustainability and CHW's reimbursement. And this two graphs talks about the training and education that we provide as a network, the CHW certification, the capacity building, the Medicaid and Medicare, which is really important as well, and the rural CHW integration tools that we have developed, and we have partnered with different organizations to really implement, and it's like food for thought for organizations and health systems to get the buy-in of the CHW work and implement CHW programs, and then move on for sustainability. If you want to scan our QR code to join our listserv, please do, and also you can join the RASHA monthly meetings where we usually are providing information, advocacy information, training and education for different organizations and health systems around the state, but one of our focus areas is Northern Arizona, so that's why we're really happy and excited to partner with this group at NAU. And this is the list of resources from Corina, the ADHS, from the Special License and CHW department, and the ASHA website, the approval process for CHW trainings, and all these resources that are available to you. So with that, I'll move on to Q&A section.
And then really quickly too, I just wanted to note, so that's my email above, Dr. Luna's email, and then below that's the Bureau of Licensing Department. So again, if you had any specific questions you wanted for the application process, there's their email and then the phone number as well.
Yeah, and also, okay. Really quick, we just want to mention that ASHA has some funding for scholarships to cover the certification fee. At the table, there is a list for you to register and apply. It's an application process, but these funds are available for CHRs, so they are for you. Go ahead, please.
I just have, for the continuing education, it seemed a lot similar to if you have a CDA for childcare, like we have to do continuing education. It's not necessarily a formal CEU, but you have to get educational hours. And they have the Arizona Early Childhood Workforce Registry where you can find trainings. Is there a plan to potentially do that so that people can find them?
There is. So I'm currently updating the ADHS CHW volunteer certification website that we have. So I'm hoping to have a list like that where you guys can go and easily click on links that are available by their topic. So that's soon to come, but it's going to take a while,
Okay, I
unfortunately.
was curious if that was in the,
Thank you.
where the direction was going. Thanks.
Hi, this is Mark from YRMC. When is your next training?
Really good question. We don't have yet a set date. We have 2 upcoming trainings for Tuba City Regional Healthcare Center. One is in May, and the next one it will take place in June 2026. But for more information about trainings, you can always contact us and we can talk.
Thank you.
And quick reminder about the CHW, about the scholarship for the certification. You can start your application at the ADHS website, and then when you have questions, and perhaps if ADHS hasn't responded yet, we can provide that technical assistance to you, and also we can, if you got selected through the application process for the scholarship, we can make the payment within a virtual Zoom call. Then you all set.
Any other questions? All right. You also have some flyers on your guys' table. So one is the initial application process checklist. So it walks you through the step-by-step process of becoming certified. There's also the fee waiver requirements as well too that are on there if you're able to be eligible for that. And then the recertification process flyer as well.
Brooke has a question.
Oh. My,
Oh, yeah, of course. You have to remind me the dates. ASHA has the Roots Conference, its annual conference that will happen in Phoenix, June 24 to 26. This is the 25th anniversary of the organization as well. So you are welcome to visit our website to get more information, buy your tickets. Scholarships perhaps will be available in the upcoming weeks, but please go to the website and see more details for the Roots Conference. It's a really good space for everyone, CHRs, CHWs, allies, educational institutions to come together to connect and to move forward within this space of the CHW movement. Thank you.
Thank you so much. And just a reminder, ASCHW, for some of you that are new, ASCHW is the professional association, the statewide professional association for community health workers here in Arizona. We talk in acronyms a lot, but ASCHW is really fundamental, and that conference is really a really beautiful professional development opportunity networking for CHWs, so that's really great. And then ASCHW will have a booth outside. So I'm going to bring up, now we know about certification, and now Megan's going to clear up every single doubt you have in your mind about how to establish a sustainable CHW program. And this will be interactive, and there's some things on your table that she'll mention.
If I walk around with this mic, is that going to be a problem? Okay. I don't know how to stay still, so. All right. Good morning. How's everybody doing? Feeling good? Everyone want to get up and stretch for a second? Move a little bit? All right. I'm going to make you play today. So I'm a big believer in trainings that help us learn and are interactive, so hopefully we get some of these things done. So my name is Megan Wilson. I am an MSW. I have worked in healthcare field in a lot of different ways. I started in behavior health, then worked for a managed care organization. At the time was Ariba, so back in the day. Simpatico, now Asian Complete Health, and they're here today. And so I worked with them on developing programs throughout southern Arizona, really active in Yuma and Nogales, some areas in Sierra Vista and Bisbee. So I was down there developing programs and really trying to focus on overall health, and then got the opportunity to work on integration of care for the Department of Child Safety. So I went to the state government for a little while and then worked with them on getting integrated care program models, and then went into quality and process improvement, which I know sounds very exciting. It is a lot of spreadsheets and a lot of ways to develop some really good outcomes for folks. But so you'll see in my training today, a lot of the stuff I'm focusing on is how do you really focus on the outcomes of your programs, and so you can sell it to managed care organizations and or other medical providers. It's like kind of making sure we're speaking each other's language and that we can really get those points across. I then went to TCAA as the director of programs over there and oversaw 8 different programs, and which was the first time I got my introduction to community health work. And I was just unbelievably impressed with my community health work team. They had all been community health workers for some of them 20 plus years, and some of the outcomes we had, and that was our Health Start program. So I'm sure some of you are familiar with Health Start, a statewide program that helps it's prenatal and postpartum care. And in our specific program, 98% of the babies were born at a healthy birth weight into that program. So it's a really good marker for good health care, good engagement. Almost 100% of our babies were getting their vaccinations on time. All of our moms got their prenatal and postpartum depression screenings. So those were just really big markers, and it helped us sell our program and get it noticed by some of these big medical plans. And then I got the opportunity to move over to the city of Tempe because they decided to use their opioid settlement dollars to create a community health worker team that responds to high utilizers of 911. And so we just launched in February. So I've had to sell a couple different programs to a couple different people. And so we're gonna talk about some basic things, some ways that I've seen some communication be helpful, and if you have questions, please ask. Here's my agenda. All right, so I'm gonna ask you guys to do a quick icebreaker at your table. Again, movement, talking, I think it's good, get your brains moving. So for this icebreaker, I'm just gonna ask you to go around, and if you all know each other, cool. And then talk about one thing in healthcare that has been a disappointing experience. You go to just one, yeah, sorry. One, and then one that has been a positive experience. All right, you have 7 minutes, go. All right. Thank you, everybody, for sharing at your tables. Do you want to shout out some words that maybe were similar or matched when we're talking about negative healthcare experiences? Use your shouting voice so everyone can hear you, please. Exhausting, yes. What else? Yes. Especially when you have no other options. Yeah, amen. Anything else? Lack of communication. Yes. Sometimes when you work on these things, are you ever like, if people didn't have a representative or know how to navigate this at all, like what? Where would they be? Would they even get healthcare? All right, what are some good things? Some good experiences? Yeah, community health workers. You got the point of the activity. Yes. Having an advocate, someone to wade through really difficult stuff, especially if it's a shocking thing that you're going through. Your brain can't always function as high as you want it to. Yes, yes. Also love those things. All right, well, thank you. So I hope you keep those in mind as we're walking through today, and then especially when we get to your activity. All right, so I'm not going to bore you guys with the history of community health work because I'm sure most of you know it. But I wanted to talk about this because as someone who started programs and had to advocate for programs when people don't understand what community health work is, it is important, especially when you're working in government, to know some important timeline things and just to really establish the credibility of community health work. And so knowing that it's a recognized profession on a federal level as well as a state level is really crucial, that it goes back into like the 1950s and probably later than that, in different cultures all around the globe have different practices for community health work. So this isn't necessarily a new idea. It's just finally everyone's catching up and respecting the profession and giving it the attention it needs, right? So when you're building plans or you're having conversations with people inside your organization and maybe they're not quite sold on something, can always be a good space to start and give you a little bit of background data. So you'll also see on your table this wonderful, colorful thing that I created. What is this? What are these? My community health workers in the room? Core competencies. So also a thing to share with people in your work groups if you're having conversations about adding programs or how you want to sell providers, if you want medical doctors to work with you from different clinics. This is all really important information. Lean on what already exists. I went to ASCHW and got this information and summarized it in some language that the city of Tempe would appreciate. So you'll see, and on the front, it looks like this, and on the back, there's definitions of the different core competencies and the skill sets that community health workers bring to the table, and just really focusing on breaking down these things. Because sometimes when we've been in the field for a long time and we are community health workers, we haven't had to explain it to anyone for a while, except for maybe our clients. But we have to, when we're really trying to sell our program, these elements are super important. So just some helpful language and unifying language, because again, this is already the core competencies. If we all use the same language, we will also help build recognition in the field and amongst agencies, right? Like if we continue to weave the similarities throughout our programming, it will really help everybody as a whole as we try and grow this programming throughout the state. So the other thing when we're talking about developing programs is defining our client base. So when you're working at different orgs, there's a lot of different people you work with, I'm sure. And so as you're developing programs or you're thinking of what do I want to focus on, what does my organization do really well, I would say look at your demographics, right? Pull those reports. Who are you serving? Which ages are you serving? What are the most common health concerns or issues that folks are coming to you with? Also, are there any reported gaps in your community? Are there things that you are hearing? Have you done a needs survey to see what does your community actually want? And so tying those in. And then last but not least, who and what health plans are they enrolled with? Because that will also help you advocate for different programs, know who to go and talk to, and have conversations with. So just collecting this data is really important, and it is kind of like a game Guess Who. If anyone got that reference, yay. All right. So when we're talking about creating this base, we want to know what programming do we currently run, and what programming are we doing really good at? What do we run well? And then what populations have we moved the needle on the most? So when I was talking about the community health worker program at TCA, we had community health workers that worked with Health Start, and then we were like, wow, we do this really well. We're going to start community health workers in our shelter, because we ran a mobile shelter, and this could be an opportunity for growth. We learned really fast what we didn't know, because we had never set up a community health worker program for shelter clients. And guess what? It's very different than your pregnant clients that have housing and that are a little more stable. And so we had to do a lot of research and what we did well in the shelter. So things we did really well in the shelter, we're connecting them to healthcare. So that was a good start. We also helped people get employed. We had a really high employment rate in our shelter. And so how do we utilize those outcomes to build a community health program? And why is it important that people get employment beyond money? We all need money, right? But employment also can affect confidence, and it can help with your overall well-being. It can reduce social isolation. And so when you start like expanding it and saying, okay, we do those things already, so how do I connect them to a community health worker base? And then how do you prove it? So this is the other piece that's really important, especially when you're talking to anyone in healthcare, right? And I'm sure we all get annoyed because they're like, what's the outcome? What does your data say? And so even though we know we're doing good work, we get the feedback that we're doing good work, we have to have numbers. So looking at that, you'll see on your sheet, there is a logic model. I'm a huge fan. I taught this at ASU, so that's why you guys get a like mini lesson in reminders of logic models. I'm sure everyone's a little bit familiar, but I do think this is important, again, when you're trying to define your program, because you want to sell, you want people to buy into your program. You also want to ensure that you're developing quality metrics and outcomes and outputs. And so this is a really good model of how you can fit any program you work with. You should be able to fit into a model like this. So the first thing you'll have is inputs. This is what are things and people and places you need. So when I was talking about our community health worker in the shelter, we were saying, we needed a private space to have conversations with, and because we actually utilize churches, and so not every church gave us a space to do that. So it'd be okay, so where can we do those things? We needed money because we had to hire a community health worker. So we added that, how much admin time, all of that went into those places. And then what activities are you exactly going to be doing? I think this is really crucial, especially when you're going down the healthcare billable, sustainable route, is what exactly are the activities that you plan on implementing with the clients that you're meeting with? So yes, you might do some in-office intakes. You might do some home visiting. Are you doing group classes? What type, are you using a specific education model? And those are all the things that you would put here, including if it's we'll use deep curriculum, right? So if you're going to use deep curriculum, you're going to put that in there and say how many sessions for how many people, because those are the activities you are promising you will execute on. And having some kind of definition is really important, because if you just say, I'm a home visitor, healthcare will go, okay, and so they want details. They want to know what assessments you're using, if you're using intake tools, how are you measuring those things? So what are those activities that you'll be doing? And then you have outputs. And I'd say this is probably the most confusing part of a logic model, output versus outcome. So our output are the things that are leaving the program when they're done, right? So it's the how many humans do you plan on working with? You can also put the amount of activities you're doing here. You can also, so you can say how many sessions you plan on executing per person. Is there going to be a limit or time limit? So for our new program with the CHW, there is a time limit of we're trying to keep everyone there under 90 days. And so then you have outcomes. And those outcomes are more based on improvement and quality. So outputs are those bean counting things that you just have to say, look at how great we are. We're getting to this many people in the community. And when you get to outcomes, you're saying, I'm making this many people's lives better, right? What are you measuring to say my life is better? Are you reducing, again, that reducing social isolation? Are you, how many people are connected to a PCP? Do that one. Everyone do that one, because you know who loves that? Managed care organizations. And so you want to get connected to primary care. You want them to go to a certain amount of medical visits. What is it that you're exactly getting them, and what percentages of success are you going to have? What is your bar? And so I know you'll see the example for the one for our City of Tempe program. And those outcomes, I will say, we came up with them, and then I had to redo them a lot of times, because I was like, this makes sense. And then I got a bunch of questions, and I was like, okay, I have to be clearer. I'm not clear enough. I have to say within this many days. So now a lot of our goals say within 30 days, within 60 days, within 90 days, because that's what people also want to see is what is the impact you have and the amount of time that you're given. And so you can really work on those different pieces. So here's that model. So you'll see for our home activities, we do home visits, we do advocacy with medical providers, we do referrals to community-based organizations. That's a big one for us. We have internal referrals within the city as well, community education. There's all the stuff our community health workers are going to be doing. Because I had to sit down with Tempe Fire and Rescue and tell them how this program was going to be good for their clients. So what happened was Tempe Fire and Rescue asked our team if we could develop a community health worker program for their high 911 utilizers. Right, because right now there is a problem in the city of Tempe of people calling over and over and over, and then the call response time increased for the fire department, and they didn't want that. They want it to be quick and fast, and they want to go on the calls where they're, life-saving measures for someone having a stroke, not for the guy who called to get his remote picked off the floor. That was a thing. So it was, how do we work on some of these high utilizers? Can community health workers do it? And so I was like, yeah, I think so. Seems like a good population. And so putting this together for them also gave Tempe Fire and Medical Rescue a better understanding of the actions we can do, what we can do, what we can't do, because I also had to explain, we're not nurses, right? We can't go in and I can't do blood samples and things that maybe they were wanting at first. And so I was like, we gotta reassess. And so we got our activities down, our outputs in there, and some of our initial outcomes. And then we have our intermediate and long-term outcomes, which are just big dreams. Hopefully we make a difference in big ways. And we are learning with the data we are collecting how to show cost savings, because that's what the big piece is right now, is if I can show cost savings, I can hire more staff. So that is some of the other piece we have here. Any questions on this logic model? Yes, so it should be, we use the prepare social determinants of health. That's a good call out. It probably needs to be in our activities a little more clear. So when we do our needs assessment right now, we do a social determinants of health, the prepare exam, and then that will help guide some of the things that we're doing. And then that really connects to, so one of the big goals we have is that we are supposed to be a critical intervention model. So we really can't hang on for longer than 90 days. So one of the cool things that we also got to do as we're working through this process is we're partnering with Contexture and Unite Us, and then also Unlimited Potential, which is a community-based org that does community health work, and that is well known in our area. And so we are using the Unite Us platform to ensure that we have referrals from, once we stabilize our folks, then we will refer them to Unlimited Potential, and they got some grant funds to take on our clients so they could provide longer term care. So this is one of some of that partnership stuff when you're talking about creative ways to develop partnerships. That was one of the things that we were able to facilitate. So, because also, Unlimited Potential already does deep classes. They already provide great community education. My community health workers don't need to do that. So if we can just be that stabilization time, and so that's why the community-based referrals are so important in this one, is because we're going to get other orgs to come on for a longer term intervention, is our goal. Any other questions? All right. Are you ready for the activity? You got 15 minutes. So you're going to be in your groups. You have a blank logic model on the back of the sheet. So I'm going to challenge you guys to, in your group, pick a program. Maybe if you guys all work at the same program, or if you have different programs that you know about, and try and get your program to fit into this logic model in 15 minutes. Let me know if you have any questions. Go. All right. Who has questions? You are all experts at logic models? No questions? All right. Well, I'll share some of the questions we had up here. We talked about funding resources. So if you work with different populations, understanding what support they have in different areas. So if you work with like folks who have developmental disabilities, you want to make sure that you're not double dipping into coverage that comes from DDD and healthcare. So making sure you make those kinds of initial separations. Also, trying to really stick with a theme. I think sometimes it's like we all know community health workers can do it all, and it is expansive, and like we have so many skills, but that is not always helpful when you're trying to pitch a program or you want a provider to buy into what you're doing. So you want to try and be as specific as possible and having those really like time-oriented outcomes. All right. So just a couple of things. This is some, yeah, no question. Okay, 5 minutes, great. So I'm gonna go through this really fast. I'll be around today if you have questions, because it's gonna be like speed lightning round access. All right, so these are Access's quality strategy goals, which I think is, again, important when we're talking about how do we sell our programs, how do we get buy-in, how do we connect to these pieces. So when you're looking at some of those outcomes that you're developing, this is the big, broad thing to focus on, but this is what programs, when you're talking about, I want to bill, I want to create a sustainable program, this is what they're looking for. So if you can always connect your measures back to something like this, it's super helpful. We also have, if you are looking at starting a relationship with managed care organizations, which again, I'm super excited that Arizona Complete Healthcare is here today, you have to do a letter of interest. And so the one cool thing about the logic model that you just wrote, and if you want Access to buy into your program and say, hey, yes, we need this in our network, you have to do a letter of interest, and you can outline those details in the letter. It's important that you review that specific health plan's goals. So if you're trying to work with them, you can go on and see do they have a specific population that they're really focused on? Like I happen to know Arizona Complete Health is taking special interest in elder care. So how can I gear some of my stuff that I already do towards their interests? You can adapt a letter for each health plan that you apply for. And also, this is important, they don't need 3 pages. They want it to be like very succinct. They want it to be clear. They want to understand exactly what you were doing. So that's why I was saying, like, when you use some of these logic model elements in your letter of interest, it is helpful in maintaining attention and being direct with your intentions of what you want to bring to the network. Because remember, when you have a network of services, they need to make sure that, like, this doesn't already exist. They're going to want something new. They're going to be excited about it. And then they will also help refer to your program. So this is some other things that you need to make sure you have when you're doing a letter of interest. So if you haven't worked with an MCO before, these are all the things you want to make sure are included, that you will collect ahead of time before you put in that interest, so you have it all ready to go and presentable. And then once you get the letter of interest and they're like, hey, yeah, you sound cool, you get your first date. So you get to have a meeting with the MCO, and like I said, it's your first date. Sell yourself. Talk about all the amazing things you do. You want your best information. You do not need all the details, right? You want it to look awesome. You have, like, this is marketing 101. So you have to really market yourself. I've been in these meetings, that's why I'm telling you this. Like, I've been on the receiving end of getting to say, like, yes, we want this provider in the network or not. And I can tell you, when people come and they come very prepared and everything looks nice and legitimate, I'm like, great, let's go. And then I've had other people come with, like, the brochure they printed off the printer right before they got there with spelling errors. And I was like, nah, brah, we're not doing this today. So make sure that you have these professional elements, that you also have your defined population and demographics in this material, because you want them to know who you're working with. Stick to your talking points that you included in your letter of interest. Again, that whole element of, like, saying succinct is super important. And then how are you going to improve their network of care? How are you going to work on their quality goals? How are you going to focus on what they want to see improve? Also, you can use these things when you're trying to make relationships with providers. So one of the things you'll hear today is that to bill services, you have to have relationships with a medical provider, licensed therapist, someone who can refer to your program if you don't have them on site. I understand that some have them on site. You can also partner with FQHCs, because FQHCs can't always bill for community health work, or they can't bill, it's included in their per PMPM. So make partners with FQHCs and say like, hey, when you see someone come through, refer to our program. And we can be great partners because then FQHC outcomes grow and our outcomes grow. Providers also get incentives, especially when you're talking about some behavioral health providers. They have value-based purchasing. So if they have good outcomes for their clients, they get incentive pay. So one of the things that you can look at is if there is a specialty area that they're focused on and you also can aid in the improvement of that area, there's a conversation that can happen. Because again, you will be incentivized because you will be able to bill, and then they will be incentivized because hopefully their rates go up or maintain because they're doing quality work. The other thing I will promote is Unite Us using using that platform. I will say just for ourselves, tracking those referrals are also really important. Part of social determinants of health is connecting to the community orgs and other locations. And if you have a space that you use and that access supports and that all the health plans want you to utilize, it's also seen as a positive engagement. And there are now, you can get all different kinds of referrals and go back and forth. And I will tell you, after use, I will be honest, Alex knows, I fought using Contexture for a long time. I was like, I'm not gonna do it. This is gonna put more work on my workers, no way. And then we did it and I was like, all right, it's not so bad. And so it really didn't add a whole lot of time to our work. And it kind of looks like Facebook. It's really easy to navigate. And so our staff were like, okay, Megan, fine. And I got to incentivize them a little bit with how many referrals they completed, yada, yada, yada. So that is all. Any questions? I am not an expert in FQHCs, but I will say I do not believe they can do any additional billing for community health work, even if it's in a different location. It has to be a different organization. Yeah, per definition and the other thing that we'll be going over today.
At all your tables for lunch. We've already tried to corner her up here to stand up a program locally, but please find her and you can kind of grab her and she'll help you think through. She's very knowledgeable. So now you all know how to certify your staff and engage CHWs in certification process. And now we've gone over how to lay out exactly what you might be able to do and where you fit in collaboration with other organizations. And now Luisa O'Mara is going to talk through some of the tools to turn on billing. And later in the afternoon, we have some fantastic conversations with Pear Suite, which can aid in this. But this is kind of the 411 on how, what are the tools that exist currently for Medicaid and Medicare. And she'll have a fun activity where it's called Show Me the Money. So get ready.
All right. Oops. I think that was me. All right. Okay. Hello, everyone. Thank you for coming to our conference. So I'm going to be talking about reimbursement opportunities through both Medicaid and Medicare, though a little less in depth about Medicare. And then also talking about some resources to assist you in pursuing those opportunities and some tools that we developed. So I'm a senior research coordinator here at NAU at the Center for Community Health and Engaged Research, and I've been working on CHW and tribal CHR workforce advocacy and evaluation and research for the past 8 years. And billing was new to me as of a few years ago. In fact, it feels a little bit surreal to be giving this talk because I remember when Alex came and gave the talk here when it first got approved in 2023 and talked about this opportunity. And I remember going up with my list of questions afterward, like, I don't understand this. And then I just spent the last 3 years just researching this nonstop, and here we are. So I'm going to be talking about, like I said, overviewing Medicaid and Medicare, billing, tools and resources, and also we've discussed a lot of challenges. So we'll touch on some of these challenges and a little bit about readiness, which Megan did a great job of setting up and talking about. So before I get started, you have actually this code on your table. So this is going to feel really redundant because I'm going to keep all the QR code will appear on several slides. This is where all of the tools that I'm going to be talking about live currently. Someday, hopefully, they'll be on a real website and it'll look really different. But in the interest of getting these out to the world as quickly as possible, they live in a Google Drive right now. So to use them, you download them straight out of the drive. So with the Excels, just know that if you click on it, it's a read-only file if it opens in Google Sheets. But if you download it into your Excel on your desktop, it's a file that you can modify and play with. And most of the rest of them are PDFs. All right, so whoops. So first, I have to use the clicker. First, I want to talk about, just a quick overview of the opportunities that we have right now. And several of these have already really been mentioned. So as several people said, CMS, the Centers for Medicaid and Medicare, have recognized the value and importance of CHWs and wanting to actually reimburse for those services, the importance of addressing social determinants of health with these with this incredible workforce. So we have in 2024 Medicare implementing new billing codes, and in Medicaid that became available in Arizona in 2023. And currently there are about 24 states that are reimbursing for CHW services through their state Medicaid programs, and they look. There are differences across every state, but also lots of similarities. All right, so the high-level view, because I'll dig into each of these, but the high-level view is, like I said, Medicaid, access, I'll be using those terms interchangeably, and Medicare. At just a glance, I think the important thing to see here side by side is that the covered services are fairly similar in terms of being related to navigation, resource coordination, health education, health promotion and coaching. So really kind of similar looking services. You just have different populations, of course. So you have your Medicaid population. And then with Medicare, there's actually two codes, and I'll describe them in a minute. And they have little difference in the populations that are eligible to receive those services. So first, Medicare, and like I said, won't spend as much time on this because I think it's going to be less applicable to most of the people in the room, but I do want to make you aware of what's there. So what you need to know about Medicare billing. So there's a few main things I want you to walk away with. There's obviously a lot more to this, and if you are interested in knowing more, one of the resources in that drive is this fact sheet that I put together. That summarizes the two billing codes, some key information, and on the back has links. So you want to, any of these PDFs, I recommend using the digital version because there's going to be live links to all the any associated resources that I thought were helpful. So in this one on the back, there's lots of live links to Medicare resources and some other organizations that have done some really great work, like the Partnership to Align Social Care has some amazing resources on implementing Medicare billing. So, but the takeaways for today for you all is who can provide the services. They define it as auxiliary personnel, so it is not limited to CHWs, but it includes CHWs. And then who can bill? So this is key. Only licensed providers, not community health organizations. Only licensed medical providers can bill for these Medicare codes that are available. But they can contract with community-based organizations to provide the services and bill on their behalf. So one of the links on that sheet actually takes you to a sample contract between a clinic and a CBO, showing you what that could look like. The important thing to remember about how that contracting could work is that there does need to be some clinical integration in terms of communication between the CHW or CHW organization and the clinical provider. And like I said, there are two different billing codes. They're called Community Health Integration. You might hear it referred to as CHI, and Principal Illness Navigation, which they call PIN. And like I said, the differences on those have to do with who can qualify for the services. So basically the big difference is for PIN services, it's for folks who have like a severe, I'm looking for the right word here. They have to have a health navigation for someone with a serious high-risk condition and some other qualifications to that, whereas community health integration can be for anyone who is facing health-related social needs. And just quickly to show you what kind of rates are available, so kind of what money is on the table for Medicare billing. You can look at the highlighted column there. They're almost the same rates, basically, for the two different types of services. There's an initial visit that you get to bill for 60 minutes at $86.17, and then each additional 30 minutes after that with that patient, with that client, is at $54.11 per 30-minute unit of service. So when I show you the Medicaid billing, you'll see that this is definitely a higher rate. It's about double what we actually have available to us in terms of Medicaid. And so I'm going to leave Medicare right now. Any questions before I leave the Medicare conversation? Okay. All right, so on to Medicaid. All right, so we already heard that this has been available since 2023. We have the initial guidelines are set out in the AMPM policy 310W, which is actually on your table. So, and you can find it with that code as well. So this is the access policy that was initially published. You'll see it's only about 3 pages long, so it's a little bit limited in terms of what it tells you. Luckily, Access is also maintains a really robust FAQ document, so I went ahead and linked that as well. And I didn't print that for you because that's like 15 pages long, but that's really helpful for answering lots of questions that come up related to the 310W policy. All right, so some of the basics, because we've heard several people refer to this billing opportunity, but I want to just cover really what it means and who is it for. So who's eligible to receive the services? Obviously an Access member. They have to have either a chronic condition, be at risk for a chronic condition, or have a documented barrier that is affecting their health. So it's a pretty broad group of people. It's probably most of the people you serve. And then one of these factors, right, the condition or risk for the condition or the SDOH barrier has to be documented in the patient's medical record to be able to be eligible for reimbursement. And then what specifically are the services that are reimbursable? They are defined in this way with these sort of 3 categories, but all of these fall under one code, essentially. So you're not thinking about billing separately for health system navigation or separately for health education. These are just the things that can fall under that code that is available. So there's health system navigation and resource coordination, health education and training, and health promotion or coaching. And so important to point out, of course, that this seeing these up here doesn't mean that your CHWs can only provide these services, right? These are just the reimbursable services. It's well known and understood that the CHW scope of practice and their core competencies extend beyond what's up here, but at least these are actually fairly broad in terms of being able to cover a lot of services that CHWs do provide. And then you heard Megan talk about referrals from providers, so who can the service has to be deemed medically necessary by a licensed eligible physician or practitioner of the healing arts. And if you look into the policy, there's a little table that Arturo showed in his slide that has the provider types who can recommend the services. I just pulled out kind of the most obvious ones here at the bottom, so DO, MD, physician assistant, and registered nurse practitioner. And they have to work under the direction and employment of one of those registered provider types, one of whom is a community health organization. So you could have one of those practitioners working at a community health organization, or they can be working in a clinical setting. And then this was that visual that Arturo showed as well, right? So we talked about now who can receive the services. We talked about what services are billable, and we talked about who has to recommend or refer those services. So now let's look at who can bill for the services, right? So we have two different pathways. We have the first one, which is a billing model that arguably is fairly simple to turn on because it says that access providers, so we were talking, clinics, hospitals, or clinical providers that are already access providers, they can bill Medicaid for CHW services for CHWs that are employed at their organization. Fairly simple. They just turn on those codes in their system. The second pathway is the one that presents more challenges and why we're all here today and things we've been talking about is that community-based organizations can register with Access to become a provider type and be able to bill for CHW services. So they have to have the certified CHWs on staff, which many already have, but challenges, of course, that organizations are facing is the sort of issue around, well, we've never billed before. We don't have billing staff. We don't have billing software. We don't have relationships with clinical providers. So how are we going to get referrals? So there's lots of questions that are not addressed in the Access visual that they have made, and it's lovely, but it leaves a lot of questions unanswered. So that's some things I want to talk about here in a second. All right, so when we had this, and a few years ago, we would ask lots of questions at all these meetings, and come away with everyone has their own interpretation of what happened and how this process could work. And a little while ago, last fall, I just felt like we needed some kind of visual, and so to me, the few steps on that pathway looked more like actually 6 steps. So I'm going to go through, and Megan talked about a bunch of these steps. And this is this is a one-pager that you can find in that Google Drive. But for standing up Medicaid billing, I think there's a lot more to it. So at the very base level, we have needing organizational leadership. Support, which Megan touched on, right? Whether it's your board of your organization or your executive director, or whoever that is, getting that buy-in. And then the second step is registering as the provider type with Access. Alex mentioned the APEP, which is this Access Provider Enrollment Portal, and that's how you apply to become a provider with Access. And I'm going to share some resources for getting through that portal because it's moderately complicated, but it's doable, and then that process can actually take months. So if you are considering pursuing this, highly recommend starting your application as soon as possible. If you have the step 1 there, you're ready, you've got the leadership support, you've got your CHWs on staff, definitely start this application because it can take a while. And then, like I said, having your CHWs certified. And then your next step is what Megan spoke to, which is thinking about the health plans that serve your clients and which ones you're going to approach in terms of working with, because as a community-based organization, you don't bill Access directly. You actually have to bill through the managed care organization, the health plan that is serving those clients. If you are a tribal organization, however, and you bill fee for service, you do get to bill Access directly. So you all are super lucky. You get to skip the next 2 steps. Like I said, Megan already spoke to what it could take to onboard with the health plan. They have to choose to accept you into their member network, their provider network. And then you also have to figure out your reimbursement rate with them. So I'm going to show you the fee-for-service rates, which is sort of the base rate for the reimbursement amount that's available with Medicaid, but there is some negotiation that's available between the organization and the health plan. And then you'll want to, this is obviously very important, want to actually establish really functional workflows for those CHWs in your organization to be able to receive provider referrals, communicate back to the provider if some issue arises, or you want to be able to tell them that the referral was closed. You completed the service that they referred you, that patient to you for. And then figuring out the documentation and then into step 6, which is the billing, which has a lot to do with documentation. And so luckily, we have some wonderful resources here that you have the opportunity to go to their workshops later today. So in terms of documentation and referrals, we've got the Contexture Unite Us folks being able to answer questions. And then with billing, we have some people representing essentially option 3, contracting with a third-party billing service. If you're an organization that already does billing for to access for some other service, you might be able to go with option 1, where you already have some billing staff, you've already got some systems in place, you can just sort of, have them work with you to get these codes going. Or maybe you have billing staff, or you have staff that you don't bill currently, but they have experience billing because that was their previous job. So maybe you just get to use a low-cost software and have that person manage your billing because, they used to do it. They used to work in medical billing. Or option 3, like I said, maybe you need someone else to really hold your hand through this because you have no experience, and then you might go with someone like PearSuite or something like PearSuite. So I wanted to just bring to your attention, so we're thinking about all of these steps, and there's a lot to it. So we've had, because of that, there aren't very many community health organizations that are registered for that second pathway option yet with Access. And so we, with some funding support from ASCHW and the Arizona Community Foundation, like I said, created a number of tools. So this is what you're going to see in the Google Drive, these things, and I'm going to talk about a few of them now that are especially helpful, I think. So if you are those 6 steps, if you are kind of in step 1 of like, we're not quite even with leadership buy-in, you might want to look at some of the resources in this reimbursement readiness toolkit, which is the last thing in the drive. And this gives you some background on what it means to bill Access, some key considerations, a readiness assessment, and some example scenarios in terms of reimbursement and cost. So that can just help clear up some confusion before you jump into even the next steps of the process. But let's say you've got buy-in, you're ready now for step 2, you're ready to apply as a provider type to Access. So there's 2 important things in here. We have a step-by-step checklist, which is, what do I need to complete the APEP application? All the things you need to pull together ahead of time, and then what it's going to look like to work through it. And then the step-by-step guide, the one on the right there, is like 30 pages long, and that has screenshots of every single step of the APEP as you go through. There's a screenshot, and there's tips on how to fill out the different fields in that application. So that can be really helpful. I recommend, if you're in the process of applying through the portal, to have that on hand just to, in case you have questions as you go. But there's also, there's a helpline and there's an email address that is on the second page of that step-by-step checklist that are Access folks who are available to answer your questions. But there's, and we have tips in there how to get them to answer your questions. So recommend reaching out to them if you have any trouble that isn't answered in the enrollment guide. Okay, so with the last little bit of time we have, I want to talk about the money, the reimbursement potential with the program. So, or with billing Medicaid. So we have created a couple of tools. So one of them looks at just the Medicare billing codes and reimbursement, and the other one is for Medicaid. So just make a note when you're downloading and using it that you're using the right one, because the billing amounts are quite different, as I mentioned. So they can help you answer questions like, why bother? Is it going to bring in enough revenue to make a difference? And how does that revenue compare with the cost of employing a CHW? So it looks, I'll bring it up here so we can actually play around with it. And so I have to just exit my slideshow. All right. And sorry, I know there's like nothing worse than seeing someone in a spreadsheet on a big screen because it's hard to see. So I apologize, but I didn't want to do screenshots because I think it's important to see this working live. So when you get into this, you want to start at the Start Here tab. So notice there's different tabs along the bottom. The first one is Start Here. This explains the purpose of the tool in terms of estimating costs and reimbursement for Medicaid, that it allows you to enter your total cost of employing your CHW, how many hours they work, and estimate, the potential reimbursable hours you think you might be able to do, and then it auto-calculates the estimated reimbursement. And then the note down here is to tell you which estimator tabs to use. So you'll want to, if you think that your CHWs never provide services to groups of Medicaid patients, then you'll use the pink tabs, because those are for individual only calculations. You're only going to use the billing code for individual patients. But if you think you have CHWs that you're going to do group and individual work, you can use the blue tabs, because that lets you work with all of the billing codes for individual, small group, and larger group. And then importantly, as a reminder of what rates are here, the last tab actually describes the rates, and I'll open that in just a moment. Before I do want to acknowledge that this tool was adapted from one developed by the Community Health Worker Collaborative of South Dakota, who shared an example of what they had developed, and we adapted it for Arizona. So that last tab, like I said, tells us about the actual rates. So you can see that there's 3 codes. As mentioned, the first one is for an individual patient, 30-minute unit of service. The second one is for 2 to 4 patients, same 30-minute unit. And the third one is for 5 to 8 patients. So the rate, the fee-for-service rate here is our multiplier, right? So you can see the first one for individual is $26.03. The second one seems, that's so low, $12.59, but you have to multiply it by the number of patients you're billing for. So if you see 4 patients in that group times $12.59, you're looking at like $50. So the multiplier works, and I'll show you what that looks like. And then just to be aware, of course, there are caps on per patient, units per patient per day, per month, that sort of thing. So, and those are outlined in the policy. Those are not built into the system. All right, so this is the fun sheet where we get to actually put in examples of what we pay our CHWs, so what is the cost of employing them versus how much we can get back in reimbursement. So the thing to notice about this sheet that is in our helpful instructions box at the top, the first thing to notice is you only enter information into the green boxes, not the gray boxes, not anywhere else, just into green, and then everything else is going to autofill. I'll show you how it works. So for the CHW hourly rate, we want to think in terms of not just their hourly wage, but we want to add in the benefits on top of it, so 30% or 25%, whatever your benefits are. So I like to put a round number in here, even though I appreciate that, and I hope that your CHWs are getting more than this, but just in case, a round number is nice for just seeing visually how this looks. So let's say that in our example, they're making $19 an hour. Again, hope it's more than that with our 30% benefits. So we're getting around $25 an hour. Okay, so the first line here, we want to think about the hours worked and reimbursed. So we're only thinking about Medicaid reimbursable hours. Your CHWs, of course, are working 40 hours a week, but how many hours in a day do we think that they could actually provide Medicaid reimbursable services? And at first, this might be super low, but maybe down the line, it's bigger. You'll see here when I hover over this box, because there's a red triangle in the corner, a note comes up that explains how the calculations work here. So it's just a reminder that if you remember, the billing units are in 30-minute units, but I think it's easier to estimate in terms of hours. So when we think about 1 hour of service, it's 2 units of service equaling 1 hour. So let's say they're able to work with a single patient every day, maybe 2 hours. Maybe an hour with one patient, an hour with another one. That's 4 billing units. You can see right across the way, we immediately got a weekly reimbursed amount for those individual visits at $520. And then per week, for a small group, would the CHW ever work with a small group of individuals? Maybe an hour a week. Whoops, oh God, don't do that. make sure you're in the right box. Okay, maybe an hour a week. So then we have auto-filled on the gray side, how much that could be per week with those small groups. And maybe a large group, maybe it's rare, but we'd put some number in here, and you can play around with it as much as you want. So you can see just doing 1 hour, that's 2 units of service with a group of 7 patients, would be $128 a week. And then your CHW, let's assume they work full-time, 40 hours a week. So over here now we have simply the total cost on a week's perspective to employ that CHW, $1,000. Total reimbursement potential, well, that was interesting, just over 700. So the difference in the pink box of 275. So that's what's not covered by reimbursement. Again, this is a little bit of an ideal situation because at first you're probably not going to be doing this sort of work, but we can play around with it. And then we want to know now what that looks like annually. So we need to put in a number here of how many weeks they're going to actually provide services in a year. It's not 52. I hope your CHWs are getting some vacation. So we're going to put in 47 and going to trainings and doing continuing education. So put a little bit lower number there. So annually, you're looking at the cost of employing that CHW being about $52,000 and the annual reimbursement being just over $34,000. So in the pink is our difference, what would need to be covered by other funding sources. Like Alex talked about, Medicaid reimbursement is not the end-all be-all of sustainability for the program. There still needs to be the braided sources, potentially from grants, potentially from other sources. And then before I go down, I'm going to show you what's happening in the pie chart tab, because that's kind of nice. So now you're seeing that with those estimates that we just put in, 55% of the cost of employing that CHW is covered by reimbursement, and 45% in the blue is the remaining that would need to be covered. Now, we also know that there's more to cost of employing a CHW than just their salary and their benefits. So down here we have a space to put in your additional CHW related expenses if you want to be able to put in some other things. So I put in some examples last night just to get this ready. You might be paying for billing support software. You might an annual fee. You might have you might be wanting to cover part of the supervision for that CHW, a partial FTE. You might have training expenses, mileage, phone, whatever it is, you can put an item here and put an amount over in this box. And now we have the cost went up from $52,000 a year for that CHW to pay for their position to $61,000. So that's helpful just to be maybe more realistic about what it really costs to employ that CHW. And then at the very bottom is a spot where you can play with, well, what if I have multiple CHWs on staff providing these services that are billable? You can put different numbers here and see how it affects your annual costs. So of course our annual cost doubled, but so did our annual reimbursement amount and our program level difference. So this is helpful. We can see some different examples here in terms of like maybe we never do group work. That's okay. And so this would be kind of a scenario for just getting started, maybe pretty early on. You don't have that many reimbursable hours per day. You're not really doing group work. So you have a bigger kind of gap to fill with your other funding sources. Or maybe you're an organization that does a lot of group work because you're, serving clients who have similar, maybe you have a diabetes education class, something like that, and maybe you're doing several of these group things a week. Then all of a sudden, your gap gets much smaller. So this can just help you play with the types of possibilities that are out there and specifically for your program. So hopefully that is something that is beneficial. And we're almost to the end of time. And that actually was my last main slide. Of course, I lost my visual. So like I said, you download it to play around with it. And know that, I think as Sam mentioned, there has been a lot of research actually on return on investment. And that's out there for your use. There's going to be a new study coming out quite soon out of those same partners in South Dakota I mentioned, who are finding savings per $4,700 in savings per recipient that's getting CHW services annually. So they're seeing some good results out of that state when they had Medicaid reimbursement going a couple years ahead of us. So they're sort of our example. So again, the billing tools are in the Google Drive. I'm going to lay some printed versions out, and if anyone wants to talk to me about anything or see them, what they kind of look like, I can visit with you during lunch. There's also another tool I wanted to share related to CHR and CHW integration into care teams that we've developed, and if you're interested in that one, because that talks a lot about care coordination and referral processes and things like best practices, that's a different toolkit that you can request access to using the other QR code. Questions? Sorry, it was a lot of information, but I'm here the rest of the day, so. Yeah.
Thank you for your presentation. So we're working, thank you. We work from the Navajo Nation tribal perspective and population. And you mentioned that we could skip 2 of the startups. Is there the supporting legislation or rules that take us out of, that we're not having to go through those steps? Can you help me guide that just for policy purposes? Thank you.
Yeah. There's information in the Access on the Access website and in their policy documents about organizations that can use the fee for service path that tribal organizations can. And yes, like I said, then you don't have to work with the health plan. So these are steps 3 and 4. And we have a different flow chart for tribal organizations that is also in that drive. But I can also answer questions for sure later. Yep. And it's lunchtime. Do you want to say anything before we break? Yeah.
Big round of applause.
Oh, thanks.
Okay, you've been in this room all day, so now we're leaving. We're going to take off. We're going to go eat lunch. But I just really appreciate all of these speakers, and hopefully that is like the building blocks or foundation of the house that you're building, right? Certification, how to set up a program or how to amplify your program, how to collaborate with others that already have a program. And then kind of some of the mechanisms that you can take advantage of in terms of Medicaid and Medicare. So we're really excited about all of that and are very hopeful. Yeah, maybe after lunch, at lunchtime, I'll do that. Well, I'll do it during lunch, yeah. So what I'd like to do is just invite you to go to lunch and eat it. And find friends, like you've all been sitting at your own little table, but maybe you want to process information and, take over the world at your table with your team. But consider, you know who talked and you've got other people, you've got their faces in color. So seek these folks out. Take advantage of this time because we did build in a whole hour for lunch, which is such a luxury. And some of you might have to go, take care of some business while you're here. But take advantage of talking to people. They're really good on their feet and thinking through possibilities. So we invite you to enjoy and eat lunch with your friends and with new friends. And then if anybody, since we're all public health people and we care about your cardiovascular system, NAU is right behind here and we have beautiful walking paths. So if you need to get out and smell a pine because it's been 70 degrees and they start producing this beautiful sap smell, I just invite you to walk back there and just grab a pine tree and just give it a little sniff because it's really healing and delicious. So that's that way. And then we'll come back in here and I'll make some announcements right around 12:15. So when we come back, because Louisa was telling me to do this and I was like avoiding it, but we're going to come back basically at 1:15 when lunch ends, but we'll have lunch in here. I'll make this announcement again, but we'll have 2 afternoon workshops, one in here and one in another room. And so you'll be able to choose and kind of ping pong back and forth. So it'll kind of get you moving and around. So that's what we're going to say. And please visit all of the vendors as well and have conversations with them. And thank you for being here and eat lunch and enjoy. Bye.
Good afternoon. Okay, you're awake. Good. I just want to make sure nobody fell asleep after lunch. All right, so My name is Ben Fisher, and I am an SDOH Community Programs Advisor with Contexture. Raise your hand if you heard of Contexture. I hope you have at this point after this much time in the morning. Thank you. Okay, a few of you have. This lady wants to say one thing.
Sorry to stop your roll. Stop your roll. We just wanted to make sure that you know that we have two different sessions going on. So you can choose, and the only reason why I'm saying this is because you want to stay here, but then there's another one that you'll go to after, and then you'll switch back. Does that make sense? So this is Contexture, and then Pear Suite's going to be in the room 2 down, but you stay here because then you can go over to Contexture, or you can go over to Pear Suite at 2:15. Okay, got it. Sorry about that.
Or you can just stay here and listen to me repeat myself for the second 45 minutes. Actually, I'm probably not going to be repeating myself verbatim on both because there is a minor misprint in the agenda. So I'm going to breeze through this one for the first 45 minutes up until 1:45 so I can get you all to get out to your second breakout, okay? So anyway, I'm Ben Fisher, Community Programs Advisor with Contexture. Great to be here in Flagstaff. I'm currently based out of Phoenix, but I serve the northern Arizona area, so La Paz, Coconino, Mojave, Navajo, Apache, and Yavapai counties. So good to be here. So I'm going to be talking a little bit about community cares, and then I'm going to be going into a demo. So please tell me you've heard of community cares. Okay. All right, so our agenda is going to be a quick community programs overview, and then I'm going to give you some highlights from our partners. We're going to go into the community cares demonstration, and then if we have enough time, and if you've decided not to leave me and go over to the other breakout session, please don't, come over here and stay here, then you're welcome to ask any questions that I'm happy to answer. Okay, so community cares overview. So Community Cares and Contexture is Arizona's Health Information Exchange, otherwise abbreviated as an HIE. And we've teamed up with Arizona Healthcare Cost Containment System. Please tell me you heard of that. It abbreviated as ACCESS. We've also collaborated with Solari Crisis and Human Services to implement a single statewide closed loop referral system, which is Community Cares, and that is designed to address the social determinants of health needs throughout the state of Arizona. So as you know, ACCESS, being the state Medicaid agency, has rolled out the Community Cares program as a key component of ACCESS's Whole Person Care Initiative, which initially launched in November 2019. The Whole Person Care Initiative focuses on addressing the important factors of social risk as a part of a person's whole well-being. ACCESS connected with community shareholders and identified several needs of focus. One area, transitional housing, another, non-medical transportation, and another, social isolation, and then finally, substance abuse. The initiative ultimately led to the development and the rollout of the SDOH initiative and enter stage left, community care system. We like to show this slide to provide an example of all the factors that can impact a person's health. If you notice on this slide, only 20% of a person's health is impacted by medical care, medical and health care. In fact, more than 80% of a person's health care is driven by socioeconomic factors, physical environment factors, and health behaviors. So those are going to include areas such as, does an individual have access to fresh fruits and vegetables? Or otherwise, do they have access to a supermarket? Do they have access to adequate pay? Or better yet, do they have a job? Are they getting enough exercise? Is somebody getting appropriate lighting in their neighborhood? Do they smoke? Do they drink? What is their sexual activity like? All of those factors have an impact on a person's ability to address health concerns or prevent them from developing. The execution and oversight of the Community Cares program is not possible without these key partners. In addition to Contexture and with Community Cares, we also have the Unite Us team, who is the vendor of the closed loop referral system, Community Cares. Both Contexture and Unite Us work very closely together to onboard participating organizations and also provide platform support and post-live support. That's me too, so you're always welcome to reach out to me. As part of the Whole Person Care Initiative, Access endorses and funds the Community Cares program for all organizations in Arizona, statewide, making it a free resource. So whether you are an access provider or otherwise, using Community Cares comes at no cost and is also does not come as a cost to the individual who is benefiting from getting connected to services in the community. All right, for the sake of time, I'm gonna speed through a few things, and another highlighted area is Contexture's initiative to drive alignment across the state of Arizona. On this slide here, you'll notice that there are multiple collaborative partners that work with Contexture in collaboration with Community Care. So one example is the ADHS Wise Woman program. Another one is the initiatives on SDOH, DAP, and TIP. DAP stands for Differential Adjusted Payment Program, and the TIP is the Transforming Initiative program as well, and both of those are programs that are offered through Access. So if you need more information about those and you are on the healthcare side of the industry, please let me know. I'm happy to connect you to those resources that are available. We also are working with Access under Housing and Health Opportunities, otherwise abbreviated as H2O, along with reentry. Another cool factor is the ADHS Diabetes Referral Network. Anyone hear of that? Maybe? No? Okay. Oh, some of us have. Okay. Yeah, so the Diabetes Referral Network comprises of two programs, the DPP and the DSMES, which are both programs I work with very closely on organizations rolling out those programs throughout the state. So let me know if you want more information. And we also have other state and community-led initiative programs. We've got a food pilot hub down in Cochise County. We have a food pilot here in Coconino County with Flagstaff Family Food Bank. We are also rolling out with Quartzsite Family Food Bank in exploration as to what we can do to partner on the food bank needs, or the community food needs, excuse me. In addition to that, the Quartzsite Area Innovative Heart Program, which is another program that is funded through the parent org level CDC. So we have our hands in a lot of pots, and we are collaborating very closely with both local communities, regional communities, and statewide. Community Care's impact at a statewide level is huge. As of February, we have over 267,000 referrals sent using Community Cares, which is really impressive. The total number of Arizonans served is over 87,000. To put that in perspective, that is almost the population of Buckeye, Arizona, if you think about it. It's pretty amazing to think of. At the site level, we have over 1,500 organizations that are live using, sending or receiving, referrals on Community Cares. So, and at site level, if you need more information about what that means, I'm happy to explain a little bit further, but for the sake of time, we also have over 3,100 programs available, again, statewide, available through the use of Community Cares. So the rollout of Access's Whole Person Care Initiative and ultimately the implementation and deployment of Community Cares across the state of Arizona has been foundational at best. Right here, we have a frequently asked questions here. What is a closed loop referral system? We have a definition here. In addition to that, another common question we have is, how much does Community Cares cost? Does anybody remember what I said previously? It's free, that's right. The fine print up here will tell you a little bit more about the free cost. Now, there is a cost associated with implementing if you have a system that is compatible to integrate with Community Cares. If you want more information about that, I'm happy to provide that. I have a whole entire team of individuals who also have a lot more information about that as well. Who can join? Any organization that identifies as a healthcare-based organization or a community-based organization is able to join. So if you are a food bank, if you are a clothing provider, if you provide shelter services, if you provide housing and reentry services, if you are an organization that is based in the correctional health system and you are providing reentry services for those leaving the incarceration system, we can collaborate. A great question we also commonly get is, why should someone use Community Cares instead of another CLRS available? Great question. The answer is Community Cares is a statewide CLRS. We are the only statewide CLRS that is connected through all communities throughout the state of Arizona. There are other CLRSs in regions of the state. However, they do come at a significant cost, and they only have resources that are community, local, or regional, whereas Community Cares has resources statewide. So if you are serving an individual in Kingman, Arizona, and you know that they are transient and that they go down to Tucson during the winter months, you can connect them to resources in Tucson knowing that they are going to go down to Pima County. Really cool. I love that feature. There's a consent process in Community Cares that we ensure confidentiality. In that process, we have workflow designs that we can meet and tailor to customize to your existing process. What we want to do is ensure that when Community Cares is implemented for your organization, we want to make sure that it is aligned with your workflow processes and not creating a duplicative process or a secondary rogue process so that you're having to follow two processes independently. In addition to that, with our workflow, we also have considerations for sensitive services and non-sensitive services. Sensitive services are those services that are such substance use services, HIV services, domestic violence services, and behavioral health services. So services that you may provide that fall within one of those categories, we can cloak it to identify it as a sensitive service. In addition to that, Community Cares offers custom add-ons. One really cool one I really love is the assistance request form. If that is something your organization is interested in, we can provide you a link, which you can translate into a QR code or keep embedded as a link onto your organization's website, where you can have an individual put in a request for assistance directly, and it shoots to your instance of Community Cares. Really cool. In addition to that, if you have screening questions that you provide to your clientele or to an individual that are not contained in the preloaded screening forms within Community Cares, we can create custom screening questions as well. So again, versatile, designed to accommodate your workflow. Here we have an example of a workflow that is standard that comes with the Community Cares product. In addition to that, we also have a workflow that we have designed specifically for CHW. So CHW receives and reviews and accepts a referral, right? Next, they contact the client to determine the eligibility and assess the client's needs. Afterwards, based on the identified need, CHW creates the referrals to the community organizations and the CHW orgs. CHW then documents the case progress and then documents the notes with the open internal case. Once the client's needs are met and the outcomes are achieved, they're documented, CHW closes the original internal case, and the loop is closed. Onboarding with Community Cares is really easy. It is join a demo session of the referral platform, and I'm going to be providing you a small one today. Sign the Community Cares Agreement, and we internally, to Contexture, we refer to that as a CCA. So you'll hear me say those things in tandem, so just so you know what a CCA is, Community Cares Agreement. Receive onboarding support from dedicated members. You will get onboarding support from our partners at Unite Us, and any questions you have on the onboarding, you're more than welcome to contact me. I'm more than happy to help. Complete the required meetings and documentation for successful go live. We have a few documents to tailor and design the platform to your needs. And once that has occurred, you'll receive new user training, which is scheduled on a regular cadence with Unite Us. Ultimately, afterwards, you'll receive post-live support. You are ultimately live on using Community Cares. If you are a community-based organization, we anticipate that this process should not take more than 4 weeks. If you are a healthcare organization, it's probably going to take a little bit longer depending on the needs of the healthcare organization and the degree of implementation you have with an electronic health record. So with that being said, I'm going to pause. Could you imagine? I almost didn't even take a breath there. All right. And I'm going to go ahead and spend the next 15 minutes, or 10 minutes. What? That wasn't me, was it? Y'all saw that? It just blipped out on me? All right. I'm going to spend the next 12 to 15 minutes going over a demo. So this is a demo environment. Please forgive me. It is defaulted to Omaha, Nebraska. So please pretend it's Arizona. So here, I'm going to enter my email, select next. Or maybe not. All right. All right, I'm going to sign in to the Community Cares platform here. Now, for me, there's a unique situation here. On this screen here, I have 2 organizations. So if you are running more than one organization, this is the first page you're going to come to. If you are only one house, so to speak, you're not going to see the screen. You're going to directly digress over to the Community Cares dashboard, okay? So in this case, I'm going to be a person who's going to be sending a referral. I am sending a referral based on an individual who's come to my housing company, which is Holy Name Housing Corporation, and they're telling me that they need food. So as Holy Name Housing Corporation, I'm going to look in Community Cares here, and I'm going to see if the individual has been previously served. So this is the dashboard. And where we default to are the needs action inbound referrals. So this list here are all inbound referrals to my organization that are requiring user action, okay? So because I am working with Ben Tennyson, I'm going to go ahead and look for Ben Tennyson first to see if he's been previously served. The best way to do that is I'm going to hit the plus icon in the top right corner and select new referral. When I do that, I'm going to enter, whoops. That went really too big for me. Tech support, where are you when I need help? Oh, so this has happened before.
It just happened earlier. I'm wondering if we did, can we do the?
Can you, oh, you were right. All right, now I feel goofy. All right, anyway, all right, so I'm gonna look for Ben Tennyson. Ben Tennyson, and his date of birth is going to be January 1st, 1975. Actually, I'm gonna say 74 because I think I used 75 before. So I'm going to search the records. This searches through the national database of records on this individual based on first name, last name, and date of birth. If the individual has not been served previously, it's going to automatically take you to the new patient section, just like it did for me here. So here in Community Cares, I'm going to enter the demographic information for the individual that is presented in front of me. So social, if applicable, if the individual wants to share it. All of the demographic information, you can populate it. Please note that the gender, marital status, race, and ethnicity are all defaulted to undisclosed. If the individual does not wish to provide that information, they are not obliged to. It does help in many cases, and especially if they are eligible for certain programs or services. If you can garner that, great. If not, that's okay. All right, so I'm gonna scroll down here, and I'm going to put in Ben Tennyson's phone number, and I'm gonna say 928-555-1212, and I'm gonna say it is okay to call him, it is okay to message him, and it is okay to provide him notifications. I'm going to scroll down to the bottom. I can put in additional contact notes, and I'm gonna hit Save Client. So, in here, Ben Tennyson, as you can see, we got some demographic information in the top left corner here. We have in big red block here, no consent. No consent is indicated that there's no consent garnered on the individual yet. I cannot send a referral on this individual until I get consent. So that's how you know where we are in this process, just by that little red block. What I'm looking for here is I'm looking for a selection of resources. So here, the cool thing about Community Cares is I can look by a region. I can scroll out, use the map, and look in different areas. Or I can look at the available resources on the left-hand side here. Food Bank Heartland happens to come up first because I have it starred as a favorite. So in this case here, I know that Ben Tennyson came here because he's seeking food. So I'm going to go ahead and select Food Bank Heartland by selecting Add Resource. Once I add the resource, I'm going to select the services down here. I'm going to say he wants emergency food, and he also needs food pantry. So once I've added those resources, I can select the Added Resources button in the top right corner. And the cool thing about using the Added Resources feature up here is I can just go ahead and go straight to create the referrals. Or the other cool thing I can do is I can select Share right here, and I can also text Ben Tennyson the contact information for these referrals. So I can send Ben Tennyson Food Bank Heartland's contact information and allow him to contact directly if he wants. I can also send it to him, and knowing that he may or may not contact Food Bank Heartland, I can still continue to proceed with create the referrals.
So you can do that without the consent?
Yes.
You're not giving that or the referring agency his information, you're just saying, hey, call him.
Very good, excellent point, yes. So the question is I did not have to get consent to send that information over to Ben Tennyson. And that's a good point, because I'm only sending those resources to Ben. In order to send Ben over to those resources, I have to get Ben's consent. Make sense? Different directions here. So I'm gonna go ahead and say food pantry or apply selections, prepare your referrals here. Under the referral preparation, I'm going to provide a brief description. We try to be as specific as possible, and in this description information, do not provide personally identifiable information if you can at all help it, or protected health information. So here, client is requesting 2 weeks worth of emergency food. Also needs future food from pantry. All right, I'm going to scroll down here, hit next. If there were additional assessments for Ben Tennyson here, I would complete those here. In this case, by default with the application, there is a tribal affiliation, pronouns, and preferred language. I'm going to go ahead and say next. I see my referral information. I get to preview it here. If I'm ready to submit, I can hit confirm and submit. When I hit confirm and submit, the referrals have been created, and now I'm going to the consent process. In the consent process here, there's multiple ways we can garner consent from the individual. We can do an on-screen consent by verbal attestation. That means I am reading a script over to Ben Tennyson, telling him, asking for his consent and getting verbal consent acknowledgement. The other one is I can send a request for signature to him, or I can have him do a direct on-screen consent. I can have him do an electronic signature. There's multiple ways we can do it. In addition to that, we also can upload paper form. What I'm going to do is I'm going to go straight to the on-screen form here by selecting Go to Form. And this is a script that I read to Ben Tennyson. By consenting, you agree to share information with this third-party agency, et cetera, et cetera, et cetera. And then Ben Fisher, me, the referral sender, I'm going to go ahead and say, yeah, you know, I read it to Ben. He's cool with it. And I'm going to go ahead and put my signature. There we go. And hit accept. Once I've hit accept, the referrals were successfully created, and bam, it's been sent over to Food Bank Heartland. I went through that very fast, but that is the basic process of sending a referral. And just so you know, the referral sending process in Community Cares has been shown in many case studies since 2014 that it actually saves on average of 13 minutes per referral. It's pretty impressive. Any questions before I switch hats? Okay, now, instead of being the referral sender, now suddenly I'm with Food Bank Heartland and I'm the referral receiver, okay? In here, I'm going to go ahead to the org icon, and suddenly, magically, I'm Food Bank Heartland. So now, as the person who is on the Food Bank Heartland side, bless you, I'm going to go ahead and look, and I see I've gotten a notification in my email that Ben Tennyson is an organization who is being referred to me from Holy Name Housing Corporation. In my needs action list here, I see, oh, look at this, check this out. Ben Tennyson is a client name. He needs food pantry. It was created at 141. I'm going to go ahead and open this up to check out the details of this referral. So I look here, I can see some basic information about this referral, the sending org, sending user, which is Ben Fisher here, and it's user network, food pantry, okay. Clients requesting 2 weeks worth of, okay, okay. We have capacity, and you know, we just got a shipment of food boxes, so no, the blank screen does not normally happen. So at this point, I can say, you know what, we can serve him. So I don't see a problem with that. In this case, I'm going to go ahead and hit send or accept to accept the referral. But notice here, there are some other options here. I can hold for review if there is an eligibility criteria on the individual that has not been met. I can hold this for review so I can gather additional information about the user's particular situation. Or if for some reason I'm at max capacity and I cannot serve this individual, I can reject the referral and put an explanation in. So there's multiple things you can do. Again, we can design workflow around this. In this case, I'm going to go ahead and say, accept the referral. So what I did not call out is that if you notice up here, there is this yellow line. This yellow line indicates that this referral needs action. Once I have accepted the referral here, the case, what it does is it opens up a case. So this case can comprise of one referral or multiple referrals, but this is the case of managing this individual's situation in the current needs. So in this case, I'm going to go ahead and say accept. And ultimately, I've accepted this referral. That yellow bar has now turned green. It's an open case. So then what I do is I send part of my staff over. They call Ben Tennyson, say, hey, we got some food boxes for you. Ben Tennyson comes running down. He grabs those food boxes. He goes home. He's grateful. And then I document in the case here, hey, Ben came in, excuse me, And so, and he was served. We got him his food boxes. And then ultimately, once we got that confirmation and what's has been done, I can close the case. Is it resolved? Yes, it's resolved. Ben got his food. Close the case. Oh, client received services. And the loop is closed on this referral. Any questions? I know I am very sorry I went through that very fast. I was shortened on time. But ultimately, that was the demonstration of sending a referral and receiving a referral. Yes?
For getting their information, is it just assumed that you're doing that with their permission? You don't have to have a separate, release signed by them to just have their name and date of birth to plug in the first place? Or is there an initial step with the consent?
Are you talking about the consent process built within the platform or your own consent?
Consent to just start adding their information in before you even do that.
You can work in a process to get their consent before you start adding this, but typically that's going to be in the policies and procedures with your organization. So if an individual walks in and they say, hey, I need some help here, you're probably doing some initial triage with the individual. Good question. Thank you. All right. To be deeply respectful for your time. Oh, yes.
Have you ever implemented that in a hospital organization, like in a hospital EHR system?
That's a great question. So short answer, yes. And one of, I know that YRMC has implemented community cares, and we've with the YRMC group, along with the Yavapai, the Young Children of Yavapai County Coalition group, we've also had a presentation done by Phoenix Children's Hospital, who is a mass producer of referrals, sending them out statewide. Yes? That's a great question. I'm so sorry I did not cover that. The question is was the Holy Name Housing Corporation notified when the food bank was able to help the individual? And the answer is yes. So when I go back into, when I flip on my hat to go to Holy Name Housing Corporation, the person who sent the previous referral, if you notice here, we no longer have, that's my inbound, outbound. All outbound referrals. Under outbound referrals here, under all, Food Bank Heartland, Ben Tennyson Food Pantry status was accepted, last updated today. So I, as Holy Name Housing Corporation, am notified when the food bank was able to help the individual. I'm also notified if they're not able to help the individual.
You can receive that either in the app natively, or you can receive it like via email or something like that, or if you have an integration with your EHR, you can set up a workflow where you can get that notification back, in any way that makes the most sense for your workflow.
Good question, thank you. All right, it's 10 till 2, so it's a great opportunity if you need to get up and take a stretch break. I know we've all eaten food, so some of us are probably getting sleepy, so thank you for your time.
We'll be up here if you have questions.
Say hi, everyone. Yes, we have just a little bit of time, 10 minutes before the next session. So if you want to now watch, be part of the Pear Suite informational session, that's a few doors down in the Doyle room. Starting at 2 o'clock. And then also want to make you aware that after the afternoon sessions are done, we are having sort of a reception time, more networking time. So that's from 5 to 6 this afternoon after our little closing. So do hang around if you don't have to get back in the car and drive home for that reception time. Otherwise, you have a few minutes break before joining Pear Suite. And then there's another set of workshops starting at 3 on standing orders and managed care organizations.
Good afternoon. How are y'all doing? Good? Yeah, great. So good. Thank you. I was looking for a great here. Anna's so good. I was worried everybody was going to have the after lunch sleepiness because I get that by 2 o'clock normally. All right, so thank you for being here. My name is Ben Fisher, and I am an SDOH Community Programs Advisor with Contexture. So I'm here to present on Community Cares, which is the statewide closed loop referral system. So you're going to be hearing me say that probably multiple times. You might end up saying that in your sleep by the time I'm done with this presentation. So this afternoon, for the next 45 minutes, I'm going to provide you the Community Cares program overview, and then I'm going to present a little bit of partner information. And then I'm going to dive into a Community Cares demonstration, AKA a demo. And then afterwards, I'll open it up for a little bit of time for question and answer. So with that said, on we go, onwards and upwards. So Community Cares overview. So go back here really quick. All right, so Contexture is Arizona's Health Information Exchange, otherwise abbreviated as an HIE. We've teamed up with Arizona Healthcare Cost Containment System, otherwise known as ACCESS, along with collaboration with 211 and Solari Crisis and Human Services, to implement a single statewide closed loop referral system, otherwise known as a CLRS. And the CLRS is designed to address social determinants of health, otherwise known as SDOH. So Community Cares, driven by ACCESS, as you know, ACCESS is the statewide Medicaid provider. And ultimately, Community Cares is the program that was the CLRS program that has been rolled out statewide as a core component of ACCESS's Whole Person Care Initiative, otherwise, again, abbreviated as WPCI, Whole Person Care Initiative. The Whole Person Care Initiative launched in November of 2019. So ACCESS also connected with stakeholders and identified key areas of focus within Arizona communities. Those areas are transitional housing, they are non-medical transportation, they are social isolation and substance use. So ultimately, with those things at the frame of the shareholder's mind, the initiative then ultimately led to Enter Stage Left Community Cares and implementing the community care system. Contexture and myself like to show this slide as an example of the factors that can impact a person's health and well-being. If you look at this screen here, only 20% of a person's health is actually directly impacted by their access to health and medical care. The other 80% comprise of a person's behaviors, their socioeconomic factors, and their physical environment. Those areas include having access to fresh fruits and vegetables, otherwise known as, does the person have access to a grocery store or to a small supermarket? Do they have access to adequate pay? Or even more so, do they have a job? Does the individual have access to safe parks or safe areas to be able to walk? Are they getting enough exercise? And do they have appropriate lighting in their neighborhood is another great example. And then for health behaviors, of course, does the individual smoke? Do they drink alcohol? You know, what is the status of their sexual activity? All of these things impact a person's whole well-being. Execution and oversight of Community Cares program would not have been possible without the organizations you see on this screen here. So in addition to Contexture, where I'm at, the HIE, we have the Unite Us team, who is the Community Care's vendor, who we work very closely with, to onboard new organizations to using Community Cares. As part of the Whole Person Care Initiative, Access endorses, funds, and sponsors the rollout of Community Care statewide, making it a resource that is free to organizations that wish to sign up. In addition to that, we work with Solari, who supports the engagement for organizations and CBO partners to roll out Community Care statewide, and the 211 resource directory. Community Cares at the initial rollout had ingested the whole entire 211 resource directory. So if you are a user of Community Cares, you have access to all of the resources that are in 211. The question I get about that, by the way, is that are those resources kept up to date? The answer is yes. There's a bidirectional API between 211 and Community Cares that keeps all those resources up to date. But it does rely on organizations to make sure that they are keeping their own programs and services up to date as well. So just keep that in mind. See, I was reading y'all's mind here. All right, Unite Us, bless you, is a technology organization, and they help streamline the process of sending and receiving referrals in an effort to develop a more holistic, whole person care approach to individuals in the community. So essentially, Unite Us is the platform vendor of Community Cares, who Contexture works very closely with. On this slide here, this is to demonstrate how Contexture is driving alignment across the state of Arizona. So our hands are in many pots, and we have many co-collaborators throughout the entire state. And this screen just gives you a highlight of those co-collaborators. In one area, we have ADHS Wise Woman, which is the Wise Woman grant and the grant recipients for those who are executing the Wise Woman program. We as Contexture work very closely with Access on the SDOH DAP, which is the Differential Adjusted Payment Program, and the TIP, which is also known as Transformation Initiative. Both of those are programs that are within Access. If you want more information on them, let me know. I can connect you with my colleagues that are on the healthcare side of the house. In addition to that, we also work closely with Access and other collaborative partners on housing and health opportunities, otherwise abbreviated as H2O, and reentry. We also work closely with ADHS on diabetes, on the Diabetes Referral Network. And this comprises of two sub-programs who are using Community Cares for DPP, which is Diabetes Prevention Program, and then DSMES, which is your diabetes education. We also have multiple other state and community-led programs. We have a food bank pilot with food banks in Cochise County and Coconino County. In Coconino is with Flagstaff Family Food Bank. In Cochise, it is the Cochise Food Hub, who actually distributes and disseminates to other local food pantries. We're also working in La Paz County with the La Paz County Health Department on the Quartzsite Area Innovative Heart Program. We're also working with the Friends of the Quartzsite Food Bank on in discussion about how we can help them leverage Community Cares for food distribution to the Quartzsite community. So we are everywhere.
Is it okay for questions in between? Is that all right? Only 3 of them.
I guess, go ahead.
It's a quick one. Community Cares falls under Access, or it's above Access in terms of how it's not above it, but where does it fall in the family tree of Access to how it's as the referral process? Like, where does that go? Is it completely separate from Access, or is it a part of Access itself? How it's created and how it looks like?
Gotcha. Okay. Great question. Where does Community Cares fall within the umbrella of Access? Excellent question. So Community Cares is its own separate platform. Access is just sponsoring it. Yeah. So basically, I mean, on a very, very super micro level, think about it as you using the Microsoft suite of products. you're purchasing those products, and you're using those products. Community Cares is a product of Unite Us. And we are, Contexture is essentially the responsible party for rolling out Community Cares statewide. We are basically administrating Community Cares, if that makes any sense.
So what's the difference between Unitas and Community Cares?
Unitas is a technology vendor supporting Community Cares. They are the technology owners.
Okay, so we use Unitas, the platform, or so are we technically using Community Cares?
So it's one and the same.
Correct. A lot of people, that's a great question. A lot of people get that confused. When I say Community Cares, it is the Unite Us platform. You'll see the Unite Us logo within the platform. So,
Community Cares is like the Microsoft, and then there's different products like Unite Us.
probably, I'm not, if Unite Us has other products, I don't know about them, but I do know the Community Care is the referral platform. So, but yeah. Great question. Yes, it has the Unite Us logo everywhere. I think it's branded as Community Cares in the state of Arizona. So, thank you for that question. I appreciate it. No, it's no, it's all good. We have an intimate group here, so I've been able to slow down, and plus I have an additional 15 minutes where I was actually cut short on my last one. I know, so I had to speed network through that. So good question. Yep. Well, who are we talking about?
So he just mentioned that they use Unite Us, and you just said that Unite Us is part of, or somewhat similar to Community Cares.
1 and 1, yes.
So in this diagram, so I work for North Country Healthcare here in Flagstaff, and we've been talking about how we could be a part of Community Cares. It's been a conversation. I've been with them for a little over 3 years, and no one has really taken the step, I guess you could say, within our organization, because we have 11 clinics all across northern Arizona, to be a part of it. Because from my understanding, it's a really good networking and working with like referrals, not only within your agency, but also outside of your agency. But to make those referrals outside of your agency, those agencies also have to be a part of it.
That's a great question. Organizations that are listed in Community Cares, aka Unite Us, don't necessarily have to be on the platform. We have what are referred to as on platform and off platform. So remember, just a few moments ago, I made a comment about ingesting the whole entire 211 resource directory. So we list every resource. So those resources that are using Community Cares will have a little indicator that they're accepting on-platform cases. That means you can send them a referral using Community Cares. Those organizations that are off-platform would, you have the capability of using Community Cares to drop a referral to paper, or you can fax it to the other organization. Because they are not using Community Cares, they cannot accept an online referral because they're not on Community Cares. But so you do have some options. But if it's an organization that you work very closely with and you have a high referral volume, that would be a good opportunity to say, hey, get on board with Community Cares, because then we can do this electronically and we don't have to mess with paper, we don't have to mess with fax, we don't have to we don't have to email back and forth, we don't have to pick up the phone and make a phone call. We can just send it using Community Cares. Great questions. The 211 directory basically is in the platform. That is correct. Yes.
Good afternoon. I am working with the nomination Department of Health, so I'm looking, where do we fit in there? Perhaps we're not there yet, but I did note that perhaps we're the other state and community-led program. I mean, is that where we would fit?
That is where, so just some clarification on the screen. These are the programs that Community Cares is participating with. It is not isolated to this. We go well beyond the screen. This is just an example of some of the community and regional initiatives that we are participating with. Community Cares is rolled out statewide from corner to corner. So we would love to work with every organization, regardless of whether it's healthcare or a community-based organization.
So you work with tribes?
We're happy to. I know that there are, that's probably going to be a question for my leader, Alex, who spoke earlier. We're happy to work with tribes. We want to. We want to work with the tribal nation. I think there are some challenges more at the leadership levels within tribal government. Yeah, sorry. Okay. All right. So the impact of Community Cares. Community Cares, as of February of this year, since its inception, has sent over 267,000 referrals using the Community Cares platform. It's pretty awesome. This translates to the statistics that are available from Community Cares into over 84,000 Arizonans statewide served, which is pretty impressive. And if you think about that, that's roughly the size of the city of Buckeye. Which is really cool. I think Buckeye might be a little higher, but it's pretty close. This also translates down to over 1,500 organizations using Community Cares at the site level. So, and ultimately, the total number of programs available in the state of Arizona are over 3,100 that are listed on Community Care. So since its inception, we've made a significant impact in being in the rollout of Community Cares throughout the state of Arizona. Well, it started with the inception of Access's Whole Person Care Initiative in November 2019. So once that happened, Community Cares came into play less than a couple of years later, and that's when we began rolling out the onboarding process for organizations, healthcare and community-based organizations to start implementing Community Cares as the statewide closed-loop referral system.
So just to circle this, this is part of the CHR or CHW framework or the billing cycle. So when there's a referral, and then the software that's being talked about over there, the bill, the Pear Suite.
Yeah. So this would.
That's part of the network.
Right now, because my brain is all within Community Cares. I only have just a foggy idea about how Pear Suite integrates here, but this, in my framework, this would be the kickoff. This would be your starting point. This is where you are sending the referral. Pear Suite is towards the end point when you're getting ready to bill, when the loop has been closed and you're ready to bill.
I think Navajo is involved when the state provides a referral to Navajo, like for TB infection or sexually transmitted diseases.
I would love to get your contact information or give you my contact information so we can continue that conversation and continue collaborating.
So we with it, so I think that collaboration is happening, but it's not being recorded into the system, into the hubby. So it's still the paper form.
Ah, gotcha. Okay. Well, we'd love you to be on Community Cares and send and receive referrals.
Yeah. We're looking forward to it. I have a question. I'm super confused. So you will do the referral system portion, right? And is that it? Because just a minute ago in the other presentation, they mentioned that they're able to do other things beyond billing, like data management systems and those other pieces in tracking. Is that on your side or is that strictly on the payer side?
That's a good question. I'm not sure. Do you know? Oh, do you know the answer? Okay, we have an answer.
So we can think about Community Cares as where it's only as good as the organizations that contribute to it, right? So when you are a contributor, so say Victim Working Services signs up, or maybe you're already on Community Cares, you can see all of those agencies that you might need to make a referral to. And what they're offering is software that can close the loop. So I think you're going to do a demo, right?
I am going to do a demo.
So let them do the demo. I think it'll be clear once you see the whole thing. But the reason why they're here in relation to community health workers, and it goes back to Ramona's question, is it's like what you just said. It's kind of like the kickoff. So CHWs manage a lot of care coordination with all of these different agencies, transportation, housing, all the things. And so this is a platform, and it's free, that you can use in your organization to be able to make sure that the person actually gets to the referral. So what he was saying, like open versus closed. So if you're an agency that's on there, I can refer, and I have somebody that needs victim witness services. I go on, I refer to you, but you could say on your platform, and he's going to show this to you, right? We're full. He can't take anybody. So then it kicks back to me, and then I can handle that referral with a different agency versus just kind of sending somebody off into nowhere and not ever being able to close the loop. Is that kind of? Yeah. But it's like all tangled up right now because we're trying to show you that CHWs do a lot of that work. So this is an easy platform for them to be able to bring.
And I'm sorry, but did you say the service is free?
So, item number 2 up here. All right, item number 2 up here. Back to the presentation. How much does joining Community Cares cost? 0. That's the short answer. Community Cares rolled out statewide is free to use. So if you are looking for integration and you're using an electronic health record or an electronic medical record, there are the potential of additional costs for that integration if you have an EHR, EMR that can integrate with Community Cares. So, but to use it as Community Cares as intended, it is free. Yep, good question.
It says as at this time. Does that mean it's subsidy now, but later on it couldn't? That it would be something out of pocket if they sign up, but then later on it would have to be paid for?
You are so good, and I'm trying to look for where at this time is located here.
It's third sentence, second paragraph.
For Community Cares at this time. That's a good question. So Community Cares has been free for the last 6 years. So I'll check on that though.
It'd be good for anyone that would be signed up and then all of a sudden dependent on a program that would no longer be free.
Agreed. 100. I do think it's going to continue to remain free. That is the intention, at least from what my understanding is.
Access pays for this.
Yeah.
Yeah, it pays for it, so to make it free for everyone. Certain medications.
Yeah, so good question. Another question, why should somebody use Community Cares instead of another closed loop referral system? There's a couple big, large reasons. Community Cares is statewide throughout the whole entire state of Arizona. So you can see resource, if you are in Kingman or Lake Havasu, you can see resources down in Tucson or San Simon or Safford. You can see resources throughout the entire state. There are closed loop referral systems that are used in different areas of the state, but they are isolated to either region or community, and those do come at a cost. So those are some of the cool angles, and of course, Community Cares, like we said, it's covered by Access, sponsored, so it's free and it's statewide. So Community Cares does support HIPAA, and it acknowledges the compliance within the HIPAA regulations. It is also FERPA compliant. So if you're dealing with kiddos in the education system or anybody else that are not kiddos in the education system, it is FERPA and HIPAA compliant. So there are various consent processes that do come built in with the platform, and we are happy to tailor and design workflows to meet meet your organization's needs with the use of Community Cares. So. In addition to that, we have structure for additional considerations for sensitive and non-sensitive services. The sensitive services would be items such as substance use issues, HIV, domestic violence, and behavioral health services. So there is a way that we can cloak those services so that when you are creating a referral for an individual that is receiving services in one of those categories, that it is only visible between you and the receiving organization. So nobody else outside of that sees that referral. Really kind of cool. In addition to that, Community Cares has custom add-ons. We have what is called an assistance request form, which is a link or a URL that you can embed onto your organization's website, so that when an individual goes to your site, they can request information or request assistance from services. So this is really, really cool. I have seen it done. In addition to that, if you have specific or screening questions for your clientele that you ask in your own process, we have the ability to add those custom screening questions within Community Cares so that you can follow that workflow as well. Community Cares, we got a couple workflow examples. This one right here is a standard one that comes preloaded with the application. Essentially, it's we have an individual. Her name is Katie. She shows up to the hospital to receive services. At discharge, Sue, who is an emergency department social worker, identifies that Katie's got social needs. She then uses Community Cares to gain digital consent from Katie, and then is able to refer to multiple partners. And then she can share Katie's information with those partner organizations and communicate with other community partners in real time. And then when Katie receives care, those updates from those organizations that have requested services from are providing real-time updates by using Community Cares. And then Sue, the ED social worker, is able to close the loop by saying, yeah, you know what, she got, or I see that she got services, so we know her case is closed. This is a pretty standard high-level workflow. Specific to the AZ-CHW hub, another one has been designed. This has been this design was done by my team, and that is that AZ-CHW receives and reviews, accepts a referral. They contact the client directly to assess eligibility and assess the individual's needs. Based on the need, they create the referral to the community organization, including the other CHW orgs. And then AZ-CHW will document the case progress within the notes of the internal case. And once those needs are met and reported back to AZ-CHW, then they document it and then close the original internal case. So this one and the previous slide are just demonstrations of a couple examples of two different types of workflows. They seem similar, and at a high level they are, but there's some subtle differences between them both. So
just to clarify, this hub is the same hub that was talked about over there at the Pear Speed Hub?
Is that real? Is that, or is that fake? Is that like a made up? Is AZ-CHW really a hub?
Because over there on that side, the presentation described all these services, resources, and then it had Community Cares, and then it goes to the hub, and then the hub has all these.
Well, since we have Dr. Arturo Luna here, I know AZ-CHW is indeed an organization because he's running AZ-CHW.
Yeah, we just don't know if they're a hub.
If they are identified as the hub.
Yeah. We can get, he's not in the room right now, so we can get that information.
Yeah.
Not only the hub, but is the hub the same as the hub there? Because my visual cue is like, okay, so that's the hub and the hub, and so you're the same.
You know, it sounds like I probably need to go to the Pear Suite session. And here I am missing out because I'm providing information on Community Cares.
I'm just so new to coming here, that's why I'm just like,
Oh.
We'll get it straight.
Yeah, yeah.
The Pear Suites, they have the ability to build a hub system with Pear Suites. And so whoever is identified as the hub organization or whatever, other organizations can kind of tap in to be a part of that hub. So This is a different hub. Yeah, a hub is a system. Like this table, this is the easy chow hub. That's the Pear Suite hub, and you're like, hey, I want to sit at your table, you know. So you sit, you know, you join that hub if your agency wanted to.
Sure, and that's just what I'm like, is that hub, that hub?
Well, they work.
I was just like trying to make the
These systems
connection.
work together, so I mean, you could integrate both into a single hub.
Thank you.
Great questions. All right. Moving onwards and upwards, I'm going to start going a little fast here because I got to save some time for the demo if you want to see community cares. So the onboarding process for community cares, short and sweet, is join a demonstration session or AKA a demo session of the referral platform. We have them scheduled on a regular cadence every single week. So do that. Next step, after you join that, you'll sign up with a community cares agreement. From myself or my colleagues, you'll get an intake form. We'll also request your organization's W-9, and then we provide you a community cares agreement. After that, you'll receive onboarding support from dedicated team members, which includes myself and my buddies at Unite Us. And then they'll probably set up several meetings and also document your processes to ensure that you have a successful go-live. Then ultimately at that point, there's new user training, and you'll receive post-live support from both the Unite Us, my partners at Unite Us, as well as myself. So you always have an open line with me and my colleagues at Contexture. So. Community cares is easy to use, and the other part of community cares that's great is that there is the ability to, there's data capabilities to it. So there is what is called the Unite Us Insights, which is a Tableau-driven dashboard where you can do analysis and you can look at dashboards at an aggregate level of data on the number of referrals sent, received, at an organizational level, at a community level, at a zip code level, the number of referrals rejected, the number of referrals accepted, the average number of time that passes between the referral sent and referral accepted. So there is a lot of data to be had within community cares. All right, now, I think I have enough time for a demo here.
Heck yeah.
She's twisting my arm here.
Oh, Ben's pulling that up.
Oh, yeah.
There's a
question about is Astro a hub, and is it the same as Pear Suite hub? So Alex can clarify as best he can.
Yeah, it's a good question. I think probably the best way to describe it is they're trying to become a hub actively. I think that CHW is really interested in serving that role for the community, and we're working with them and with Pear Suite to move in that direction. I think the workflow is yet to be exactly determined, but essentially, you get referrals from any type of organization that's using this. I think the workflow is going to be essentially getting the referrals into CHW through community cares, right? Having CHW be a user of community cares, they receive referrals for CHW services from all over the healthcare system. They would then have a contract and an account with Pear Suite where they would, well, let me back up. They would receive the referrals as the hub and then delegate them down to the CHW entities in specific communities, right? Those CHW orgs would do the work and then close the referral out with CHW as the hub. Then CHW has an account with Pear Suite and is able to submit the claims on behalf of those organizations, engage in some kind of like shared savings, kind of like some shared revenue arrangement, pay the CHW organizations for their services, probably take an administrative claim would be the idea. But then there's one entity that the CHWs can all roll up to have their claims submitted and have all their claims paid by one organization, one entity, not have to each individually worry about contracting with the health plans, ASCHW partnership with Pear Suite, can kind of take care of that part of the process and that part of the administrative lift. And then ideally, everybody ends up getting paid for the services that they're providing. Again, that's in concept what we're trying to do. That is something that we're working towards. But I think it is a reality we're not too far away from, to be honest. I think it's just about getting everybody in the room, making sure all the contracts are in place, and then setting up the workflow effectively. The technology exists for this. Like we could, if the contracts with the health plans are in place, like the technology for referral receipt and delegation, and the technology for claim submission through PairSuite, all of that exists currently. It's really just about getting the contracts in place, getting everybody in the room, and then you know, for organizations that are delivering CHW services, it's totally your decision whether you want to work under a hub model with an ASCHW of the world, or if you want to take on that responsibility yourself to directly contract with the health plans. And either of those models work and could work equally well. It's just about, you know, how much are you losing on an administrative cost versus how much do you need to make to clear your overhead, and you know what makes the most sense. You probably have to hire somebody for the health plan contracting, to be honest, if you're going to be doing that on a regular basis. So that's where the tools that Louisa presented on today, I think, can really help. Is like if we plug in, you know, the cost for salary plus the cost for, you know, additional overhead for claims processing, etc. What does that look like if we go with the ASCHW hub model? What does that look like if we go with contracting directly? Those tools are there and available for you to use. It's just about plugging in the right inputs so that you can effectively, you know, make the decision for what works best. And when we have that hub live, we will come back and like shout it from the rooftops, because that will be, I think, pretty game changing as far as at least presenting another option. So it's not just, yeah, you all have to go out and contract with 7 health plans each. Like that's, I don't know how realistic or reasonable that is. So that's my TED talk, I guess. Yeah, but it's a good question, and it's a little cart before the horse. But we want to get the idea out there. It's something that I know PairSuite's really excited about as well, and ASCHW is. But there's some details that need to be worked out before we hit go on it.
Yeah, I've explained earlier, we're a country healthcare, we're an FQHC facility, so we can't utilize like the billing because we already bill at the highest NPR rates with access. So I would like to know more about the routes with the hub, like ASCHW, or with our organization we work with HealthStar, which is with EHS. If they're a hub, like we could go through them. But I also have additional questions regarding, is it like per CHW that bills for their visits? Or like how would that, I have all questions.
Yeah, for sure.
If we can table that, I would, but since the C3 event that I attended in Sholo late last year in fall, I've been really wanting to collaborate with your organization because we had Veronica there. Yeah, love Veronica. You know, but I know she did talk about some challenges, so we really would love to collaborate. So, okay.
Can you do a demo in 5 minutes?
All right, y'all forget the demo, sorry. All right, I'm kidding. No, I'm gonna breeze through this demo, okay? And best possible, I'm gonna steal a little bit of your time because I'm supposed to have you out by 2:45. So y'all okay if I keep you to 2:50? Okay, I've just made up 5 minutes now. All right, great. All right. So forget my demo environment. It is defaulted to Omaha, Nebraska, okay? So I know, go Huskers. All right, so I'm going to use my username. I'm going to have to log back in again. Okay. Don't you love this auto log out here?
Do you want to see, I think he has to switch screens, right? We can't see what you're doing.
Thank you. I didn't even know that was still up. There we go. Oh. All right. Thanks, AV guys. All right. I'm using my email as my username, and I'm going to go ahead and email or use my password. And what I'm doing is I am wearing the hat of a person who is sending a referral. All right. I have Ben 10, who's come in here, and he says he needs some food. Woe is him. And I am working in an organization called the Holy Name Housing Corporation, and I am a housing organization. But Ben 10 says that he needs some food. So I'm going to jump into Community Cares here, AKA Unite Us, one and the same. We went around about that a little bit earlier, and I understand why, so. Now, on my screen here, if you are only one house or one organization, you will not see this screen. This screen will show up if you belong to more than one organization. In my case, I have a hat for Food Bank Heartland. I have a hat for Holy Name Housing Corporation. All right, so as an employee of Holy Name Housing Corporation, I'm going to select the appropriate organization. And the first screen you will come to if you are only with one organization is the dashboard. The dashboard will land you directly to the inbound referrals of needs action. Under here, since I have Ben 10 in front of me, I am going to look in the system to see if Ben 10 exists and or if we have served him previously. So I'm going to hit the plus button in the top right corner, and I'm going to hit new referral. Under new referral, I'm going to look for Ben 10. Ben 10. And his date of birth, he's geriatric. I knew I was going to get a snarky response from somebody. There we go. The system looked through the whole entire nationwide database of individuals. Since it did not contain a match-to-match for an individual that's been previously served, it automatically redirects me to create a new client screen. In the new or create client screen here, I'm going to fill out the demographic information on this individual. I have gender, sexual orientation, marital status. Notice here we have undisclosed. Undisclosed is the default. If you have an individual that does not want to provide that information, they are not obligated to provide it. It's helpful if you can garner that information, but you're not required to. All right, so under that, I need to get some contact information from Ben 10 here. And he is going to be in 928 551 0000. All right, and it's okay to call him, it's okay to give him a message, it's okay to send him notifications. I'm going to scroll down here, and I'm going to save client. Once I save client here, up in the top left corner, it has Ben 10, who is just a newly registered person in the system. Also notice it says no consent here. I cannot send a referral on this for this individual or on behalf of this individual without their consent. So until I've gotten the consent, it's going to show as a red flag here indicating no consent. Clear as mud? Great. All right. Scrolling down. So, oh, look at that. That is funny. Okay. All right. All right. So here I'm going to identify the organization I'm going to send a referral to. When I look for that organization, the cool thing I can do is I can look on a map over here, and I can maneuver around similar to like a Google map. And then I can also default to search a specific area, or I can look for the available resources over on the left-hand side. Right here, I have Food Bank Heartland. Notice I have a cool star here. I have favorited this item, so I can immediately fetch Food Bank Heartland anytime I log into the system. I'm going to say, since Ben 10 said he needed food desperately, I'm going to go ahead and say Food Bank Heartland. I'm going to add this as a resource. And I'm going to say Ben 10 needed access to emergency food, and he needs access to ongoing food from a food pantry. I'm going to check those two boxes right there. I got two added resources here. When I click this button for added resources, I have a quick preview right here, emergency food and food pantry. I have two options. I can create the referrals directly, or I can share these referrals as resources to Ben 10. By doing that, I have the option, the cool, neat idea is to send them via text. So in here, I can go ahead and text these as resources directly to Ben 10, so he has the contact information for Food Bank Heartland. I can do that, but I can still also continue to create those referrals. So what I'm going to do here is I'm going to select Create Referrals. Under Create Referrals, I'm going to say both emergency food and pantry, apply the selections. I'm going to select Next. Program description, try to be as specific as possible. Client needs emergency food and needs food boxes to last for 2 weeks. All right, afterwards, I'm going to select, I'm going to select Next. Needs food, okay, that's because I have 2 referrals here, okay. All right, hit Next. All right, next screen I go to is Complete Assessments. If there are any additional assessments on this patient or individual, then what I'm going to do here is I'm going to complete those additional assessments. If you have a prepare screening, this is probably an opportunity to create that or to fill out or complete the prepare screening. I'm going to go ahead and select Next here. At this point, I can review my referral, and then I can say if it looks all cool, I can hit Confirm and Submit. Now remember, what did I not get? Consent. So at this point, now I have to garner consent from the individual. I have multiple ways I can use community cares to garner consent from the individual. I can do it on-screen consent where I can read a script to the person who's sitting in front of me, or I can drop it to paper and give it to him or her or it to sign. I can also garner digital consent. I can have them upload a consent. I can also do a telephonic consent. There's multiple ways in community cares where you can garner consent from an individual you are assisting. So for the sake of time and in the interest of the demo, I'm going to go ahead and say quickly go to form here. This is the on-screen consent. By consenting, you agree to share your information with a network team who's going to help you get all these services. You agree to your information being shared. All right, Ben Fisher, please sign. I am signing my name on behalf of the individual I'm assisting. I am saying, hey, I read this to the individual. I'm signing that they agree. Once I do that, I hit accept. The referrals were created, and they were sent off to Food Bank Heartland. Okay, so that was the referral sender. I just sent a referral as Holy Name Housing Corporation. Now, I'm switching gears. Now I am the referral receiver. I am Food Bank Heartland, and I just got a notification that there is a new referral on my dashboard. So what I'm going to do is I'm going to log into Community Cares. And I'm going to go to Food Bank Heartland. Now remember, we land on the dashboard. When we land on the dashboard, we see all of the outstanding needs actions inbound referrals. Here, if you notice, check this out. Holy Name Housing Corporation sent me a referral, 2 referrals actually, on a food pantry and emergency food for Ben 10 here. So I'm gonna open this up and I'm gonna check out the details of this referral. Along the top of this screen, under where it says referral for Ben 10, you'll notice it is in yellow. It indicates needs action. No action has been taken by my organization on this referral yet. So once I review the details of this referral, at this point I can decide if there's action to be taken. When I click on the Take Action button in the middle right-hand side of the screen, I have several options. I have Hold for Review, Send, Accept, or Reject. Hold for Review is probably a container for me to hold it until I have a chance to review a little more detail, or I can send the referral to another program. I can accept the referral or reject it. When I take any of these actions on this referral, the sending organization is going to be notified that I took that action. So for example, if I reject this referral and say, I'm sorry, I'm at capacity, I can't assist this individual, they're going to get notified. If I send this to another organization, hey, I'm at capacity, but Food Bank of Omaha can serve this individual, then I can send it to them. So there's options here. In this case, what I'm going to do is I'm going to go ahead and accept the referral. When I hit accept referral, accept referral, Food Bank Heartland, Food Pantry, the primary worker, myself, case opened, accept. Now that I've accepted this, this turns into an internal case. Now I am working this individual's case based upon their need here. And that cool yellow line has turned green, indicating that this is an open case. So I call Ben 10, say, hey, we got some food boxes for you, come on down. He comes on down, I give him food boxes, say, great, thank you. Let us know if you need any help, we're here and happy to help you. Once I've helped him, I can close the case here. When I close case, I can say, is this resolved? I can say it is resolved. Client received services. Ben received several boxes of emergency food and was made aware to return if additional needs. Close case. The loop on this referral has been closed. Now, the question that came up in the previous group today, does the sending organization know that this referral has been closed? The answer is yes. So, sending referral organization comes back in, they are notified in their email that there's an update on the referral. So Holy Name Housing Corporation comes in here and they say, oh, okay, well, let's see what's happening with Ben 10 here. So I'm going to go to outbound referrals because remember, this is the sending organization. I'm gonna go to all referrals and under all referrals, check that out. Food Bank Heartland, okay. And client name, service, status accepted, updated, okay, cool. So it looks like they were able to help Ben 10, right on. And what are the case notes? Is there anything that we need to indicate? Nope, it indicates that this is all done. Outcome notes, Ben received several boxes of emergency food and was made aware to return if additional needs. So that is the basic crux of the closed loop referral system, Community Cares. We sent a referral, we received a referral, we were able to communicate using Community Cares back and forth between multiple organizations. It is simplified, but this is essentially the crux of the process. As you saw, there's multiple other facets to it, other bells and whistles, so to speak, where you can reject the referral, put an explanation in, you can hold the referral. If there's eligibility requirements for the that the individual needs to meet for your organization, you may also triage them at the time of contacting the individual. And I know we are at like 7 till, so I appreciate you all staying extra. Thank you.
Hello. Hello and welcome. Welcome everyone. How was your break? How was the last session that you attended? Really good? Okay, we're gonna get going. So we're gonna present on our lessons learned from the standing order and billing for CHWs in Medicare. So my name is Nora Lozano, and I work with Equality Health, and I'm going to be co-presenting with...
My name is Sandra Baca. I'm the manager of clinical care operations at Equality Health.
Awesome. Oh, yeah, and I'm the director for community health workers. So let's... this is the agenda. Really, this is going to drive me mad, so I'm going to... Okay, so we are going to be talking about, as I said, our lessons billing for CHWs, what we learned, what we are changing, and why are we doing it. Okay, so who is Equality Health? I don't know if many of you are familiar with our organization, but our organization is a delivery system, a health delivery system that we partner with health plans, and we also contract with a network of primary care providers. And our aim is to provide better access to health for the patients that that the providers have in their panels, and we are supporting the primary care providers to be successful in value-based care. So as we are aiming to deliver better health access to our patients or our members, we call them members, we are supporting the providers with value-based care, and we are partnering with health plans. And all this, we have teams that provide the services and the support for the providers for them to be successful in their own practices. But for us, we are able to provide a holistic approach to care for the patients outside of the clinic. So how does that work? They are seeing their panel of patients, but they only have, 15 minutes with the patient maximum, and they are able to see that they have needs beyond that that they can address. Some of these primary care providers don't have the infrastructure to do care coordination or referrals for SDOH or even the screening. Some of them do, but when they identify any SDOH needs, they are able to send referrals to us. Also, we are able to see in the health information exchange that patients are being admitted or discharged from hospitalizations, from whether it is mental health or regular health, right? And so we are able to see that, and we proactively outreach to the patients, and we meet them at the hospitals at bedside, and we start that connection. So we are able to establish rapport and follow them after the discharge and support them with the SDOH needs that they may have, with care coordination, with healthcare navigation, and advocacy. We have a interdisciplinary care team, and we are integrated with MPs, CHWs, chaplains, care coordinators, and care specialists that that we are able to support the members, right? So our community health workers and nurse practitioners are able to go in the field and meet the patients where they are at. The community health workers not only meet them at the hospitals, but they also go and meet them at their homes after they're discharged. And all these services are really important. They are really bridging the members to the health and social services that they need. And we are able to connect them not only with those services, but with their PCPs. We are able to help them manage their disease, and they also are able to close the gaps in care that they have. And all these services we've been doing in our program for the last 7 years. The way that we've been sustaining our program for the last 7 years has been with the managed care savings that we are able to obtain from the care coordination and being a managed care organization, right? But since the onset of the billing with access from April of 2023, we've been having conversations on, hey, let's do this. Let's bill. Let's be one of those pioneers that are billing, because it's not sustainable. If we want to have more CHWs, we need to use the infrastructure that is out there. So we want to talk about the steps that we've taken and the lessons that we've learned. Yeah. Oh, there we go.
Okay, thank you. So as previously mentioned by the other speakers, community health workers must hold an active certification through the ADHS. In addition, the ordering provider must also be registered with Access. And we've included links to for quick access here. To the APEP portal for easy access. Within the APEP portal, we also have to upload a list of the certified CHWs within the organization, and this list must be updated each time there's like a new hire or there's a new CHW. This APEP portal must be updated. I think that one's it here. That's pretty much.
Yeah. So we understood that we needed to have this infrastructure. We already had the MPs billing, so we already had our account. We heard today how it takes like almost a year for a lot of people, for a lot of organizations when they're trying to register themselves as providers. They take a long time. For us, even though we already had this infrastructure, we were already billing for MP services, it still took us a long time. So it's important to understand the challenges, but if you do it and follow the process, eventually it took like 6 months or more, a little bit more? A little bit less than 6 months? Okay. So, so yes, just know that it takes time, but we use the infrastructure that we already had. We certified our CHWs. Currently, we have 10 CHWs, and 9 of them are certified. The only one that is not certified is because she just started and she has like 2 months with us, and so she's building those hours. But out of our entire team, we want them to be certified not only for the billing ability, but for the credibility and the standardized quality of care that we're providing to our members. So there's a lot of requirements. When you look at the access and you start studying on what is it that you need to do to bill, seems like it's overwhelming. We understood that if we follow every single step that Access had, and we attended those workshops that were offering with technical assistance, and so we designed a way that adapt our processes to the billing processes that Access had, so we were successful in embarking into the billing for Access. We were talking, as I mentioned, to our leadership. It took us some time to convince the leadership that this was going to be worth it. That yes, we were successful in the savings, in the share savings to support our CHW program, but we wanted, just like it was mentioned this morning, of how not just billing is the sustainability infrastructure, but you can do the billing for Access, you can do grants, and you can do other things, maybe Medicare, and the share savings, right? So we finally convinced our leadership, and we wanted to have a sustainable billing process. So we understood that there was a lot of requirements in a standing order that we were already using with our MPs and our MDs for other services. Sounded like a good idea. And so we started implementing, and we built this document that standardizes the process, the protocol of the valid ICD-10 code that is linked or associated with the chronic condition. and the diagnosis that the patient has, and then that it's medically necessary, and the CHW and the provider is recommending the supporting services that the CHWs are doing. So we establish it in there. We only bill for one code. We do the 98960, which is the individual code. We do not bill for groups because we do one member at a time. We do provide services for their family, but the patient for access is just that one member, so we use that. So as we studied and understood the requirements, we thought, well, let's use these starting orders. Let's maximize the reimbursement ability, and then also ensure that compliance, the compliance processes are there. So we learned, right, that there's the, well, no, we didn't learn. The access, it's establishing that there's the authorized services that are the, let's see here, the patient's self-management education, training services, training service system navigation, resource coordination, and health promotion. We knew that we were already doing that. Our community health workers do face-to-face. This needs to be face-to-face, whether it's in person or it's in video. We knew that we were providing already that. And we also knew that some of our interventions lasted 30 minutes or more. So we were having all the requirements to be able to build. So we just, there we go. We built the standing order for these services.
Okay, so this slide highlights why having the proper authorization and documentation in place is so essential. So first, it confirms the medical necessity and ensures that the provider has recommended and authorized the services, which is a core access requirement. It protects both the member, the organization, and it also helps us stay compliant with access policies and audit standards. When everything is documented correctly on the front end, we're better prepared for any audit review. And another key benefit is that it supports the timely and consistent care. With proper authorization, the staff can move forward without needing, repeated individual orders. And it also significantly reduces the claim denials or the recoupments when there's any missing or incomplete documentation. So finally, it clearly defines the scope of services and the roles of the staff involved. This ensures accurate billing, reduces confusion about who can perform what services. So it defines the scope of services and staff roles for accurate billing. So we have a dedicated staff member who manages all of our billing. She uses a standing order as a checklist. So to verify that every encounter that is submitted for billing meets all of the required criteria. So she confirms the patient is enrolled in Medicaid, the patient has a documented chronic condition, is at risk for a chronic condition, or has documented insecurities, transportation insecurities, food, shelter, has to be documented. And then that there is a documented CHW referral in the medical record signed by a provider. So it's an NP, MD, or PA, and then that there's consent forms. The services provided are clearly documented, and that documentation has to include the total time spent, ensuring that we stay within the allowable limits, which is 4 units per day and 24 units per month. This process helps ensure the accuracy, compliance, and clean claims. Yeah. Do you want to add anything to that one?
No, thank you so much. So what we wanted here is, I know that there was a lot of questions on how do we present it, or is Arizona already using standing orders? There was questions earlier if it was allowed. Yes, we've done it. We've submitted claims, and we've successfully proven that a standing order like this can help you and your program to document and have compliant claims that you are able to submit. So this is going to be, I believe, shared, and you are able to kind of like look at the kind of like this standing order and see if it is something that can help you build in your program. By no, and I want to say really by no means that we've been completely successful. We have a 30% rate of claims that have been paid. We learned out of those. However, it is not the standing order. It's been different challenges that we're going to talk in a little bit about what are the bottlenecks on billing or in getting the reimbursement. But for the standing order, this is what we have. We once the CHW completes the SDOH assessment, we identify that need. And we document that need, and then as we are documenting that need, that triggers for a communication to the provider, who is able to see the need identified with the patient, and he is able to then do the referral or sign the referral.
Yes, he has the provider has the option of accepting the recommendations or declining the recommendations. So it doesn't replace that provider referral.
Correct. And so this is how it looks once. I mean, this is just the template for as an example, but this is how it looks already in our EMR. So I know that we just attended this wonderful workshop on Suite on how they are doing it. We use our an EMR, which is Athena Health, and we were able to build the processes, the templates for documentation that are backing up the services. We are able to track the time and make sure that it is the 30 minutes. If we see that the encounter did not meet the requirements that we needed, we are not going to submit. But once everything, all the stars align, and we are able to submit the claim, this is how it's going to look. And so the provider is going to sign the referral, and we are going to know that that is already reproduced in the EMR. So,
this example only shows a system navigation.
Oh, this example only shows that system navigation intervention, right? As and as it was said before, you don't need to do all the services, but all the services are kind of in a bundle for the each code, so you don't have to bill for each one. If in this encounter we would have had more than navigation, if it was coordination or education, it would all be there. We would not have to do one separate billing for each one. But in this case, there was only one service, which was the system navigation. And now let's talk about the challenges and the lessons learned. And the reason that we wanted to share with you all is because I think that in the workshop that we just ended, they said that you don't have to have it perfect to start, right? You just have to start. And that's kind of like what we wanted to do. We thought that we were prepared, that we built a system, an ecosystem, and an infrastructure that we thought was proven to be successful. Little that we started learning some challenges. And in these challenges, we, well, first of all, let's see, limited visit types that meet all the requirements. As Sandra was saying, we we design our processes to meet the needs. And we even have a staff in our team dedicated to make sure that every single encounter that is going to be built has all the requirements. If she encounters anything that the staff, the CHWs are missing, she is going to send it back and say like, hey, fix this. Or simply, if it was, for example, the time, we're not gonna force the time to be 30 minutes just so to build. We know that, well, if it was 18 minutes, then we just pass and we're not gonna do it. So we have limited visit types that meet all the requirements. Also, a lot of our members may be here in Northern Arizona or maybe in Tucson. And currently, we only have CHWs in Maricopa. We used to have in Tucson and in Flagstaff, but currently, we only have our CHWs in Maricopa. So what happened here is that we're going to be calling. And unfortunately, telephonic interventions are not part of the billing options, right? You have to be either in person or you have to be telehealth. And with telehealth, that's another little bottleneck that we have. Our patients, our members, the majority of them are Medicaid recipients. Actually, all of them are Medicaid recipients. And our population lacks of technology literacy. And a lot of them don't have Wi-Fi. They don't have devices that are allowing them to do telehealth, or they don't know, even if they have a phone and they may know how to use Facebook like nobody's business, they don't know how to do a telehealth visit, right? So that is a challenge. If they are older adults, they don't know, they don't have support. So that is a challenge. So our barriers with telehealth, the remote workflows, yeah, they are going to reduce. If our CHW is not able to drive, we're not going to be able to provide an encounter that is billable. Also, our pilot started with 2 plans. Shortly after we started our pilot, that we decided to let's see if this is going to work for us. That one health plan did not approve any of our claims, so we kind of concentrated on the plan that was actually approving the claims. So we kept billing in that one. However, we started in August. We started August, September. By November, December, they came up with a bundle, a B bundle. This B bundle integrates the 3 billing codes for CHWs in this B bundle. That means that those claims are not going to be paid because they already paid somewhere down the road with other services. So all the encounters that we have submitted, they have come back declined because they belong in the bundle. So that's another challenge, right? But it's also a lesson learned. And then the apparent increase of denials. Yes, we see a lot of denials, but in reality, the volume that we are billing is not yet sufficient or enough for us to prove that billing is not worth it or not sustainable. So we're going to continue to advocate, and we are going to be partnering with others that are billing or are trying to bill, like the next presenters, to see what can we do as a state, as a network, as a community, to see if we can have conversations with the health plans and learn from them, ask them, what can we do? Why are you not paying? And what is it that we can do to get reimbursed? Do you want to talk about some lessons learned?
I think the only one, the NP co-visits.
Oh, yes, the NP co-visits. So some of the encounters that our CHWs have is there are that we go to home visits and we complete home visits, whether it's face-to-face with the MPs, and the MPs come with us to the home of the patient, or we provide the technology for, among other services, we provide the technology for the MPs to have a telehealth appointment, and then our CHWs go and drive to the patient's home and provide that technology so they can have the clinical visit, and then do the care coordination, the health navigation, and all that other stuff. When we were billing for these encounters, we learned that we were not able to bill for the MPs and the CHWs on the same encounter. Even though they were billing for their services and we were billing for our services, it was the same day, and it was a denial. So those are also lessons learned. Nowadays, we just started another pilot that we have embedded CHWs into the practices. So now we have CHWs that go to the practices and start outreaching from the practice for those patients that belong to the practice. Yet to see if we are going to be able to get any claims paid if we are providing our own services at a practice. So more to come on that one. We have it. We just started, actually launched Monday. So we just started to do that. So we're gonna be we're gonna continue, and we are going to open, hopefully, convince our leadership to open the opportunity to build more health plans, to start learning more, because the more we learn, the better we are going to become billing and getting reimbursement. And with the tools that were shared today, we're definitely going to be improving our processes. So that's that with our presentation. Thank you so much.
And I guess Navajo County Public Health's journey. We're just barely getting started. I did want to introduce myself. My name is Sherry Thrasher, and I am the Public Health Office Manager. And then I have my co-presenter here, Janelle. Go ahead and introduce yourself.
Hi, my name's Janelle Lynn. I'm the Public Health Director for Navajo County Public Health. How many of you guys, are any of you guys employees of a county health department? No? Okay. So this may not be as applicable to you, but still we can share some of our information. We are excited to enter the realm of billing for community health worker services. As a public health department, we have been billing since 2009 for other services that we provide. We were the first health department in the state of Arizona to bill for public health services, and others have followed since. Some of those bill conglomeratively through an agency called TAPI for just certain services like immunizations, and some of them bill independently through other models. We are licensed as an outpatient treatment center, so that's a similar license that a doctor's office would hold, and that allows you to do things like clinical assessments, treatments, supportive health services. And so what we found is that by billing under that model, rather than a public health model, we have had improved success. So that's how we set up our billing model to begin with and have been billing since 2009. And here's the reasons that we have done that. We've had better payer familiarity. So with the payers, they have accepted this practice of billing more readily because they're more familiar with it. It's how acute care systems bill. So they're accustomed to reimbursing under this model, and it's reduced confusion and administrative pushback as we have billed for public health services. Stronger reimbursement rates. We have had typically been allowed a higher reimbursement, leading to more sustainability than our partners who have billed under public health models. It has provided simpler provider credentialing, so when we go to credential our providers, it's been easier to do as billing as an outpatient treatment center than under a public health model. We've had fewer denied claims billing under this model, which has helped also minimize the administrative burden of appeals and things like that. And it's allowed us broader billable services. So in public health, we largely use standing orders. And this has still allowed us to lean on that standing order billing model and has worked for us for other public health services. So we see that as we move towards being able to bill for community health worker services, we see the standing order model being able to work here, helping us with reimbursement and overcoming some of those public health billing limitations. This helps us with improved financial stability, alignment with integrated care models, and then operational efficiency. So billing in public health, like I mentioned, is not super common, especially in rural communities. But OTC licensure is very common in rural community health departments. So we see that as could be an option for other county health departments. Okay, so as we have started looking at moving towards community health worker services, as public health departments, we are going to be receiving Rural Healthcare Transformation Fund allocations. And this is one of the things we have chosen for our health department to invest those funds in, is to work towards building a community health worker service model and billing infrastructure. So we're going to prioritize establishing that billing infrastructure to develop that Medicaid and payer-aligned workflows, documentation standards, encountering tracking systems to enable us to be reimbursed for those services, to implement competency-based training for our community health workers, aligning their training and supervision with the Arizona certification requirements for community health workers, also with public health core competencies and with the access standards so that we can ensure compliance and billable service delivery. We're looking to integrate technology and AI supports, look at things possibly like different billing models or software and programs like that, but also how can we also bring AI technology into what we're doing, because in public health, one of the things we're always taxed with is overburdened staff. Our resources are so thin, so is there additional capability to engage AI in that? To pilot and refine reimbursement pathways, and I think a lot of those have been, covered here today. But Sherry's going to talk a little bit about how we might envision that looking for us. And then, with the goal to transition more towards financial stability with that braided model that we've heard about several times today. In public health, grant funding is precarious, and it's been really unreliable the past year and a half. And so we're just always looking at ways that how do we make things more sustainable? And we see this as a real opportunity to do that and invest our rural transformation funds in a way that hopefully can set us up for success for years to come. So I'll pass this to Sherry.
So we have our rationale for utilizing an OPT billing pathway. OPT billing offers strengthens documentation by directly, I can't see with my glasses on, so I'm going to take them off, directly trying services to provide directed care and documented treatment plans. This reinforces medical necessity, improves reimbursement timelines, reduces claim denials, and enhances audit readiness, while maintaining public health ownership and operational alignment. CHW referral and service workflow formalizes existing practice without changing service delivery. Patients seen by provider are identified through public health programming. Treatment plan includes CHW referral. CHW assigned by public health. CHW provides education, coordination, SDOH support, time and activities documented consistently. This workflow reflects what is already occurring in practice, but introduces standardized documentation steps. Public health maintains operational oversight, while documentation supports medical necessity and billing compliance. The model is designed to enhance sustainability, not alter service or scope. Oh, there we go. Last one. All right. A 30-day documentation cycle allows CHWs to capture cumulative patient engagement activities such as outreach, education, resources navigation, follow-up coordination, at the end of the cycle. Time is compiled in standardized intervals and reviewed prior to submission. This process improves documentation accuracy, supports internal quality assurance, and strengthens audit readiness. So compliance and documentation considerations, the core elements would be provider-informed treatment planning, documented medical necessity, time-based service tracking, standardized documentation practices, appropriate CHW certification. Let me go back. So just a little bit of clarification. This model does not bill standalone CHW visits. It documents medically supported services within a treatment plan. It's not my friend today. There we go. So anticipated operational benefits would be sustainable funding stream for CHWs, reduced reliance on short-term grants, standardized documentation processes, improved SDOH intervention tracking, enhanced patient engagement, stronger care coordination. From a public health perspective, this approach supports long-term workforce sustainability and program scalability. It allows the county to maintain full program ownership while improving financial stability and accountability for services already being delivered to the community. Public health-led clinical supported reimbursement alignment. This model remains fully public health-led. The county retains operational control and community health worker services continue to be a public health driven. The OPT billing pathway serves to enhance documentations, alignments, and provide informed care plans. This approach strengthens compliance and supports long-term program sustainability without changing the core mission or structure of public health services. And I just would like to give credits to Susie Salvo-Went from Summit Healthcare. She has been so helpful with this presentation, and I also want to thank Janelle Lynn for her help as well. So thank you.
We have some time for questions, a couple minutes for questions, because we just heard two pretty different models with the same goal, with this idea of standing orders, and I just think we do have tribal health departments in the room, although not county, but some of that that might be relatable with how counties are setting up. I just had one question about, I don't know what an outpatient treatment designation is. Do you think you could just say that a little bit more?
So different healthcare entities have to be licensed through the state health department to operate as a medical facility or organization. And so the category that we fall in as public health departments is an OTC license, or the outpatient treatment center license. That's also the same category that a doctor's office falls into, so a primary care practice. And so that gives us that flexibility to bill under the same model that a provider's office would, which is a lot easier when you're negotiating those contracts with your payer because they understand that model, where public health models, they struggle to understand the concept. And then also sometimes they are not as eager to reimburse at quite the same rate.
So just, so then as in your example, Navajo County Health Department, you wouldn't necessarily, if you remember those two pathways, you wouldn't necessarily want to stand up the community-based organization because you already are the outpatient designation, which is pretty much pathway one. It's the provider director. And that's how you have that medical director or medical kind of oversight that allows the billing to flow from that other model.
Yes. That's how we see ourselves proceeding, but we wanted to highlight the other option because other departments may want to pursue another path. There are also larger health departments like Maricopa County that they're not licensed as OTCs, and so they're going to be looking at more that public health route, so they may be pursuing a whole different model than us. So there may be different public health billing models. That's the route we're going to explore because it's the route we've had success with through the years. It's already established. We have the systems in place. We have the contracts in place that we can easily tag off of.
That's the key, the contract.
Or more easily. Like they said, they were already billing for some services too. It's still different. It's still bringing in those more community health approaches. But Susie at Summit is amazing, and she loves to help people. So we just want to get people excited about this and not be intimidated. It is intimidating, but it's also a real opportunity. And if we all work together and we share lessons learned and we support one another, I think it's going to be a great opportunity and have a lot of success over time.
And we do have another quick break before we switch rooms again. And I know Christopher is already set up in the next room, but they have not come over here yet, so I'd give them a couple minutes. But let's see, it's 3:50. We're going to reconvene at 4 o'clock in both rooms.
And that'll be our last session, and then we'll have some snacks and
Hello. Hi. We know that we are in between you and the networking snacks and all that. So we're gonna get this going. So we go for the networking. So welcome, you guys. My name is Nora Lozano, and I am the director for community health work at Equality Health. And I'm gonna be co-presenting with my co-worker and teammate.
My name is Sandra Baca. I'm the manager of clinical care operations at Equality Health.
Yeah, and I'm gonna lower this a little bit. Okay, so we're gonna be presenting today on CHW Medicaid billing and the standing orders, and we're gonna share with you guys our lessons learned on billing access and using a standing order. And so, well, this is the agenda. For those of you that have not yet heard of Equality Health or you are not familiar with our organization, Equality Health, we are a healthcare delivery system that we are supporting providers to be successful in value-based care. We partner with health plans and well, we actually contract with health plans and partner with the providers, and we help them, these independent providers, to be successful in value-based care. We provide the technical assistance, we provide the technology, and we also provide infrastructure and services, such community health workers, to support their patients beyond their clinics. And so our member engagement, right? We talked that we exist to support those patients from the providers that belong to our network. Our member engagement teams are different. We have the care coordinators, we have MPs, we have clinic care specialists, and we have chaplains, and we have the community health workers. Our care specialists are the call center. They are on the phone. They provide care coordination, a little bit of care coordination, but it's a quicker engagement over the phone, and a quick referral to community-based organizations, and a link with their primary care provider. That's over the phone, and that is for those patients that are not as high risk, high need, high cost. Our team of complex care team are more dedicated to the high risk, high cost, high utilizers. And so we have our MPs, our care coordinators, our chaplains, and their community health workers. And we operate under a holistic approach with body, mind, spirit, and environment. And with the environment, we do the social determinants of health and the care coordination and the navigation that you all are familiar with community health workers. So we've been doing this work for the last 7 years, going into 8 years since we started our CHW program. And since then, our community health worker program has been sustained by the shared savings as we are a care management organization, right? And we are able to sustain this program this way with the shared savings. We are not getting grants, though in occasions we've obtained them, but it's not the main sustainable funding resource for having our team operate. And so there has been conversations, or they were conversations in the past, that Access was going to approve these codes and all this anticipation. And finally, in April of 2023, when these codes were approved, we started conversations with our leadership team on like, hey, let's do this. Let's take advantage of the hard work that the state and all the allies and CHW workforce was advocating for. Let's do it. And since 2023 till the last summer of 2025, we finally were ready to embark in this pilot. Well, actually a little bit before, because at the beginning of 2025, we decided that, yes, we're going to do a pilot, we're going to start billing, and we started with our application, and of course that took time, and we're going to talk about the APEP application that we submitted to have all the requirements ready to build. But in August of 2025, we finally started our pilot. We chose two different health plans to start the pilot, because those services that the CHWs are providing to our members, the health coordination, the navigation, the education, the advocacy, and building relationships to support their health goals and outcomes are essential. But also it's essential to fund these programs. And so we know that the more we have to choose from, not only the shared savings, but using the sustainability on the infrastructure that our health system has here in Arizona, it was a good idea. So we're going about to share the lessons that we've learned and we are learning. Here you go.
Okay. So as previously mentioned by other speakers, community health workers must hold active certification through ADHS. In addition, the ordering provider must be registered with Access. So we've included links to the APEP portal for easy access. Within the APEP portal, you'll also need to upload a spreadsheet or a list of all of the certified CHWs that are associated with your organization, and this list must be updated. So each time you have a new hire or a new CHW, we need to maintain this list updated.
Thank you. And so for us, we currently have 10 CHWs in Arizona, and 9 of them are certified. The one that is not certified is because she's brand new. She's like 2 months or 3 into the job, and we are waiting for her to build the hours of experience to be able to apply for that certification. But it's been a pleasant experience. Let me just tell you that with the assistance of AC Chow, with the last few CHWs use that scholarships that Dr. Luna was talking about. So if you are thinking about it, please use them. They are wonderful. And literally 2 days later, we were certified. So ADHS is really doing a great job on certifying really quickly. So yeah, very easy process. So as I said, we were already using CHWs. We already had a program. We already were sustainable, but we wanted to start billing. And we thought that using that standing order was going to facilitate the process, because it was going to ensure that we were compliant in our documentation, that we had all the requirements that Access is asking. And so we didn't want to leave any details behind. And since we have providers within our team, medical providers that are facilitating these referrals, then we said, okay, a standing order is the way to go. So for us, we are only billing for the 98960 code, because we only serve one member at a time. We don't do groups, even though we provide services for the member and their families. The patient, the Access recipient is only one at that point, so we only bill for that one code. But as we understood the requirements, we kind of design our standing order to meet every single of those needs. And those needs were that, of course, our CHWs are certified. That was one. That the services that the CHWs were going to provide were aligned with the ICD-10 code, and they were associated with the patient's chronic health condition and the diagnosis, and they were documented and identified undocumented insecurities that were refer or necessary for the patient to to improve their health. So we already had that, and then we were documenting the code. We chose which code we were going to use. If you're going to use if you're going to be doing groups, of course, you can use the other codes. And for the code, for this specific, the 960 code, it needs to be authorized billable service. So the patient self-management education training, service system navigation, resource coordination, or health promotion, which is within the scope of practice of the community health workers. We knew that we were only going to be able to bill if it was a face-to-face, whether it was in person or telehealth, video and audio, and 30 minutes or more. We understood that those were the encounters. If our encounter met all those requirements, we were going to be able to bill, and we had that documentation, that protocol already structured to facilitate the order. And our licensed practitioner signs off that order, which generates the services.
So this slide highlights why having proper authorization and documentation in place is so essential. First, it confirms medical necessity and ensures the provider has recommended and authorized the services, which is a core access requirement. So this protects both the member and the organization. It also helps us stay compliant with access policies and audit standards. When everything is documented correctly on the front end, we're better prepared for any audit review. Another key benefit is that it supports timely and consistent care. With proper authorization, the staff can move forward without needing to repeat individual orders. It also significantly reduces claim denials or recoupment that happens when there's like incomplete documentation or missing documentation. And finally, it clearly defines the scope of services and the roles of the staff involved. This ensures accurate billing and reduces confusions about who can perform what services. I think it's your other one.
Mm-hmm.
Okay. So this, we have a dedicated staff member who manages all of our billing. She uses the standing order as a checklist, and this is to verify that every encounter that is submitted for billing meets all of the required criteria. So she confirms that the patient is enrolled in Medicaid, the patient has a documented chronic condition, is at risk for a chronic condition, or has documented insecurities. There is a documented CHW referral in the medical record signed by a provider, a licensed provider, so an MP, an MD, PA. The consent forms are in the medical record also. The services provided are clearly documented. The documentation includes the total time spent, ensuring that we stay within the allowable limits, so that doesn't exceed 4 units per day or the 24 units per month. So this process helps ensure accuracy, compliance, and clean claims. And this slide shows an example of what a CHW referral generated in our EHR. So the referral includes the ordering provider, the relevant C codes. There's a documented reason for the referral, like Nora mentioned, patient self-management, education or training, service system navigation, resource coordination, or health promotion. This example here only shows one system navigation intervention, but if there were more, it would appear on the referral. And this is saved in the patient's medical chart.
Thank you. So, as Sandra said, that document lives in the patient chart. We use an EMR called Athena Health, but you can use any EMR that you are using. We just completed that workshop, seems for per per what? What's the name of it? Per suites. Which is great because they are going to be able to serve as a hub if in the case that you or your organization is not using an EMR. We do use it, and so we are able to store there or have the documentation in the chart for each of our patients. So anyhow, we've been using that, right, since August. We've been billing, and our rate is 30% of the claims that we have submitted have been paid. Now, sounds great, but no, not really. I mean, it's oh yes, you got paid for some, but really 30% could be super improved. They were talking about their goal is 90%. Yes, our goal is 90% too, or more, 100%. So here we want to share with you the challenges and the lessons learned. We are proud of the efforts that we've done and the claims that we've gotten paid, and most importantly, the knowledge that we've gained throughout this pilot, because that's exactly why we start with a pilot, to learn and then to scale. So the challenges. So limited pilot plans. We started with 2 health plans that we are billing. We then reduced it to 1 because one of the health plans was not paying anything. And so we decided to, well, we're not going to play with that one. We're going to use the one that is paying. However, after a couple of months of billing for this health plan, it was announced that they were using a bundle, B-bundle payment. And so that means that they are not paying separately the reimbursement, which in theory, the services that the CHWs are providing are already being paid somewhere down the line. And so we are not being able to obtain reimbursement for those services. We have limited visit types that meet all the access requirements. That means that those 30 minutes, sometimes we're not going to push for 30 minutes if it's not necessarily. So sometimes we are not able to bill because we are not meeting the time, right? Sometimes, yes, we are, and then perfect. But also in this requirements, it's that it has to be in-person or telehealth audio. Currently, we have CHWs in Maricopa, but we have patients all across the state. And that means that if our patients are here in Flagstaff or somewhere in Cottonwood or down in Tucson or Yuma, we are not able to do face-to-face. And the telehealth is challenging for some of our members. They might be older adults, or they might not have the technology or know how to use the technology. They may have a smartphone, but may not know how to do a telehealth visit. So that reduces the opportunity. It's a barrier for our members to have that access to technology. The remote workflows that we have, right? If they are in Yavapai and we are in Maricopa, yes, we have these limitations that sometimes it's only over the phone that we are able to see them. Or, for example, we outreach to our members or our patients at the hospitals. That's the first encounter that we have with them for those that we are able to encounter in person. However, we're not able to bill when they are in the hospital. And our second appointment, the first time that we meet them are at the hospital. We're not able to bill for that because they are already under the care of the hospital. And then we schedule a home visit for when they are discharged. That home visit normally comes with an MP. which because we are completing their follow-up appointment after hospitalization, which is a care opportunity, a care gap, a quality gap that we want to make sure that we complete. However, we noticed that the MP co-visits, if we are billing for CHWs and billing for MPs for the same encounter, it was not allowed. So, of course, we're going to keep the MP because it has higher rates. So that reduces our opportunity. However, we're able to do the SDOH assessment and all our intakes. And after that, then we may schedule follow-up interventions with them and then have the ability to bill. But yeah, this really translates into apparent denials, right? Or not denials, but less opportunities to bill, and then also getting denials that we don't really understand why we are not getting paid. We've talked to the health plans and the representatives of the health plans, and they really just point out to the policy, but they don't provide that technical advice. But we're going to be using some of the tips that we learned here today to really talk to the health plans and advocate for and negotiate for rates. Some of the lessons learned is get your leadership bias to start. It was said before today, you don't need to have a perfect program or a perfect plan. You just need to start. And so don't be intimidated. Yes, it's hard, it's a lot, but just to start and keep learning and modify and pivot as needed. Register your providers as early as possible in the APIP program or portal because it takes a long time. So the sooner you do it, then the sooner you get it done. Have your CHWs complete that certification, voluntary certification. Create your documentation charts on your EMR. If you have an EMR, as I said, we use Athena. Create a billing checklist and have a process for audits. We have a designated person that provides that for us, which is really great. And identify patterns of denials if you get them, so you are able to articulate this when you talk to your health plans. And those are so far the lessons that we've learned on billing for access. However, it is possible. We're doing it. You can do it too, and then we can help each other along the way. Thank you.
I wanted to thank Nora and Sandra again. I thanked them before, but they've been helpful. I like to glean from their information, what they've learned and their knowledge. So I'd like to thank them again. My name is Sherry Thrasher. I'm with Navajo County Public Health Services District. I am the Public Health Office Manager there. Janelle here, she is going to introduce herself, but I appreciate her and her co-presentation with me.
Hi, my name's Janelle Lind. I'm the Health Director for Navajo County Public Health. Are any of you guys employees of a county health department? No? Well, the people that are here with us? Okay. It's just kind of good to know your audience. So we are a public health department in Navajo County, and we are really excited to be starting the process to enter the world for billing for community health worker services. So we were kind of asked to present to you today on what led us to start this path and this journey, and why we think we can be successful in that. So we have been billing for our public health services, other types of services, since 2009. We were the first health department in the state of Arizona to bill for public health services. And we have been doing that successfully. So billing is not completely new to us, and therefore it was intimidating to us back in 2009. It's less intimidating to us now. We have billed as an outpatient treatment center. So We have to be licensed to provide health services in the state of Arizona, and we are licensed as an outpatient treatment center through the state health department. That's the same licensing category that a doctor's office is licensed under, so any primary care provider office. So we hold that same type of license, and so that is how we bill. There are now other health departments that bill in the state. Some of them bill that way. Some of them group together and bill under a public health model through different companies similar to like Pear Suite. And then there are some who just bill off of independently but under a public health model. So why did we choose to bill as an outpatient treatment center? Payer familiarity. So for the payers, when they're looking at reimbursing, they are familiar with this type of reimbursement model. That's what they're accustomed to, so it reduced confusion and administrative pushback when we entered the world of billing from a public health perspective for public health services. Stronger reimbursement rates. They are typically allow for higher reimbursement rates on this model than for public health billing models. Simpler provider credentialing, so it allowed us easier credentialing of our providers under the model we bill under. Fewer denied claims. It minimized the rejected claims in the appeals process. Broader billable services, so it expanded our billable service flexibility. In public health, it's common to work off of standing orders, so we had always operated under standing orders, and we were able to find a way to incorporate that into our billable model, and we have billed primarily off of standing orders since 2009 and done that successfully, so we see opportunity to go ahead and move forward with that as we move forward with community health worker billing. We're looking for it to be able to, it provided us with improved financial sustainability on reimbursement reliability, alignment in integrated care models as we've worked to integrate behavioral health and physical health services, and operational efficiency for workflows, staff expertise, and things like that. So outpatient treatment center licenses are common in public health departments, at least in rural settings. Not so much in urban settings, but in rural settings, this is a common designation for how to be licensed. However, billing in public health departments is not common, and it's intimidating, I think, to a lot of public health departments. They've relied heavily on grants and as primarily their funding source. Oh, I forgot the financial stability one. So one of the things that we have decided, we are going to be receiving rural healthcare transformation funds, and we've decided for our county to largely invest those in developing a community health worker service model and billing infrastructure. We want to do that to establish the billing infrastructure, to develop a Medicaid payer-aligned model and workflows, with documentation standards and counter tracking systems that will be able to be reimbursed for those services. To implement competency-based training, to align our community health worker training and supervision with the Arizona certification requirements, with public health core competencies, and with access standards so that we can ensure that we are compliant with billable service delivery. We see opportunity to integrate technology such as maybe exploring the Pear Suite or things of that nature, but also is there opportunity to integrate AI supports in public health. One of the things we never have enough of is resources, whether that's financial resources, staffing resources. We're always stretched thin. So is this an opportunity to explore AI, and how can we maximize that as we build this model? To pilot and refine reimbursement pathways, to assess Medicaid and other payer billing opportunities, to test service models, and to refine processes to ensure financial viability in rural settings, and to transition to financial stability. Public health funding has been really precarious, especially the last year and a half, 2 years. And so we're really looking at other things that might help sustain us better. Looking back today, as they talked about that braided approach, we see this as a real opportunity to braid into our sustainability model. We also see opportunity that there could be to build a hub within public health for community health services, for peer support services, because in rural communities, those things are almost non-existent. And one thing that is stable and reliable is your public health department. And so maybe we could become the hub for some of those things. But we also see that it's going to be very important to track data, to have reliable data, and to help use that data to tell our story of why value-based care is making a difference and how this is making a difference, and use that to tell our story to payers and to our different funders and to our county administration as we look for funding to help support the work that we do. And Sherry's going to tell you a little more about a couple of different public health models, one that we intend to use, and then some other options because not all county health departments bill.
All right, OPT billing offers, they can strengthen documentation by directly tying services to provider-directed care and documented treatment plans. This reinforces medical necessity, improves reimbursement timelines, reduces claim denials, and enhances audit readiness while maintaining public health ownership and operational alignment. CHW referral and service workflow formalizes existing practice without changing service delivery. Patients seen by a provider are identified through public health programming. Treatment plan includes CHW referral, CHW assigned by public health. CHW provides education, coordination, SDOH support, time and activities documented consistently, documentation aggregated and submitted through OPT billing pathway. This workflow reflects what is already occurring in practice, but introduces standardized documentation steps. Public health maintains operational oversight, while documentation supports medical necessity and billing compliance. The model is designed to enhance sustainability, not alter service or scope. A 30-day documentation cycle allows CHWs to capture cumulative patient engagement. There we go. Activities such as outreach, education, resource navigation, and follow-up coordination. At the end of the cycle, time is compiled in standardized intervals and reviewed prior to submission. The process improves documentation accuracy, supports internal quality assurance, and strengthens audit readiness. Compliance and documentation, the core elements. Provider-informed treatment planning, documented medical necessity, time-based service tracking, standardized documentation practices, approved CHW certification. Just for clarification, this model does not bill standalone CHW visits. It documents medically supported services within a treatment plan. Anticipated benefits. From a public health perspective, this approach supports long-term workforce sustainability and program scalability. It allows the county to maintain full program ownership while improving financial stability and accountability for services already delivered to the communities. And those anticipated benefits would be sustainable funding stream from CHWs, reduced reliance on short-term grants, standardized documentation processes, improved SDOH intervention tracking, and enhanced patient engagement. public health-led clinical supported reimbursement alignment. This model remains fully public health-led. The county retains operational control, and community health worker services continue to be public health driven. The OPT billing cycle, the billing pathway serves to enhance documentation alignment with provider-informed care plans. This approach strengthens this. I'll go back. It doesn't want to work. This approach strengthens compliance and supports long-term program sustainability without changing the core mission or structure of public health services. And then I would like to give credit to Susie Salvo-Went from Summit Healthcare with her wisdom and advice, and of course, Janelle Lynn. Thank you.
All right, good afternoon, everyone. Excited to run this session with you all. I thought this morning's sessions were really great. Lots of context, lots of background, lots of information about the process from start to finish, the why, the how, the steps along the way. So hopefully we can add on to that and maybe fill some gaps along the way to understand how we can get everyone ready for billing. My name is Kobe Takeda. I'm with the Pear Suite team. CHW myself actually taught courses during the pandemic and have since worked with CHWs across the country. I think we're in like 30-something states now, and every state's a little different, so it's always fun to learn about the state policy, the people in the state, who's doing what challenges they're facing, and we're here to help. I'm joined by my two colleagues, Julie Garcia and April. Do you guys want to introduce themselves? We have a pretty long session. Share your background in community health as well.
Yeah, of course. Hi, everyone. My name is Julia Garcia. I'm the head of operations here at Pear Suite. I lead our network of providers, CHWs across the country, and also support with a lot of the training and compliance for different organizations. So really great to meet you all. My background started in population health, supporting a rural health system, and I've been supporting community health workers at different organizations since. So really great to meet y'all and excited to work with you.
Good afternoon, everybody. I am April Avila. I am a community health worker. I work on our community engagement and partnerships teams over here. And I started off as an eligibility worker doing SNAP, Medicaid, and that actually transitioned into doing community health work and joining Pear Suite, where I was able to apply that work into the amazing stuff that we're doing all across all these different states. So happy to be here with you all.
All right, thanks. And April has roots in Arizona as well, so it's great to, she's kind of our representative locally. And then Julia is the policy expert, so I'm gonna keep her close so we can go through this good stuff together. So today we're gonna really dive deep into some tools and resources and ways we can support with the different challenges that we're facing across the state. Really quickly, Pear Suite actually started off as a service company, so we were doing community health worker work. We recognize that doing work on paper and spreadsheets is challenging and won't get us very far, and so we ended up building some software along the way, and now work with states, government agencies, public health systems, nonprofits, even health plans to help more CHWs be able to work with Medicaid plans and reimbursement codes. And we do this across 36 states now. So working with over 2,000 providers, impacting lots of lives. We love the work. And seeing this impact that they're having in people's lives. So our mission really quickly is to empower community workforces to deliver care anywhere. We love when we meet people that provide services in churches and grocery stores and schools, housing agencies, and really that's what we see as the benefit of the community workforce. And that's why we thank all of you for doing what you do. Of course, there's challenges, right? There's so many CHWs out there that are doing this work now, but not getting paid and compensated, and we want to change that. And I think this morning's sessions were really firing us all up about the opportunities to be part of the broader healthcare system, align with new funding mechanisms like reimbursement, support value-based care, really show the value of CHWs for people that have money and that can help to compensate and pay for this. But unfortunately, the utilization of these reimbursement codes, the Medicaid and Medicare, CHI, is really low. And of course, we see there's different challenges along the way, and we'll talk about them today. But we'll also talk about solutions. So what can we do about the different barriers to care, about the different barriers to reimbursement? First, I wanted to just hear from some of you. So I'm curious who is in the room. Which organization, quickly go since we have a small group, organization type, kind of what services you provide, and then if you're currently billing or not. Who wants to start? Yeah?
We'll start here. We're University of Arizona Cooperative Extension. Just recently licensed as CHWs in January, but we provide a lot of our work under the First Things First grant, which is the Quality First for early childhood. So we work with a lot of northern rural providers and early childhood centers, providing consulting and general on-site services.
Perfect.
You're also extension, right? No, sorry. That's okay. Yavapai County Community Health Services, Heather Comparents, public health, and also we have a FQHC.
Okay, great. Yeah.
And no, we're
Not
not.
yet.
So I don't think we're allowed to.
Yeah, well, I guess not directly. Yeah, and we'll talk about that a little bit too, is how we help other FQHCs bill without directly billing. So it's like a roundabout way, but yeah, great. Okay, looking at options. Yeah, great, thanks. Yes? Mm-hmm. Amazing. On Brooks' team, yeah, great. Nice. Who wants to go next? Anyway.
So fulfillment of services for Northern Arizona, we have an application in, but not billing yet.
Great, awesome. Application in for ADHS or for certification or access? Okay, great. Oh, all right. Okay, great. All right. Also, teams. Great. How about the back?
Yeah, by Regional Medical Center. We have our own billing and finance department, and they're currently billing out the platform so it can accommodate that.
Great. And you're planning to bill through the NP of the hospital? Yes. Gotcha. Great. Perfect.
And I'm also with Services Services.
Amazing. Thanks. And then.
I work with the Wallapai Tribe. I'm the director for Senior Services, and we are looking at building.
That's exciting. That's what I want to hear. So yeah, I mean, these are some of the same experiences we're hearing across the country. Of course, in Arizona, the services that are covered include any community health worker or CHR services around these different three categories. And of course, despite the access to these programs, we know that there's still some challenges. And this is kind of how we summarize the challenges ourselves. I mean, every state's a little different, and some states are easier to do credentialing, and other states are easier to do contracting and everything in between. But these are just generally some of the challenges. So of course, the health policy, right? Understanding what it means, like what is an NPI, what is certification versus certificate versus credentialing versus licensure. Understanding how to work with health plans, right? They can be very complicated, and there's so many people in different departments who to work with. Technology, certainly, paper forms and claims are possible. We actually work with some groups that will fill out PDFs of claims to submit to get paid, but maybe not be the most cost-efficient use of your time. Supervision hurdles, right? Some organizations can't be supervising providers in some states. You guys are really lucky. You guys can be a community-based organization in Arizona and become a credentialed provider. Other states can't, so they have to work with provider groups or clinics or hospital systems. That's one part of it, but also the clinical review side of things, right? Getting the clinical oversight to make a recommendation for someone to receive services is the other part of that. And then, of course, claims. Getting a claim to be submitted is one thing. Getting it paid out is another. So we'll talk about that a bit. What are the compliance considerations? How do you prepare for an audit? How do you make sure you're checking all the boxes on a claim so you get paid out and you don't raise any red flags with your health plan? These are critical pieces. So really quickly on billing readiness, and I don't want to spend too much time here, but there are kind of 4 categories that we'll go into deeper, but we kind of break it out into organization, right? Your organization, is it ready? Do you have leadership support? Do you have the right tools in place to make your organization operate the community health worker benefit at scale? Do you have the workers? Are they credentialed? Do they have the time and capacity and the willingness to learn? Technology, this is going to fill multiple gaps, and we'll talk about that a little deeper, but it's everything from eligibility checks to claims to verification to managing consent. There's a lot of pieces in a lot of the charts this morning that are sometimes nuanced and complicated, and we can help to break those down with you. Then, of course, operations. How do you operate a consistent, thorough, comprehensive CHW program that, one, meets the needs of your patients or your clients, but also supports the reimbursement and gets you paid? I do have some slides, a little wordy, but I can, of course, share those with you, but these are just the different elements within each of these 4 categories. So you can see here, it's everything from, sometimes change is like the biggest barrier, right? If an organization doesn't want to change their processes or their, operations, it could be a barrier to adopting new software or looking at working with health plans or getting credentialed. So you need that leadership buy-in. You have to understand, the different policy in place. You have to have the maybe sometimes the board approval to get things done. You have to make sure it makes sense financially. I think the tools this morning was awesome for you to compare based on the cost of your overhead and staff and other equipment costs. How does that balance out with any revenue you can generate? And that's income and expenses calculations there. Insurance has been really a barrier for a lot of groups, that they can't get cyber insurance or can't manage the risk of working with the health plan. So that's all things in the organizational readiness category. Workforce, making sure that the staff you have, even if they're not certified yet, can meet the requirements and you can get them certified. Make sure they have the right support from managers and staff that may provide ancillary services, whether it's billing or claims or credentialing or contracting or HR. Some organizations we work with have 1099s, others have W-2s, some use volunteers, right? Understanding how you're currently operating is really key on the workforce front. Of course, technology, this is huge in healthcare, right? There's so many news stories around on data leaks and security being an issue. And of course, healthcare is a complicated, sensitive field where data is key and can be at a risk if you don't know how to handle it properly. So making sure that your system you use is HIPAA and high trust certified, has SOC 2, has barriers between organizations to make sure you're not sharing data mistakenly. If it can integrate with other systems like community cares or a billing system, an EHR, all these potential things. I think some of our groups we work with will have like 7 or 8 different platforms, and they try to make it all work together. They have one EHR, they have DocuSign, they have a phone system, they have an EHR that can support their clinical review. They have a separate one for their case management. They'll have a clearinghouse for billing. It gets really complicated if you don't have that interoperability. So all this is really important. And finally, operational readiness. Right? Can you actually put the policy to practice? Can you align your workflows with the requirements of the policy in the state? Can you make sure you document properly and meet the compliance standards of each element of the claim? Can you make sure you support recertifications for your staff and reauthorization of extension of services if you go beyond that limit? And of course, staying in compliance. So now, how do you overcome these barriers, right? There's so many different options out there. There's certainly more than this, but I want to talk through some potential solutions. Arizona, there's a lot of exciting conversations right now around this concept of a hub. There's different groups, local entities that we're talking to that want to potentially become a hub to support smaller entities. It could be another CBO, it could be a state agency. Hubs, and I'll actually have a graphic after this about what a hub is, so I won't say more yet. There's a lot of software now that can solve a lot of the problems that you may be facing. So maybe you don't have a tool to review the credentials or make sure that members you're serving are eligible. There's software for that. Maybe there's you're struggling with compliance on making sure claims are meeting all the requirements. There's software that will make sure you can't submit a claim if it doesn't have all the requirements in place. So I think technology and software in general is a great solution for a lot of the challenges you're facing. Consulting and advisement. I think you guys have a great plethora of resources here. Between the Google Drive and the handouts and the organizations here, you have a lot of information and access to resources. So that's really great. There's also groups that specifically support organizations trying to get started with billing and claims, and can work with you and teach you and train you. And I think there's some good funding rolling around that can help bring them in and provide that additional support. a lot of the administrative burden around billing and compliance could be handled by external teams as well. There's companies that will just take on your RCM, they call it revenue cycle management support. And so there's definitely options there with teams that can take on all of the tedious work that you don't want to do, but you need for claims, right, to get paid. So 4 different solutions. I'll talk a little bit more about the hub model in a bit, but just want to throw it out there that this is potential ways that you can overcome those barriers. So what is a hub? Are you guys familiar with hubs? Community care hubs? Yeah, it's good. And its hub is used a lot in different ways, so I'm going to explain what this hub is, and it can have different forms. But essentially, a hub can provide administrative and financial support for multiple entities under that hub. It's kind of like an umbrella organization. So in this setting here, this is a hub that's set up that can receive referrals through community cares by any of these entities on top, right? Any of these entities may be working with a family or a member or that could receive services. If they were to make a referral through community cares, that community cares referral can go to directly to an entity that can provide services or through the hub. The hub can then delegate or dispatch that member to multiple entities that, based on language or location or a specialty area, may be able to facilitate that care best. The hub can help to delegate those services. The hub also takes on a lot of other challenges, right? Whether it's around administrative burden for documentation review or compliance checks, or maybe they have the cybersecurity insurance for the entire hub. They can take on those tasks. They might also do, billing or claims reconciliation. They might help you with audit preparation. Hubs can have multiple entities that are all CBOs. They can also support individual CHWs. We have hubs that will support lots of doulas at a time because the doulas don't want to take on that role themselves. Hubs can also support other hubs. So we'll have large entities that may be statewide entities, but they'll have smaller regional hubs under them that also need administrative support. So again, it's a way to provide administrative or billing support for multiple entities. It can also help with contracts. So you think about all these CBO 1, 2, and 3, they don't have to get their own contract if the hub has a contract. The hub can have the contract with the health plan, go through all those logistics of getting credentialed, manage the compliance and audits and reports for that hub, and then all the entities in the hub can benefit from that. So again, this is a great way for multiple organizations to benefit. Like was mentioned this morning by Alex, we are helping to launch a hub here in this region and for any organization that needs it across Arizona. This is what we're calling the local, provider network. We don't have a name for it, but it's a provider network, essentially. It's lots of entities, lots of providers, CHWs, CHRs, building under one entity so that you can skip the contracting process and credentialing process with access. You can skip the need to get certified through the health plan, which oftentimes could be a 3, 6, 9 month process or more. In California, we went a year and a half going through credentialing and contracting with one health plan. So not a fun process. Every health plan does things differently, and that's part of the challenge, but certainly some are easier to work with than others. Once you're part of a hub, you can benefit from utilizing their services, and you can go straight to getting the requirements of the CHW benefit fulfilled. So whether that's starting with the screening to understand their social needs, getting that provider recommendation. This is another area where the hub can support. Maybe you don't have a clinician on your team yourself, but the hub has one that is contracted to provide services for the entire hub. In California, we have 3 providers that do CHW reviews and recommendations for over 1,000-something CHWs, and it works because they meet the requirements that you have for the claims, right? Certainly, you can work with local entities or local providers that you want to partner with, and they can join the hub as a contracted provider. So there's other ways to facilitate that relationship with the provider that can review and support recommendation letters. Once you provide the services, you document them in some kind of unified system. You can, with our hub that we're helping to set up, we'll be able to help with calling and texting and emails to any members you're serving. Of course, all that is time you can calculate as part of your billing claims. So you want to use that time to generate more revenue for your organization. And then finally, you can manage that claim as it goes through and is submitted to a health plan. And that is through the clearinghouse. That is fixing any errors, reviewing the CIN, fixing any codes or modifiers. There's a lot of complicated elements to the claim, and we can certainly help with that. And like was mentioned this morning, we're syncing our system so that any organization that wants to make referrals or receive referrals through community cares can do so with ParaSuite. So it doesn't overlap in use cases. ParaSuite doesn't have a referral platform, so that's great. You can still make referrals to other organizations through community cares, and you won't have to log into 2 different systems. You'll be able to manage that case from ParaSuite, get paid from ParaSuite, and then still facilitate and monitor any referrals made through community cares. So pretty great. Another benefit of a hub is that they provide that wraparound support, like I mentioned. They might help you build out your programs and create better workflows. They might manage and take on all of the elements of billing that you don't want to deal with, and you just see the revenue coming in every month. They might help you with audit and compliance to make sure that all the reviews are done correctly. We have all the right codes in place, all of the tedious reporting that you have to do to the health plan, such as updating your rosters every quarter, or making sure you have all of the certifications in place, or all of these different elements that health plans require of their providers, whether you're a doctor, a nurse, hospital system, or clinic, or CHW organization. You have to be able to meet the requirements of the health plan, and that's what the hub can help to do. Quality assurance, making sure that the care you're providing is up to par with what's required in the state, but also is good for the patient and the client. And then, like we mentioned, the contract and credentialing part. So here's just an example workflow, right? Just 2 different examples where how could the hub support your work? So maybe there's a referral from a hospital system that wants to help a family member get connected to a community health worker. They may make that referral to the hub or directly to the organization. The hub will then refer that member to a CBO within that hub. The CHW at that CBO will provide services, and then the hub will submit a claim on behalf of that CHW organization. So again, the hub helps a lot in this case to take on a lot of the onus of managing the referral from a provider group or a hospital system or a clinic. They'll kind of help to navigate the member to the organization. The organization can then do the services, and the hub will take on all the administrative and billing requirements. Another use case, right? Maybe the member comes to you directly, or you're already working with a member under your organization, and you don't have a provider recommendation yet. So maybe you start with a social needs screening, like the Prepare. You then have that submit that Prepare assessment to your provider, who can say, yes, this person has social needs, has unmet needs, has a disability, some other indication that they meet the requirements in the state of Arizona. The provider can submit a recommendation letter to verify that the member has medical necessity for CHW services. And then, just like the other side, that CHW provider can then provide services and submit a claim through the hub. Again, this is meant to reduce that administrative burden and also increase the time you can spend with your patients and clients. Definitely have time for questions at the end, so if any of this is confusing, please let me know. ParaSuite has been able to build a platform that helps to facilitate a lot of this. So we do it ourselves with our providers. We give the software out to groups to use it for their own hubs. We're working with local groups like CHW and others to build out their own hubs to help support multiple organizations. So this is a tool for local entities to do this work both through a hub and as a provider themselves. I think 3-4 providers who are already credentialed in the state, like I think it was mentioned this morning, Unlimited Potential, is already using our software and doing this work and getting paid. So that's great. And it's really meant to fulfill all the requirements of the CHW benefit. And so, like I mentioned, instead of having 8 different systems to manage your cases, to bill, to check eligibility, to communicate with your members, we have all of that in one system, and it can be customized to your organization's needs. And so whether you support food insecurity through a Meals and Wills program or a food bank, it's very different workflows, but they're both eligible for reimbursement. So our system can be customized to your specific workflows at your organization. This is a claims reporting system. We have billing that you can manage from one place. You don't have to leave the platform at all. You can run reports and get all the data you need to get back to your donors and your funders. This is a customization. I know it's really small, but you can see you can customize the workflows and create different pathways to manage members at scale. And of course, we have a mobile app. All of this is meant to kind of drive engagement and get the outcomes you want to see, right? We're helping organizations, like one organization went from like 0 revenue to like $20,000 in new revenue a month for like 6 CHWs or something like that, a small team. So organizations can make a lot of money and do good work at the same time. This is also meets the needs of the health plans. So health plans want to see that you can get the reporting done to show that you're closing quality care gaps. You're addressing some of the HEDIS measures that you want to see. Our platform helps to measure all of that, even efficiency of your staff. And so you can use this to meet all of the last session was really great about how do you show value. Our platform can help to document all of that and make it easy for you to report and share with others. Running out of time, but just two quick case studies. Two organizations that we helped get set up doing work with different populations, didn't have software, and all of a sudden we're able to get paid out through both Medicaid and Medicare billing. We do support Medicare as well, which has a different complicated challenges, but we can support with that both through the software and the provider network. My last piece of advice before I wrap this up is, it's, what does this code say? Let's see. You don't have to be great to start, but you have to start to be great. And I think the idea there is you probably don't know what you're doing yet, but just getting started and jumping in, you'll learn a lot along the way, and you won't know until you get started. And so we encourage everyone to just jump in, feet first, and you'll learn how to make this possible. And we did it 4 years ago, and now we think we're pretty good. So we will help you. Finally, I think some of you guys are joining us for the workshop tomorrow, which is awesome. We're going to help you get set up immediately and hopefully get you started really quickly. We also have a booth in the hallway, so come please talk to us after. And then you can also reach out to April. She'll be our local representative supporting community-based organizations here. And yeah, really appreciate everyone's time and definitely want to open it for any questions that I can answer. Make it sound so simple, right? It's like. Yeah. Yes.
This is so essential, and I'm just so grateful for PearSuite because as Colby really laid out, those barriers are real, very real barriers, and it's stopping a lot of you. And I look into the eyes of many of my friends in the room who have been like pushing up against these barriers, and PearSuite is just such an awesome opportunity, I think, for us, and I think it's really special and cool that you partnered with Community Cares. And so I would encourage anybody that can make it tomorrow from 10 to 1 to join in because I think this is just such a wonderful opportunity to be able to solve some of these problems that you all, like you said, this is your skill set, this is your contribution to the greater good, and it allows everybody in this room to continue to do the work that they do with the clients that they serve. So I just wanted to give you that plug.
Thanks, yeah.
And just, come tomorrow, 10 to 1. We probably will run out of food, but there'll be some drinks, and we'll find some granola bars. So just bring a snack.
There you go.
Any questions?
Yes.
Thank you for your presentation. We work with tribe, with Navajo Nation. It's my understanding that we have an interest.
Right.
And we're preparing our foundation. She knows a lot more than I do.
We have a lot of questions on this. We've been introduced to this, but we weren't sure. We're still searching, and I was thinking where, like, Navajo is New Mexico, Arizona, and Utah.
Okay. Yep.
I was thinking when you were showing that framework or the workflow,
Yep.
where would we fit, to connect to community,
Yeah, and that's an option that would probably be good here, but we can configure it for if you have, we also work in New Mexico and helping people build there, so we can skip that. They actually have a different system there, Find Help, that they're using, and we also work with them as well, so yeah.
In addition to, my question is about, do you have a case study working with tribes?
Yeah.
And are we going to be your first, or?
We have a lot in California. Yeah, a lot of, yep, and I can't pronounce half of them. Konokatoi is one, I think that was pretty good. But yeah, we have a lot of tribes that are using it for different programs, everything from complex case management to CHW billing. I don't think any doulas yet, but yeah, it's been.
Maybe, I don't need to be all like unique or, the complication or barrier that I have is that we have IHS,
Yep.
federal, and we have 638 self-determined, self-governance in one area location. Then we have the citizens that don't.
Yep.
Don't talk. We have a tribal epicenter that even they have challenges to access to data.
Sure. Yep.
And so it just is like, excuse my comment, this sounds too good to be true.
Yeah. Yeah.
Because that's part of the barrier or struggle
Sure.
we have. So it's great to.
Yeah, we could definitely talk about it. I mean, some organizations will do things separate from, the Cerner system or the rest of the EHR that you have set up. Because, and even we work with large hospitals like Common Spirit, where everyone in Common Spirit's on, Epic or Cerner, but the teams working under Common Spirit is working just on our system. And it's just an easier way to get started because, if you try to work with the larger, EHR, it'd take years probably, right? So, yeah. Yes, please.
You mentioned case management. What does that look like? Is it like a data management system where you're putting in service codes and stuff?
Yep, you can put service codes, you can track goals or do assessments for a member, you can track any outreach or health education navigation, we can even do events. Basically, how do you resolve any social or health problems for a member? It's not meant to replace an EHR if you're doing clinical care or, but certainly for the community health worker benefit, it can meet all those needs. Yeah. Yep, and you can add any code, whether it's time-based or unit-based. Yep. Yes? Yeah, absolutely can migrate. So yeah, let us know which ones, and that's easy. And we can build templates for constant migration of data or like a one-time data dump as well. Yeah.
I think, I don't want to cut anybody
Yep.
off, but we'll just do a transition now.
Yes, swap.
If people want to stay here and keep listening, you can, but then there's another presentation.
That's right.
And then Colby will do the similar presentation to probably a larger group that kind of got stuck.
Oh, gotcha. Yep. Yep.
And again, there's a Pear Suite is out there. Come tomorrow from 10 to 1. It's here in High Country.
Amazing. No, thanks everyone. Thanks for the time, and we look forward to talking with you more. Thank you.
Thank you. And then if you want to stay, you can stay, or you can go to that other presentation and listen to that. We're switching rooms today, so it's not.
Let's do it, guys.
She's the director of the CHW program for implementation. Again, Ramona in health promotion, but on the other epidemiology, on the health, human health and service, and then our name is Winston Service Unit, CHR manager,
Just to give people time to get back from the bathroom and get water, so if you need to get some water, feel free to do so. Thanks. Hope you guys, wow, big group. There we go. All right, so good afternoon, everyone. My name is Kobe Takeda. I'm with the Pear Suite team, and we're excited to share more about how we're helping community-based organizations and CHWs and CHRs bill and work with health plans. I'm here with two of my colleagues, Julia and April, and I'll have them introduce themselves in a bit. But just background myself, I'm originally from Hawaii, and I helped to both train CHWs out there and also was doing a lot of frontline community health work. And so I really was passionate about this emerging workforce, and during the pandemic saw how much great things they were doing, and also saw them on paper and spreadsheets, and seeing them take phone calls on their cell phones and struggle with the day-to-day operations of community health organizations. So we decided to help potentially solve that, and here we are today with Pear Suite. So I'll have my two colleagues introduce themselves. They have great connections to community health as well, and so here.
Hi, everyone. It's great to meet you all. My name is Julia Garcia, and I'm the head of operations here at Pear Suite. I lead our provider network of community health workers across the country and help them turn the complex policies into an operating CHW program. My background is in population health, started out at a rural health system, and then transitioned to supporting community health workers and have been doing that ever since. So it's really great to meet you all.
Good afternoon, everybody. My name is April Avila. I am our community engagement manager, and I work in our partnerships team. My background is as a community health worker and as a case manager, and yeah.
All right, and April has roots in Arizona, so she is our local rep here. It's great is that she also did a lot of work with both Arizona organizations and New Mexico and other states that we recently got started to set up, so she has lots of experience with the onboarding process. It's really actually about 50% of our team at ParaSuite is either CHWs themselves or worked in community-based organizations, so we really love that we can bring that experience and expertise to what we do. So today we're going to talk about different tools and ways we can overcome the barriers to community health worker billing. We heard a bunch of great information this morning with resources and around the policy and credentialing. So I think you guys have a really great support system here in the state. We're excited to support that and be a part of that ecosystem and know that there's still some barriers and challenges to getting started. So hopefully we can help give some options to do that. Just quick history about ParaSuite. We actually started off as a CHW billing team ourselves. So we were actually doing the work across 4 different states during the pandemic and recognized that there was opportunity to create more impact by supporting other organizations who were already doing the work and already had the relationships in communities, already knew the resources. And so we started building out tools and resources to provide ample support for more organizations. Now we're working with over 350 organizations across 38 states. We have about 2,000 providers in our network. So we see everything from, organizations working on the streets, doing street medicine, to CHWs in public housing. We have organizations billing at barbershops and students in high schools billing. So we've worked with quite a wide range of organizations, all of which are doing great work in the community around health education, navigation, resource linking, and they just needed a solution. They needed support to get started and make this work sustainable. So we know that there's hundreds of organizations, and I love the fact that there's over 800 certified CHWs in Arizona, so that's amazing. And unfortunately, despite the wide range of providers, we know that billing is extremely low, not just for Medicaid, but also for Medicare. So we want to help to support that and help hopefully bring some support and resources to all of you. Really quickly, is anyone in the room actually billing already? Amazing. What kind of setting do you work in? Is it a public health agency, or is it a hospital system, or CBO?
No.
Oh.
We are a network of, so we have, well, actually it's kind of like a clinic, right?
Okay.
Not, but.
Home visit. Oh, okay.
Yes.
Yeah. For older adults or for all ages?
For adults.
Gotcha. Okay. Great. Amazing. Yes. Anyone else billing? Anyone want to bill? Exploring it? Okay, yeah, amazing. Okay, that's great. So, yeah, you came to the right session. Thank you. So we know that in Arizona, these are the 3 top areas of covered services. And despite all of you already probably doing this work, there's probably some challenges you're facing. Like we mentioned, we work across many different states, and not every state has reimbursement yet. But in the ones that we are working in that has reimbursement, these are kind of the top 5 challenges, right? One, they don't understand the policy. Right? What is an NPI? What is a CIN? What is, credentialing versus contracting versus, certification and certificate program? There's all these different terminologies. So understanding the policy and how that applies to your organization is the first challenge. Second is working with the health plans, right? They've been doing work around clinical care and do amazing things with hospital systems and clinics, but CHWs are new to them. So we have to give them time and give them grace and work with them to make contracting easier so we can partner with them and bring the resources and expertise and experience you have to partner with them alongside other clinicians. But payer contracting is a challenge. Next is technology, right? For many of you, you probably will operate on, maybe Google Forms or Sheets or Excel. Some organizations we work with are on paper and clipboards, right? There's lots of opportunity now to incorporate technology and utilize these tools to increase your workflows, to reduce the redundancies and the tedious work, and hopefully create more impact. But that's obviously a change, right? How do we overcome those barriers with technology? So supervising challenge in Arizona, certainly because there's no standing order, you do need that recommendation on file, right? And if you don't have a clinician on your team, how do you secure that? I know there's another challenge around rural and tribal communities also requiring that and needing it in the healthcare system. That's a different challenge that is different from a CBO who might be in the community, So how do we ensure that supervising provider status is met? And we can also provide the wraparound support of what a supervising provider does. And then finally, claims, right? This is a new process for many of you, unless you've already submitted claims for other programs and services. Claims have modifiers and Z codes, and you need, to be able to indicate your place of service and make sure that you're compliant and meet the requirements of the health plan. This can be really complicated if you haven't done this before. And so we'll talk about that in a bit. At Parasuite, we actually created this really cool tool that may supplement some of the other tools you already have. It's a readiness assessment tool. It's just a check the box of see what areas of this readiness assessment you might already fulfill and what areas you might want to ask more questions about. And what's great about this is it actually can lead to a lot of the resources you already have access to, whether it's through ASCHW or through the resources at NAU or on that online drive that was really cool. Find the resources that can help fulfill these gaps. But let's just go through these 4 dimensions of billing readiness so we can kind of talk through how this could be probably more complicated than it needs to be. The first is around organizational readiness, right? Is your organization ready to pursue billing? That could be everything from leadership buy-in, right? Does the board, does your organization leaders, agree that this is something you want to pursue? Becoming a provider in the healthcare system isn't as easy as it sounds. It actually requires a lot of risk you're taking on by working with a health plan, by taking on the claims, by submitting and dealing with sensitive data. So that's the first decision you have to make. Of course, there's a lot of financial decisions to make. I think that financial tool this morning is really awesome, right? You have to balance out, are the benefits and the revenue you can make from this worth the expenses it will take to set this up, right? There might be expenses around going through certification or getting technology to manage claims or bringing in an RCM team to do reconciliation of payments. And that might not make it worth it to go through this process if the revenue you bring in might not overcome those revenue, so the expenses. Of course, risk management. Not every organization has the insurance coverage that you might be required to have for a health plan. It could be everything from cyber insurance to general liability to providers having the insurance for the provider type that you have. So all of this is things to consider when you're thinking about, is your organization ready or not? Next is the workers, right? Do you have the workforce readiness that you need to do this benefit? And that's everything from making sure that the work you already do aligns with the scope of the CHW services, right? Are they certified and credentialed in the state? Are they not just certified with the state, but also certified with the health plan? That's a different type of certification and credentialing. Do you have the supervision and support needed to operate a team at scale and make sure it aligns and checks the boxes for all of the requirements for this claims process? Do you have a clinical team that you can work with, either directly in your organization or at a partner organization that can fulfill those claims review or do that recommendation letter? And finally, do you need any other support around billing or compliance or QA that can fill those gaps that you might not have on your team? Next is technology. And of course, we're seeing all these reports now of data leaks and sensitive data being shared, and we want to avoid that, of course. So how do you make sure you have all the key measures in place to safely and securely transfer data, to manage it in a way that can support your operations and to help with claims, right? Claims requires things like the CIN or the first name, last name, birth date, being able to document any activities you're completing or medical care that they might be receiving, symptoms, other things like medications could be documented as well. And you want to make sure you have a system that can track all of that safely. This is different from the billing system. And the billing system is a separate type of operation that may sometimes require a different platform or a different software system. So we want to avoid having 10 different systems, right? A lot of organizations we work with will have an EHR, a CRM, a phone system, a billing system, a clearinghouse, an eligibility checker. Sometimes, other tools for mobile device. They might have a signing tool. You can really get bogged down with all the platforms. And so how do you make sure you don't get overwhelmed with that? Finally, the claims is a big part of that, right? Being able to track claims as it goes to a health plan and pays you out. They like their clearinghouses, and so how do we make sure we can work with that? And then, is there a way for all this to work together? Is it interoperability between all these platforms? Finally, operational readiness, right? Is your team ready to align your work with the requirements of this benefit? Can you make sure your programs and services align with the required documentation requirements or the case management requirements of the benefit itself? Can you meet the requirements for claims, submitting it on time and make sure any errors are addressed? And can you make sure that you don't lose your contract because you aren't compliant? We actually work with a lot of health plans who will tell us about organizations that they've pulled their contract back from because they couldn't meet the reporting or compliance requirements. And it's tough. It's like these are new things that organizations haven't done before. So we're always happy to help with them and kind of get them back on their feet. Do you guys resonate with some of these challenges and barriers? Yeah. So let's talk about solutions now, right? So we want to talk about how we overcome these blockers. The first one is around the hub model. And so you can either receive support from a hub or become a hub yourself or join a hub. Hub, you guys familiar with the hub model? Anyone? Interesting, okay, so hub is used broadly, so I'll describe what hub we're talking about, and I actually have a graphic next, so I'll show that. But a hub is essentially an umbrella organization that may take on some of this tedious administrative financial support that you might want to do yourself. They might do your billing, they might do your credentialing, they might have a contract with the health plan, so you don't have to get your own contract, or do your own billing and claims, or have your own insurance to cover your staff. This is a great way to kind of bring on lots of organizations at once. So health plans love this because it's instead of contracting and credentialing with so many different organizations, they can do it with one, and that ownership is placed in that one organization to then manage and support multiple entities. I'll talk about that in a bit in the next slide, but I'll just wanted to introduce that. Of course, there's software and technology that can save you a lot of time, a lot of energy. It's great that you guys have community cares already here, and that's going to help with a lot of these processes, and we'll show how we can align with that and support that workflow. Next is there's a lot of consulting and advisement services, so it's amazing to hear just this morning alone all the resources you have with the documents and the different training, the funding, people that have expertise in this area, so please leverage that. And then you can also leverage outside teams to come in and actually do work for you. So maybe all you're missing, you might have the contract already, you might have the staff, you just don't have a billing team. Sometimes you can contract that directly. There's what they call RCM services, for example, revenue cycle management, that will do this for other clinics or hospital systems or small providers, and you can tap into those services as well. All right, so what is a hub? So a hub is, again, a way to aggregate organizations and take off those administrative, financial, or clinical requirements that you might not be able to do yourself. Here's an example of how a hub can support multiple community-based organizations, right? CBO 1, 2, and 3, as well as maybe individual CHWs. CHW hubs can also support other hubs. So we work with a lot of statewide hubs that have regional hubs under them that will then delegate services down. In this model here, you can see that you might get a referral coming down from a public health agency, a law enforcement, a clinic, a hospital. They can make a referral through community cares, and community cares can then delegate through the hub that services out to a CBO. So in this use case, community cares facilitates the referral to meet that requirement for that supervision of some kind of clinical need based off social needs or disability or language. The hub can then delegate that member out or dispatch that member to other entities to then do all the work, and then the hub can then take care of the billing for that hub. So it really is reducing the burden for all those entities. Here's a workflow that can help to explain that, right? Maybe the community cares referral comes into the hub then refers that member to a CBO within their network. The CBO with the CHW will provide the services, and the hub submits the claim on behalf of the CBO. Then the hub gets paid, and the hub then will pass on revenue to the organization, and then maybe they'll take like 5-10% of the claims just to cover administrative costs of the claims team. But at least you get paid, they get paid, everyone's happy, right? Another use case, maybe directly you're working with a member, and so working with a member directly on the right-hand side. Maybe you don't have a review or a recommendation letter from a clinician yet. You can do a social needs screening, like the prepare assessment. That can then trigger a recommendation request from a clinician. A clinician can be part of the hub or part of your entity. They can fulfill that requirement, and you can provide the services just like you would on the left-hand side. So these are two workflows where a hub could really benefit and support your work and help you get claims faster without having to meet all the requirements of the benefit in the state. So yeah, this is really exciting to see hubs popping up across the state. We're talking to a couple organizations now that want to serve as local hubs. And these are entities that may already do training with you. They already are, aggregating and bringing you together for the events like this. They're trusted entities that we want to support technology-wise, and they'll hopefully help you, meet all these requirements without having to force you to do this yourself. So if you're part of a hub, but essentially you can start billing by doing screenings, securing the recommendation through the hub, documenting services on some kind of technology platform, tracking goals and outcomes, communicating with the members, and then submitting claims pretty fast. I mean, we help organizations launch and get paid within a couple weeks, which is great. And like I said, this is everything from high school students becoming CHWs to formerly incarcerated members who come right out of the prison system, to churches. We have a barbershop billing for services in different states. So really, our whole goal is to make it easier for you all to get paid and compensated and valued for the efforts you're doing, and do so in a way that supports the state's efforts around data, around working with health plans, around working with health entities like clinics. Hubs can also support, and this is kind of what we're helping to launch in Arizona. And so if you're coming to our training tomorrow, we'll kind of share how we can support you. We will help you with a technology system that can document all your work. We will help you with your claims management and take that burden off so that when you get rejected, we can teach you how to fix those claims and get them resubmitted. We can help you prepare for audits so that when the health plan comes around and says, hey, it's time for your quarterly reporting, show us, pull these 5 files for 5 members, make sure that we have all the requirements around the recommendation on file, the consent was collected, the Z codes are tracked, the care plan is generated. We can help you do all of that. We'll help you give feedback on your work, so your documentation standards are met. You have any assessments done are updated on file. Making sure that quality assurance is key. And then, of course, if you don't have a contract yourself or aren't credentialed, fulfilling that role instantly is pretty great. So I'll quickly share about how we do it with our software and then open up for questions. But we basically built a software by CHWs, for CHWs. It helps you achieve all the things you need to do for billing and claims and documentation and to work across the healthcare system in one place. So the platform is both available on your phone and your desktop or a platform or or a tablet. And it can help you with all the different requirements for the benefit. You have care plans, you have documentation. I know this is really small, but you can do care navigation, you can do assessments on it, track all of your work and submit claims. You can see how much money you're making every month. You can get the reporting you need to go back to your funders and show the impact you're having. I love the last speaker about talking about how to show your value, right? Being able to tie this work back to the HEDIS measures, the quality scores that you're trying to document so that health plans recognize how valuable you are to the healthcare system. The platform can be customized. We know that each organization works with different members in different ways. And so, everyone could be addressing food insecurity, but one might do so through a food bank, one might do so through meals, another might help with SNAP eligibility and engagement. That's all different ways to address food insecurity, and our platform can support all of that, right? So all of that time and energy is billable, and you want to get compensated for that. So we can build workflows for each of those, build out templates. Like I mentioned, we also have a mobile app. So literally we train promotores to go out there and literally document on their phone, take notes, press complete, and they get paid for that. And so it's pretty cool to be able to make it simple and easy. We're also seeing really great results on the other end. So organizations that can use the software can do more work. They can see more patients because they're not spending as much time, transcribing notes or documenting in a Excel. They can close care gaps, which the health plans really love. They want to see that you're connecting members to the doctor for their annual wellness visits. They want to see that you're helping to get child well visits or topical varnishes completed. And you can start to do those things and actually hopefully capture more revenue for your organization. Of course, the fee for service, the billing per half hour can generate revenue. We have some organizations we've helped go from like zero revenue to $20,000 a month of additional revenue to help cover costs of their staff and their other services they provide. So that's really great. And a final slide just on reporting, right? So all the things that you need and you would want to know about your impact around the work you're doing, the amount of members you're serving, how your work ties back to revenue for your organization, the return on investment for the healthcare system. This is going to help Arizona continue to commit to supporting CHWs and CHRs and invest in the workforce. And so we want to be able to show this at scale. And so I think the reporting is a really key part of this. Two quick case studies, two CBOs that were not using any software were able to build out their teams, grow their impact, and start to bill for their services. Actually, Tenna, I just visited their offices on Friday, and they're actually building out a hub themselves to bring other smaller organizations, maternal care, and a food bank and a cafe to do CHW services as well. So it's pretty cool to see these organizations start to expand over time, and I think it's the combination, the commitment, and the technology that helps them do that. Finally, my last piece of advice before we open up is really just to get started, right? Jump in feet first. I mean, you won't know what you don't know until you get started. It definitely seems complicated, and we were there when we first started this work, but once we started working with the health plans, getting advice from other people, we learned best practices that can help make it simple. And so, again, you don't have to be great to start, but you have to start to be great. And I think it's all this idea that just commit, get started, you learn along the way, make mistakes, but eventually you can get over those humps and just make your work sustainable. Definitely excited to see any of you coming to the sessions tomorrow. We'll have the workshop where we'll give you logins, we'll get you access to the platform, you can test it out, see what it's like, and if you're interested in joining the provider network and starting to bill, we'll allow you to do that. We also have a team here, so please visit us tomorrow. We also, or today, we also have another team member coming to support with the technology adoption, so that's great. And of course, take advantage of all the resources. It's pretty amazing. We travel across the country, and it's rare to see so much support across the entities here in Northern Arizona with NAU and with different entities like ASCHW and RASCHW. So please take advantage, and thank you so much for having us. Open it for questions. All right, questions.
My question is, you mentioned a referral for a well child visit.
Mm-hmm.
Does that mean that this can do medical referrals as well as CHWs?
Yeah, I mean, it can support any codes out there. If you need to request, are you referring to like a doctor referral?
Mm-hmm.
Yeah, and I think community cares also supports physician referrals, right? You can send it to clinics.
Yeah,
Yep.
absolutely, to and from community-based organizations.
Yep, so, and because we have a single sign-on, you don't have to log into different systems, you can make that referral to a clinician for the well child visit through the platform. Yeah.
Thank you.
Oh, question up here? Thanks. Yeah.
Hi. Could you talk a little bit more about how I saw in your app or in your system that you had some caseload management for the CHWs. Can you talk a little bit more about that? And in order to use that, do we have to do the billing too, or it's a la carte kind of thing?
Yeah, good question. You can use any aspect of the platform that you want, and we have actually a lot of groups that aren't billing in the system, but still use it to track their work. I actually just logged, just because you asked about something I don't have a picture of. Here's the actual platform. Let me just. So if I go here, I can actually review all of the users and see their caseload and kind of track. That's what you asked about caseloads, right? So you can see how many staff you have, how many activities you're completing, how much money they're making you, how much activities need to be scheduled. That's a great way to kind of track the ROI of your staff. And it could be bad because it might look like some people aren't working, but yeah. Yeah, it's a cool tool for that. Yeah, of course. Questions? Yeah.
I think my question was, if we sign up with PearSuite, do referrals then come to us, or do we still need to meet with the different healthcare platforms to get referrals?
Yeah, good question. I'm not sure how it works with community care. Does referrals automatically go to each organization? Do they have to raise their hand and say, I want to receive referrals through community cares?
Are you talking specifically about community cares or?
I mean, when they were talking about the steps to become a CHW, and one of the steps was, you apply for access, and then you have to meet with the different healthcare platforms and present yourself as a vendor to get on their list to receive referrals of new patients.
So probably, I think you just have to register on community cares to say you're receiving referrals, and then.
Yeah. So if you're receiving actual referrals for services services that individuals need. You can do that through Community Cares and deliver the services and then log the services in the PearSuite platform, load them for like claim submission, and then you would get your claims paid through whether it's a hub model or directly with PearSuite. I think the other side to that question, maybe Colby, that you could address is the contracting arrangement with the health plans, right?
Sure.
So as of
Yep.
right now, the CHWs have to individually go to the health plans and contract with them in order to be allowed to bill
Right,
for
right.
their Medicaid population, right? That organization's, that MCO's Medicaid population. And I think that's like a value add that you're working on, right? Is the ability to like contract with the health plans for on behalf of the CHW
Yep.
orgs, and then they would kind of like work under your NPI or whatever.
Yep, and they can actually generate revenue for you, or generate referrals for you. So when we work with health plans, sometimes they'll give us lists of members every month. Other times they'll have their case management team make referrals individually. We have one health plan that will do HRAs every month, and any new HRA will be then referred to us to then send to one of our CBOs to follow up with them. So yeah, this could help with referrals from both community-based partners and clinics, but also the health plans. That helps answer your question. Other questions? Yeah, Arturo? Yeah.
Before service for the tribal health systems, and I'm asking particularly here in Northern Arizona, there's a lot of.
Yeah, I heard you don't have, I just learned today for the first time that you don't have to go through MCOs. So that's a great, because we're already in Access, we're already credentialed there. So I think as long as we can meet the requirement for IHS recommendation or clinician referral recommendation, that should solve that need. So yeah, we're excited to try. I think we have a couple plans to set up for that. Yeah.
Perfect. Thank you.
Yeah. Good question. Other questions? All right.
Can you speak a little more to the different levels of support that are available through PearSuite? Thinking about Nora's question a second ago about like, well, what if I just want to use case management? I know that with the different payment plans, there's like everything from just using this level of software to like full on TA and
yeah, absolutely. And yeah, if you go to our website, we do have like different pricing tiers, but we're actually going to make this available for free for everyone in Northern Arizona, just so you guys can get started, at least for a year or so. So that's exciting. Yeah, we have some groups that will document in their own system and essentially just upload data on their own. So they don't even use our system for case management. They just want to bill through our contracts. Let me show you if I can see it there. So you can actually create an import template where you essentially track all your work on a different system. You create a spreadsheet and you upload it. As long as it aligns with this data, you can essentially generate claims from it. So it's a pretty cool way to maybe not use our case management tools. Maybe you have your own clinician. You want to work with a local provider. You can add them to here. So maybe you want to add a recommending provider, someone you want to work with locally. They can become your local entity, like Josh Green here, and you can tap into them every time you want to request a member recommendation. So right here, you can say, do I want to recommend or request a recommendation? You can request it, and it'll go to that provider on file. So it doesn't have to be our clinician. You can use your own. What else can you do? You can actually even have your own contracts. So if maybe you have one health plan contract, but not the other two, you can leverage your own contract for that one health plan, but the hub's contracts for the other two. That's a good way to kind of deviate and differentiate the different kind of support. So yeah, a lot of different ways we can support you. We have groups that will train up their own RCM team. Other groups will do it for them. So definitely want to see how we can support you all. Other questions?
How long does it take to start billing?
Yeah, that's a good question. So I think the biggest barrier right now, I think, is the contracts with the health plans, right? We are in the process of getting contracted with one, I think. So hopefully, but we've been working with some health plans for years, and it's slow. They're trying to figure out how to work with community health workers and what it means to contract and credential a community health worker. One health plan in California, they didn't even allow people with a criminal background to be CHWs, but that's kind of the whole point, right? They have lived experience, and so they had to fix that policy and then allow for CHWs to be credentialed. So that was like a barrier, but every health plan's a little different with that. once we get a contract, or especially for fee-for-service billing, we can start immediately. We're already in access and have access to submit claims. Yeah. Right here, question.
Do you guys have like a physical boots on the ground office in Arizona?
We don't have an office in Arizona, but we have people and we have local entities that we're working through. So like we're doing a lot of work with.
That'll be another barrier to MCM contracting. There's still some that require
I see.
physical state office.
Actually, we do have one then. Yeah. No. I forgot. Yeah. So the way you get around that a little bit is that we have an address on file. So we actually have an entity, a provider group registered in the state. I forgot about that. I haven't been there, and I don't know where it is, but there's an address on file somewhere. Yeah. Yes.
So what is the success rate for reimbursement?
Yeah. I think a lot of it is tied to the claims. I think everything else is pretty simple. It's the claims. Sometimes health plans, I think it's been pretty good so far. Yeah, we have a couple groups already using us. So like a limited potential uses our software, and 2 other groups use it. I'm not sure what their exact claim success rate is, but usually it starts, around the 80s, 90s, and then it gets a little better over time. The whole goal is that you start building the relationship with the health plan and work with them to overcome any, modifier, miscalculations, or maybe you're missing the place of service, or maybe the claim is reconfigured incorrectly, or sometimes it's the health plan doesn't have the configurations in place for these new codes. So over time, our goal is to get to like 97, 98%, which we've done in other states. So. Yeah, of course. Other questions? What time is the session till, by the way? 45. Oh, okay. Wow, lots of time. Anyone want to see anything else on the platform since I have it open? So this is just the basic overview. So you can see on the top right here, I'm doing an activity right now. So it's actually tracking my time. So I can track in real time how much time you're spending with a member. This is how you generate claims. This could be on a phone call, in person, doing case navigation or finding referrals. It automatically has the health plan tracked based on that member. You indicate what Z codes. So if that member indicates they have a transportation security, you can select that. You can indicate that services were provided by telehealth, by phone. Maybe you want to add a note about what you did. Maybe you can say, completed assessment and completed, what was it? Oh yeah, call center option, yep, completed SDOH screening, helped with food and housing, needs new utilities, wants SNAP. You can write whatever you want, and we have an AI note generator that will help generate a better note for you because maybe your typing sucks like mine did. This is how we can meet the requirements of a health plan. I'm actually not sure what activity I completed, but boom, I can document that activity in real time. I know, it's crazy, right? I know. This in itself will save you a lot of time, right? It'll take any assessment you completed, make sure this is compliant with the health plan. You create that note. It incorporates all the things you just indicated, the Z codes. So then you have a note that meets requirements. You can end the activity. And automatically that claim is on your claims page. So you can submit it immediately or have it reviewed by a team member. It sees an error, but it says, oh, consent not found. So this is how you prevent waste, fraud, and abuse. So you can make sure consent is filed. So you can go back to Art Lee's file. You can say, hey, Art, do I have your consent to submit a claim? You can indicate that they told you in person that you have attestation to give consent. You say complete, and you can go back to that claim, and now you'll see there's no error there for consent. Oh, I have to refresh it. Actually, it's probably the wrong consent configuration, but yes. Anyway, you can meet that requirement, consent. You can track how much money you're getting paid in real time, how much money is still in the pipeline. If there's an error, you can see here why it was rejected. It'll tell you. You can resubmit it. You can track your claim in real time. You have to edit the time or something. Claim approved by insurance, blah, blah, blah. Yep. And then you can track your money. That easy, yeah. Just see the money flowing in, yeah. Lots of data analytics you can track, your impact. This is really good for, improving your workflows and managing your team. This is how hubs you can actually see multiple entities at once, right? So I can pick a lot of groups and see what's the impact of those 5 groups. So when we think about building a hub in Arizona, like we can start to measure the impact across multiple entities. It's a really good way to see that. You can request provider reviews and care plans. Yes, question here, April. Mic's coming. Oh, yeah. Here's for the camera, though. Yeah. Yes.
I have a question about the time recording.
Yes.
I really like that part where I don't have to keep looking at my time when I'm with a patient or a client, and then I know when the 30 minutes is up. But I have a question about the group. Like when you're with a group, does it also do the recording?
You can do the same thing. So let's do a group activity. So maybe you're doing a group class. You're doing a cooking class for multiple members. You can select all the members who attended that class. So now you can create a claim for each of them all at once. You can have unique activities or unique notes for each of them, but you don't have to replicate that claim for each member. And you already have the documentation, like their name, their first name, last name, birth date on file. So that's a great way. You can even reverse this and like check people in based on attending a group activity. So yeah, that's a pretty cool way to document it. This calendar does sync with your Microsoft and Google as well, so you can track it in real time and make sure you don't double book yourself. We even have a way to send out a link so people can book time with you based on your availability. It's like a Calendly link. It's pretty great. And then you can track all of your actual members' claims. You can see how many units you submitted for them. So you can see all the claims process and where they are on file. Yep. Other questions? Yeah. What was that?
Interface with other systems?
So we interface right now with community cares. We can do with EHRs if you want to, but sometimes I recommend not because it's better just working the EHR, I think. Yeah, we're really set up for organizations that don't have any other system that want to just use one. Yeah. Good questions. Is anybody coming to the workshop tomorrow? Staying for the workshop? Okay, great. Yeah, so you'll have access. We'll give you guys accounts so you guys can play around. We'll do some demo assessments and screenings, and you guys can schedule next steps, make phone calls. Yeah, here's like the goal tool. You can track goals, and we even have a recommendation tool so you can, it'll automatically prompt you to recommend members for services based on their social needs. Here's kind of like a social needs assessment that we can collect data from, and then we can use that to either trigger next steps. You can say, if the marital status is widowed, you can ask another question, or you can put them into a certain group. You can say, add members to group. Oh yes, question.
When you request a recommendation from a provider, does it automatically populate here, or how are you notified?
Yes, so say you need the questions around a recommendation from a provider. Would this be for initial services or a care plan review? Initial services. So we would send a link to the provider on file. They can then open that link and see all the recommendation requests, and they can either reprove them one by one based on reviewing any social needs screening, and then you'll get a notification back that it's been approved. So then you'll know when to provide services, right? Yeah. So it's like meeting all those requirements. And yeah. Good question. And this is how we manage the hub. So multiple groups can receive the same activity templates, the same goal templates across multiple entities, and you can track that. This is how we kind of make billing easier by uploading the payments once. So here's like in California, we have all the health plans already contracted, so we can deploy this work across any county and any part of the state. So the configurations are all set up in place already. Each one has all the billing codes, the requirements. So every plan has little different requirements around configurations, so we can upload the CPT codes, track any limitations, and then deploy the same configuration to multiple entities.
This may be a silly question.
No?
Is this just for CHWs, or do you also do, because we're kind of talking about peer support?
Yeah, we do. You can actually accommodate any building codes. So peer support specialists, doulas, some groups working with older adults, Every state's kind of a little different, so.
Another question, Justin.
Yeah.
And let's say we find a MCO, a health plan that is willing to work with us, that person can be customized in terms for the data that they're looking for.
Yeah, absolutely. So we can generate a specific, the question was around customization for health plan. So we've done like QI initiatives, like here's a child well visit screening. So we can create a specific workflow. This is one co-designed with a doctor around what would the CHW, what should they ask about? So here's one around, have you visited your doctor in the last 12 months, right? If not, let's create the well child visit as a goal. If they're interested in more services, you can maybe even schedule a next step, right? Does the member have asthma? Maybe if they do have asthma, you can create a new goal for asthma action plan or something, right? Oh my God, how do you spell asthma? Anyway, create an action plan, yeah. Or here's one, apply for CalFresh, right? So you can create goals based on that, or you can say, if this member, maybe I should, add member to group and put them in the CHW pilot group. So you can create a specific workflow that will drive you to getting the right data, and then also driving next steps. So this is a good way to kind of work with health plans, and they want to work with you, right? They want to leverage your relationships, your trust, and they want to address their HEDIS measures and their stars. And so this is definitely a way to make them excited and want to work with you. And I think there's a lot of interest here in the state for that. So, good question. Yeah, I can recommend. You can even here's a recommendation tool. You can say, okay, who should we recommend to the Kick It California, smoking cessation program? You can say if they, this Kick connection equals yes, then recommend this Kick It California referral. So it'll prompt you in real time when you're doing navigation. It will actually say, oh, this member qualifies for this program or service. Would you like to proceed with next steps? You can do that. So yeah, it's a pretty good, great way to kind of do things at once. Here's.
Or to even schedule like a simple follow-up.
Mm-hmm.
You do an initial assessment, and they'll say, okay, like let me just schedule. You can schedule it right away with the member, and it'll be on your schedule right there, so you don't have to remember to call or text them or if you forget. It's automatically prompted.
Yep. Any final questions? Yep, on time. All right. Well, please come find us outside. We'll be around. And if you have any questions, please feel free to chat with us. Thanks so much for your time.
Good afternoon. I'm Christopher Gonzalez. I am the whole person care manager at Arizona Complete Health. It's nice to be here with you today, and thanks for having me. Today I wanted to talk a little bit about positioning CHW, scope of practice within the MCO health plan priorities. So much about what you've been learning and talking about all throughout today in standing up and sustaining CHW scope of practice. So right now what I want to do is I want to break this down a little bit. And I want to work through some alignment processes through this positioning to help us understand how to take your mission vision and your scope of practice and translate it to the health plan, okay? And how to ask and receive for that information that you need from the health plan through walking through the alignment process, okay? So today when I talk about CHW, please forgive me, but I'm going to use it all inclusive. It does include community health within Medicare, CHI, and it also includes community health representative, okay? Sometimes you may see me forget and use them interchangeably and stuff, so I appreciate it. And you have my email address here if you want to capture that, if there's any follow-up. Or anything, or if you want some intimate questions between the health plan and your organization, okay? All right, so this presentation is really more of a positioning to serve the practical guide for community health workers and providers to align your scope of practice with the health plan. So as we walk forward through the presentation, We're going to walk through some best practices. We're going to look at delivering services, and we're going to focus under the access policy today, okay? We're going to synthesize those requirements from the Access Medical Policy Manual, also known as the AMPM 310W, as well as the official CHW CHR FAQs. And coupled together, this becomes your one policy to support your compliance, your service quality, and your culturally responsive care. It's also going to hopefully help CHW provider organizations align your operations and strategies with your managed care organization or those health plan priorities. Okay? We hope that this will help the CHW provider organizations align operations and strategies, as well as assure consistency within the mission, the vision, care delivery, and those measurable quality outcomes, okay? So a lot of things that you've been reviewing today are here within the things to remember, okay? And I wanted to bring these forward, and I won't go through them in detail because you already are familiar with these things, right? And we hear them a lot, and it's good that we hear them a lot, right? Because when we're looking at making the practical alignment to the health plan mission and vision and those quality priority measures, we're gonna wanna think about the certification. We're going to want to think about the services that are reimbursable for members who have these categories. We're going to want to think about all of those documenting and billing pieces that you have been already learning about and probably have already engaged with as well. Think about the service delivery requirements, the mode of service delivery, whether it's in person or whether it's virtual, okay, or a mixture of. Also think about the limitations. So I want you to think about the things that your CHWs can do and what they cannot do. Because these things that we want to remember may come into play when we start making the alignment to the health plan priorities. Okay? So hopefully this will help us put it into action as well. So within the best practice, we're going to want to look at the cultural responsiveness, okay? This is about delivering education and support in ways that respect cultural values and language, okay? You're going to leverage your trust building because we already know that CHWs are frontline trusted members of their community, right? So you're going to leverage that and build those trusted relationships, not only with the people that you serve, but also with your health plans as well. Okay? Capacity building, we're going to look at collaboration within that best practice. You know, working under the direction of eligible providers and coordinate that across the health and social services as well. And then we're also going to continue to look at the capacity building and how we're going to empower members with knowledge and skills and the confidence to manage their own health, right? Because a part of the CHW scope of practice is to work with those in the community to help get them into the most independent position that's identified by them to carry forward with their health services and managing any of their chronic care conditions. You're going to want to have an equity focus, okay? So sometimes it's taking the terminology that you utilize within the CHW scope of practice and translating that into the terminology of the health plan as well. Okay, so when we're looking at equity focus, you're actually focusing on whole person care, okay? Because the state of Arizona Access does have a whole person care initiative, which we all fall under those requirements, okay? We're also going to look at the documentation discipline, much like you've been talking about through the other sessions is how to comply with those documentation elements, okay? You may have a standard AMPM, a medical policy from Access, to tell you exactly how that medical billing needs to be. But however, within your MCO or health plan, there may be certain nuances. And those nuances may be specific per health plan, okay? So as we walk forward, think about the different health plans and MCOs that you'd like to work with. And I'm going to kind of move pretty fast because, you know, I can go on forever, but they only gave me 45 minutes, and I really want to get to the worksheet. So you can feel free to take any pictures of the slides if you want. I just can't give you the packet, okay? So within, we're also going to look at how to complete each of those alignment steps. And before we continue to move forward, you do have some documents on your table. Okay, you have some of these matrix that we're going to work through when we start with that alignment process, and I'm going to let you know which one that we're working in, okay? You also have some C3 CHW core consensus. These are great handouts and documentations as examples for building your case model. Okay, much like Megan talked about earlier today in the session, okay? We're gonna work within that case model, but we're gonna use the term value story. We wanna help you illustrate your value story. This is what's gonna speak to the health plan. Okay, you also have some other handouts. You have a stapled one with a couple of examples that we'll do some whole group activity. You also have the Arizona Closed Loop Referral Lunch and Learn. It is a monthly lunch and learn the second Tuesday of every month. And there is my email as well as Unitas's email. Unitas and Arizona Complete Health co-facilitate these lunch and learns monthly for you. And then you also have an interpreters available. So remember that, yes, the lunch and learns are virtual. So if you email the either one of those emails on that flyer, then Sebastian and I will get you on that invite list. We spend the first half hour doing technical assistance, and then we spend the last half hour doing live demonstration, okay? And working through those real-time processes. And then last one that you have is an interpreters available poster. Because we want that whole person care, right? And we need to help our members identify any of those alternative languages or those preferred languages that they would like to receive their services in. So this is a poster that you can carry with you that they can point to, okay? So yeah, stop me along the way if you do have any questions. So hopefully this will give you a structured approach. So what we're gonna do is we're gonna look at the element and we're gonna predefine any of those key areas of alignment, okay? And then we're also gonna look at provider alignment through describing how your organization currently addresses this element, okay? And hopefully it'll make better sense as we walk through. We're also going to look at a health plan alignment. We're going to note how the health plan approaches these elements and then how you approach those elements, and we're going to help meet them in the middle, okay, and see if they align. We're going to look at those action steps, a list of actions that you will take to improve that alignment, as well as the responsible parties, and identifying who in your organizations are going to lead these efforts, okay? Also, we're going to have some guiding questions, and we're going to use these questions to prompt us, to help us think about our responses and kind of think through that linear thought process. Okay, so some tips for success. We're going to want to review the MCO mission and vision and those quality priorities before completing any worksheets. So we're going to do some exercises today. If there's enough, take an extra copy, or you can build your own when you get back to your organization. But we're going to use these to practice some of this alignment and engage. Part of the other success is when you're building your value story to present to a health plan, this is really giving them every reason why they need to fund your program and your organization for CHW work, okay? And we do encourage you to engage CHWs and clinical teams in that process to help with any accurate input, things that we might not think about in those clinical aspects, okay? So help bring those subject matter experts to the table for you. We're going to use the action steps to create those measurable goals. Because our MCOs and our health plans, we want to look at numbers and outcomes. We want to see how your services have impacted those priority measures, okay? And why we should keep on funding. Okay, so this is what our value story will do. And then we're going to want to revisit this worksheet. You can do a monthly revisit to track the process, or you can do quarterly, however that you think that the review needs to happen, because as you walk forward, that contracting doesn't just stay the same. It's ever evolving. So we're always going to want to look at our value story and everything that we're doing in that case model that Megan talked about, to showcase why, again, that the health plan or the MCO needs to fund you. So if I remember my you helped me out, thank you. Got it right there. So, the reason why I brought this up, and you can Google this if you have your phone with you and you want to use this through any of the exercises, okay? Because I won't be able to leave this up here because we're going to use the PowerPoint. But I brought this up here really to look at some common mission and vision themes to help us jumpstart. They may be similar to your mission and vision, okay? They may be different, but remember that each of your managed care organizations, your MCOs, and AKA your health plans, they're all going to get priority measures from Access from the state of Arizona. However, by the time that they get to each of the health plans, again, there's going to be certain nuances to those priority measures. So, for example, Access may say, all health plans and MCOs have these priority measures, okay? Diabetes, colorectal screenings, could be something around cardiovascular, well child, prenatal care, any of those areas. And then again, remember that when they hit each of the different health plans, they're all set in different geographical service areas, right? So that means that the populations and the geographical service areas might work differently or be impacted by these priority measures differently, whether it's going to be urban, rural and remote. Okay, so again, when you're looking to align with the health plan or that MCO, you want to look at every single health plan's mission and vision and priority goals to see how they're different. Because if you can build one value story to showcase your services, why a health plan should fund you, you can adapt and adopt that to each of your different health plans or MCOs that you'd like to contract with. Does that help? Okay. So as we scroll down, you'll also see some common priority measures. So they may be centered around health equity okay, and healthcare access to care. They may be around member safety, quality outcomes. And I'll try to point out terminology as we talk about it. So I know that we use the word patient and client, but when we're working with the health plan under the whole person care, health plans and MCOs may refer to those that we serve differently. At Arizona Complete Health, we refer to those that we serve as members rather than patients or clients. So sometimes it could be a word that can really speak to one of your health plans or your MCOs. So you want to build that trusted relationship and just start connecting, having a conversation, and then gradually leading up to those value stories and contracting conversations. And they're going to be centered around physical health, behavioral health, and emotional health, just like under Access's Whole Person Care Initiative. Okay, so there may be value-based priorities, there may be other quality outcome priorities like working around A1C level controls, again, well-child visits, or even perhaps outreach. There are certain members that we serve, or any health plan or MCO serves, that is not engaged in care. And it could be for any reason. It could be from a traumatic event. It could be from any current affairs. We never know the reason. So that could be outreach and helping that member, bring that member back into services as well. So I just bring this up as an example of what they may center around. It's really not going to show you, like the baseline that where we're at, but we'll have some examples that will lead up to that. But I just wanted to really show this as an example. F5. Oh, okay. I didn't pass my training the first time. So, all right. So when we're looking at the key impact on those health outcomes, it's really around the system performance, okay? So these are really essentially to improve the overall health system performance, especially within value-based care models. As trusted connectors who share the culture, the language, and lived experience of the communities that you serve, CHWs, we already know enhance member engagement and significantly strengthen the impact and care delivery. So these are two categories, two elements that we really want you to expound on. It's like building that workflow and process of your member engagement. What are those engagement processes? Because health plans and MCOs will want to know that, whether they're phone calls, texts, whether they're in person, are we driving there? Any of those outreach modalities, or anywhere that you think that you significantly strengthen the impact of that care delivery and what you do, okay? So if we continue with the system performance, community health workers, we already know, again, are essential to the overall health. Studies show that your work, especially within value-based care models, about 23 to 51% reductions in emergency room visits. Okay? That doesn't just touch the healthcare system. That touches every system and every neighborhood and family, okay? So think about that ripple effect in the work that you do and how that might be interpreted into your value story. 21 to 50% reduction in hospitalizations, okay? Again, fewer readmissions and preventable acute care events. So kudos to you. You're amazing. And the amazing work that you do. Now let's show it. Talk about it, okay? But we also want to talk in numbers. We also, when we're working with the health plan, we're working within the quality initiatives. So quality wants to see all those numbers, right? Those percentages and those outcomes. So if we're not tracking, I do want to encourage you to start tracking your services and those impacts, because that's what we want to showcase as well. That's probably the most important piece, okay? Okay. Sometimes I'll get ahead of myself. I'm not going to go through the billing. You know your billing codes. You know the units and how to use them. Thank you, Louisa and NAU. Amazing sustainability template to work within. You also, within the eligibility, you already know the eligibility for your services. I'm not going to tell you about those things. Expanding and billing for your CHW services aligns with those strategic priorities across each of the health system programs, okay? So here, when you're able to align and with strategic priorities, this is going to help advance in value-based care by increasing access to preventative and coordinated services, also strengthens partnerships through culturally grounded care, improves those health outcomes as well as reducing costs, and also you're able to diversify your revenue streams as well. So let's go ahead and start getting into the step-by-step process. So this is where we're going to start mapping out that CHW scope of practice to those HEDIS and quality measures. We're going to want to show clear value to the MCO or that health plan, and we're going to want to build case for contracting and sustainable funding. All right, so that's what we're going to start getting into. And stop me all along the way if you do have any questions. This one is going to be so this one is also your C3 project that you have. So as we're building the value story, I thought that these were some pretty good resources to help to showcase the different parts of your CHW program and some examples from this CHW Core Consensus project. Okay, so they looked at the CHW roles, their skills, and the qualities. And then in this two-sided one, they start talking about why CHW core roles and competencies. Okay, so I thought that this might be kind of good as you're kind of thinking about your CHW scope of practice, what we can and can't do, and kind of how to lay some of those things out for you. You also have some different step-by-step processes. Okay, so when we're looking at clarifying the CHW scope of practice, you want to start with the clear written description of what your CHWs do, okay? So, and remember that your CHWs may hold dual certification because our AMPM 310W says that a CHW can be dually certified in peer support, doula, or other certifications, right? And that they can also bill for those services. So when we're thinking about any of those dual certifications, think about that when you're writing your descriptions on what we can and can't do, because there are limitations between the CHW scope of practice and the peer support scope of practice, right? They can't be delivered same day, I don't believe. Okay, they have to have a distinct delineation of those services. Okay, so there may be a process of what your CHWs can do. This one can do this, but it happens on this day. We can do some more wraparound with peer support over here, but these CHWs can't. Yes, yes. So any of those limitations within their work. And it's good to map those out because that could be a part of your sustainable funding, okay? Is also billing for those other peer support codes. But we also want to make sure that when we're talking to a health plan and an MCO, we may have to do outreach over here. We connect with that person under CHW, and then we can be able to do these other things over here through peer support. Different day, health plan now knows that you're in compliance because you're not going to be billing those same day. So we know that you know the policy. So this is really great too to kind of decipher through those policies because the AMPM 310W coupled with the FAQs, it's not very cohesive. It's not very directional. It leaves a lot of room for perception, right? So this is a great way to really walk through that process and really dissect it and be able to go, oh, these are some additional questions that I have, okay? Can reach out to Christopher over at AZCH and I can ask him. We also have a CHW collaborative, and it is open statewide. It's virtual. If you emailed me on that same one for the closed loop referral, I can get you on that invite where we're doing technical assistance and walking organizations through this process, okay? So just another added support because there are so many perceptions on the policy. Now, those perceptions may also change per health plan. Doesn't mean that another health plan is wrong or doing it wrong and not perceiving it right. It's just how they perceive it to their state contract, okay, and how we interpret those things. So great questions, and keep them coming. So we're going to want to write a clear description. You're going to want to list the core roles and the functions, okay, that they perform. We want to use this framework like the C3 project, okay, under any of those cultural mediation, health education, care coordination, outreach, coaching, advocacy, direct services, and assessment. Okay, so you can kind of list out your CHW roles even within each of these elements because they may change or maybe they won't. But when we walk through the process, we can really look at that lineage, okay? They can specify tasks under each of those roles. So for example, cultural mediation. This could be explaining health plan processes, helping members to understand letters and benefits, because that's a part of our education, right, is teaching those health literacy. And in health literacy, it also includes health numeracy. We need to help our families look at the charts and the graphs, as well as understand terminology and how to break that down. Okay, for example, care coordination could be around scheduling appointments, arranging transportation, closing referral loops. So once you connect any of those specific tasks under care coordination, you're identifying the elements like in the example, but then you can start identifying any of the specific tasks under scheduling appointments, arranging transportation, or closing the referral loops, whether that's legacy referral versus closed loop referral in the automated system, okay? When I say legacy referral, it's the old fax it over, email it over, okay? Things we've done for a long time. Doesn't mean it's wrong, but we have different modalities of doing that. That may be something that you want to call out. The closed loop referral system is probably a good call out and recommended. Health plans have a responsibility to the closed loop referral under the Whole Person Care Initiative from the state, which is really your drivers of health services, okay? And that's screening, providing whole person care, screening for SDOH, and using closed loop referral systems, okay? Under health education, this could be about teaching about diabetes self-management, cancer screening, or prenatal. And then again, any of the specific tasks in those roles that are going to touch each of those elements under that category. You also want to note the limitations of your practice, okay? It's not about giving them a bad taste in their mouth of what you can't do. It really helps to identify compliance and risk management, okay? It really helps to put each of the provider network into the right positioning. So when you're looking at any limitations of the practice, perhaps what your CHWs do and do not do, you know, based on state guidance, CHW policy standards, or even maybe the payer rules, okay? So the health plan may have certain limitations within their provider network that you must comply with that may be different from another MCO, okay? So that's why we want to build like a general holistic one, and then we're able to adapt and adopt to each of those MCOs and health plans. I recommend a deliverable when you're writing this description, at least at minimum of a 1 to 2 page scope of practice summary. If you haven't already, I encourage you to take your Access CMS policy, AMPM 310W and the FAQs, and build a CHW policy and workflow process within your agency. Because when it comes to working with the health plan and an MCO, okay, they're gonna wanna see that policy and that workflow so that that health plan knows that there is a compliance in place. That also can become your template to building your value story and just adding those additional ingredient, okay? It keeps everything consistent and well in alignment, okay? So if you haven't already, I do encourage you to do that. Any questions on step 1? Okay. So within step 2, this is about identifying those priority measures. And the goal here is to really focus on the measures that matter most to the MCO and the health plan, okay? I say MCO and health plan, but they could be the same or not the same, okay? Your managed care organizations are gonna be your REBA. Your health plans are gonna be your non-REBA, okay? So when we're looking at those measures that matter the most and that your CHWs can realistically influence, so we wanna look at what we really can do, okay? Doesn't mean that we can't have aspiration, but if we can focus on the things that can be done realistically within the CHW scope of practice, and not only that, but within the specific work that each of your organizations do, then we can have those aspirations. Oh, if we do well on this one, we can pick up this one, and we can spend that 12 months or whatever that pilot or a contracting time frame is, and then when it comes to negotiation, you can add any of those priority measures, okay? And it can happen midterm. It can be an ad hoc contract change, okay? Or it can be an annual, however that runs for each of the different organizations, okay? So when we're looking at the actions, you're gonna want to request from each of the MCOs their top priority HEDIS measures, okay? So what I would recommend is that you call, if you don't have a relationship with an MCO health plan, you could call the provider services number and ask to be connected to their community health worker department, or a business owner is what the health plan is gonna call them, or the manager of it, or their whole person care manager. They will get you connected to quality, and you can receive those quality top priorities, those HEDIS measures, okay? Because like I said, they may be different nuances to each of those from each of your health plans that you want to work with. So if you have a relationship with an MCO health plan, then reach into your liaison and request those top HEDIS measures. And then you'll be able to bring that back. You're going to use those top HEDIS measures as your baseline, okay? And I'm gonna show you where to put that in the template. That's where you're gonna get a lot of your baseline work as well, okay? So, and this usually centers around diabetes, hypertension, cancer screening, outreach, follow-up after ED visits, antidepressant medication management, and much, much more, okay? You're also going to look at the population segment because each of these HEDIS measures from each of the health plans, like we talked about a little bit earlier, may have those different nuances or population segments depending on their geographical service area and within what kind of urban, rural, remote that you're working in, okay, or that these HEDIS measures are applied to. So it could be members with SMI, severely mentally ill. It could be pregnant people, high ED utilizers, or within specific zip codes, or any identified race and ethnicity, and an underserved population. When you're speaking to a health plan about underserved population, we want your underserved population to be identified by data. That's going to define those specific areas or that vulnerable population, okay? So that we're not just overlaying vulnerability over everybody, although everybody probably is, but we want to make sure that those priority areas are clearly identified. So you're going to look at group measures. Here are some examples. You know, preventative care and screening may be centered around breast, cervical, colorectal cancer, well child visits, immunizations, or any of those social determinant of health screenings. Your chronic disease management may be measures around diabetes and A1C controls, hypertension control, asthma, medication ratios. Also within behavioral health and substance use disorder. Those measures may fall around follow-up after the hospitalization, medication adherence, and substance use disorder treatment engagement as well, okay? Access and utilization to healthcare services and social supports, okay? This may be centered around emergency department overuse, missed appointments, gaps in primary care, specialty care, prenatal care, any of those other areas around utilization. Your social determinants of health and engagement may center around the outreach to get those drivers of health assessments, connecting them to the measures that you're working with, as well as the specific independent, oh gosh, okay. So, I told you I can go on forever. So, all right, so I'm gonna go a little bit faster. So you have here on your table step 3, and that's about building the HEDIS alignment matrix, okay? This is gonna focus on the measures that matter the most. So when you're working within this template, you're gonna, after you collect the HEDIS measures from that health plan, you're gonna put those HEDIS measures here on the left-hand side. You're going to put all of the health plan information here on the left-hand side. Any of the HEDIS measures, the target population, you're going to want to ask your health plan about any key barriers, okay? You're going to look at the CHW activities. This may be where you can look at any of those specific tasks. You may also ask your health plan or your MCO, what activities would you like the CHWs to do as well? Okay, and as long as they fall within your scope of practice, then you would be good. You're gonna want to identify any data and documentation requests and desires from each of those health plans and those expected impacts. And then on the right-hand side, you're gonna write your descriptions. So you're gonna pick apart those HEDIS measures. You're gonna write the name of the HEDIS measure and a brief description of it, okay? You're gonna write down who the measure applies to, that target population. So on the left side, if there are 10 HEDIS measures with several different populations, you wanna tie it, that measure of who it applies to directly to that HEDIS measure, because each HEDIS measure may have similar targeted populations or they may be different. and we're going to want to identify those, okay? You're also going to look at the specific tasks that your CHWs perform in order to impact those measures, as well as what and how CHWs record their work and the activities on, how activities move those measures. In step 4, you also In step 4, you also have a worksheet on your table. This one gives you a little bit of an example, okay? So this one here is you're going to want to turn that previous matrix into a reportable workflow, okay? You're going to identify the trigger, like what trigger is this workflow, and that trigger is basically the need, the condition, or that risk flag. Okay, and it's going to be, you know, the trigger is that HEDIS measure, that's that risk flag, and it applies to members age 45 to 75 flag for overdue colorectal cancer screening. With a health plan, you're going to receive a quality care gap list. That may have 300 members on it, but that acts as your referral. So now you may understand what a referral terminology is to a health plan versus a referral that comes from a health clinic, okay? You're going to have your outreach. You're going to identify all of your outreach, whether it's first attempt, second attempt, third attempt, and each of the outreach modalities that you're going to do. You're going to look at the engagement and education. So these are your CHW activities that you're going to want to do to impact that HEDIS measure and what you want to focus on there. You're also going to talk about navigation and what you're going to do to help members choose screening options, coordinate with MCOs and clinics, schedule appointments, and so forth. You're also going to identify any of the follow-through, and that's going to be about closing the services. If they're agreed to be closed, can't just close a service. When you work with the health plan, you must have health plan permission in order to close a member's service. Okay, you can't just close it. Or whether that's closing the loop on a wraparound service, whether you're using Unitas or any other closed loop referral system. You're going to want to talk about how this supports the HEDIS measures and quality gaps. This is going to loop that back around to that trigger. Okay. In step 5, I don't think that you have a handout, okay? But in step 5, you can take a picture of this one. This is where you're going to talk about the measurable, trackable, and evaluable performance and metrics, okay? Whether it's within each of your measurable categories, outreach and engagement, number of members assigned to the CHW. Think about your ratios and your caseloads. The number and percentages reached, successful contact versus non-successful, and so forth. And then you're going to want to talk about your outcome adjacent metrics. These are your leading indicators, appointment completions, rate among each of these engaged members. So this is going to help you really lay out that performance and evaluation metrics. And then you're going to link that back to your HEDIS measure, which is your baseline of the current performance. And then you're targeted what you think is realistic in that impact and what you think that you can do. And then how the CHW contributes to the metrics that will move the needle forward on there. Okay. You also have step 6, which is translating all of those other pieces into your value story, the alignment into contracting. We won't have time for the whole group activity, I apologize, but you do have a stapled packet there of 2 examples that are just generic, they're all made up, showing each of the elements that we talked about. So when you read that, see if you can identify each of those alignment elements that we just went through. You could even use those examples to help you build your value story. So over here on this one in step 6, which I don't think that you have a copy of as well, so you may want to take a picture. This one talks, you know, it gives you the core elements of the value story and then a little example here, okay, of translating each of those elements into your value story. I believe that you do have a step 7 handout, okay? And this is where you're really bringing some concrete examples to the health plan and the MCO. You want to make it easy for the health plan and MCO to see, adopt, and to fund your model. These are suggested attachments. I would recommend attaching your CHW scope of practice summary or your policy, AKA workflow process, your CHW HEDIS alignment matrix. Okay, you can provide a blank one for them and a pre-filled. Inconsistent with my words here, attachment C could be the standard CHW workflows within each of these HEDIS measures. You could also, we'll want to, recommend that we'll want to see sample reports, or if you have actual reports, or you can mock up any graphs and charts, mock dashboards or tables, really illustrating how you think your CHWs are going to work within this metrics and make that impact. But even better, if you've got some real data, then we want to provide those as well. Your data sharing and privacy overview as well. We want to know how you're going to protect anything related to HIPAA. Okay, so this kind of rounds it out. This gives you a sample template of each of those CHW HEDIS alignments with any of those CHW workflows. So now you can have one of these side-by-sides for each of your HEDIS measures. Okay, so these are the alignment examples that you have in your stapled packet there. And these are things that you already do within your work. These are also things that you want to identify and showcase in your value story, okay? Or within any of your attached supporting documents. We want to know how you're going to conduct drivers of health assessments. Perhaps maybe what assessments that you use. Are we using closed loop referral? Do we have legacy referral? Translate any of those drivers of health into Z codes. Z codes are a part of the whole person care initiative requirements. They must be used. So a health plan is going to expect that, okay? And how to infuse those. How to layer culturally and linguistically appropriate services over your scope of practice, because within that whole person care initiative and requirement also is outlined by class standards. And I'm probably at time, but if you walk away and have any other questions or want to connect with any of the collaboratives and lunch and learns we have, or any technical assistance, Arizona Complete Health wants to be a supportive partner to you. So please utilize my email. Let me know. If I don't have an answer, I will find you an answer. Okay, thank you so much for spending time with me, and I'm sorry that I had to run that so fast. So thank you, I appreciate it.
Thank you so much, Christopher. And one more session happening in
We get started? All right, we got one thumbs up, so we'll make the decision for everybody, right? Sure. All right. Well, welcome everybody. It's great to be here with you today. So thanks for having me here with you to talk about, I'm just going to jump over here just so that you can capture my email address. So please feel free to take a picture of any of the slides, okay? But again, thank you for having me here with you to talk about positioning your CHW scope of practice with MCO priorities or your health plan priorities. So I hope to deliver to you today a practical alignment guide, if you will, in positioning your CHW program into a value story to speak to a health plan and why a health plan should fund your program. Okay, there are a lot of slides here that really go over things to remember that you have already been working well within and heard a lot about. So I'm not going to dive into like the certification or the services or billing, et cetera, into any deep review because you already know these things. But I have them here as things to remember because as we look at positioning your CHW program and aligning with the health plan MCO priorities, these may be some factors that you want to include in your value story. And that, you remember this morning when Megan talked about that case model, showcasing your case model? We're going to use the term value story in making your case, what to identify and how to showcase it, okay? So I'm just going to move us forward a little bit, and we're going to talk about how to complete each of these alignment steps, okay? And we're going to look at any of those predefined key areas for alignment. We're going to look at provider alignment, how to describe your organization currently addresses this element. And that could speak to how are you addressing any of those HEDIS quality measures. And we're going to get into that as we walk forward a little bit. We're also going to look at the health plan alignment, and we're going to note that the health plan approaches this, and we're going to look at how a health plan approaches each of these elements. Okay, we're going to look at action steps. We're going to list action steps that you will take as a CHW organization, okay, in improving the alignment within any of these HEDIS and quality care gaps. We're also going to look at responsible parties, which may vary when we're looking at any of this alignment as well. Okay, and we're gonna have some guiding questions, and we're gonna use these to help prompt our brainstorm and thought process, if you will. Please stop me all along the way if you do have any questions, because I am terrible at stopping for questions. Okay, I'm kind of like that wind-up car. Once you wind me up, I'll just keep going. Okay, so we're also going to talk about tips for success. Okay, and in these tips for success, you're gonna want to review each of the health plan MCO mission and quality priorities before completing these worksheets. Okay, so if you have a relationship with the health plan or that managed care organization, an MCO, you could outreach to that liaison that you're working with, and you can ask them for their mission, vision, and HEDIS quality measures. You can more than likely go to their website and draw those down from their quality improvement page that they have, okay? If you're not able to connect to the website and you need to call the health plan or MCO, just call the provider services and ask to be connected to the quality improvement team to get those HEDIS and quality measures, okay? And then we're also gonna, you also want to identify in best practice as you're building your case model, your value story, and showcasing why the payer needs to fund your program. We do encourage that you bring CHWs to the table as well as clinical teams that can help in any of these processes and really identify for accurate input as well. So the clinical teams that you work with can also help you speak clinical terms to your health plan, okay? And your CHWs can help speak to your scope of practice as they engage in it every day. You can also use the action steps to create those measurable goals. And we do encourage you to revisit this, whether it be monthly or quarterly, because as you work through those HEDIS measures and quality care gaps or any of those programmings that you have contracted with the health plan or that managed care organization, they may evolve over time as you see successes and completions, so those things may change and evolve, or even if the health plan gets mid-year HEDIS updates from the state, then we may adapt and adopt and update ours accordingly to compliance, which means that you will want to as well. So it could be a living document that you'll want to revisit and renew. Access and CMS may update their AMPM 310W and their FAQs, which would now include additions or maybe omissions from that scope of practice. So you're going to want to review those as when those policies come up for review to see if that changes any of your processes, because we're going to look at the roles of the CHWs, what we can and cannot do. Okay, or those limitations, if you will. So before we get started, I'm just gonna, if you wanna pull these up on your phone, this is just a generic search of, Chris always forgets his training. So I'm glad that we've got these two gentlemen over here to help me with these things. Okay. So I did not do a good job about scrolling up. Okay. So right now today, we don't have each of those mission and vision and quality measures, right, from each of your health plans. Okay. But what you could do today, or to get started, you could look at some general common mission, vision, and what traditionally their HEDIS measure and quality care gaps center around within any of those priorities, okay? Your health equity priorities are now gonna fall under your whole person care initiative under access. And your whole person care initiative is your drivers of health requirements. This is gonna speak big to a health plan. Okay, because the health plan is bound by the drivers of health requirements under the whole person care initiative. So that is screening for drivers of health. That's your social determinants of health and your health related social needs, right? And how we're going to address those. We also use Z codes to identify any of those needs and conditions that were identified out of that assessment. Those are required to be in claims. Okay, and then if we're not using the closed loop referral system, Access updated the requirement in 2026 that if an organization is not using the closed loop referral system that is contracted with the health plan, you must have a community resource guide. It must be updated quarterly, in print, and on website. So these requirements are ever changing. That's why this really becomes that living document, if you will. Okay, I'm not going to spend a lot of time here. I just wanted you to know that you could Google some traditional, you could even say traditional top HEDIS priorities in Arizona or even regionally, okay? And you can use those in their generality of getting started if you don't have those elements. I already forgot my training, so I'm probably doing this the old way. Let's see, I'm supposed to click on this and then press Shift F5. I know, don't tell me, let me struggle. Oh, I did it, okay. I wanted to be successful, okay. So, all right, so, as we move forward, let's look at those system performances. Okay, so we already know that community health workers are essential to improving the overall health, right? You already have numbers in the state of Arizona of the impact of your work. You can use those numbers to help get you started. You can project your numbers and you can use actual numbers that you have produced, okay? And you are also trusted connectors. I'm not going to really dive into these deep. I just wanted to mention them briefly because you're going to want to talk about these two elements within your value story and showcasing your model, because this is a part of engaging the members, right? And we want people that know how to build those trusted relationships and that are essential to the overall health improvement. Um, so within the essential to improving those health improvements or the overall health system performance, studies have shown that 23 to 51% of your work provides reduction in emergency room visits. Think about the ripple effect and how you can infuse that into your value story to showcase your model. Think about, because it's not just the healthcare system that gets a cost savings, right? That touches your community, your families. So there is that ripple effect in the work that you do. 21 to 50% reduction in hospitalizations, okay? Also fewer readmissions and preventable acute care events. Kudos to you, great work. This is what we want to showcase. You could even pull these studies to put into your showcase, into your value story. Okay, as trusted connectors who share the culture, the language, and the lived experiences of the communities that you serve, we want you to really expound on how CHWs enhance member engagement and significantly strengthen the impact of care delivery. We also want to learn the terminology that the different MCOs and health plans speak. So I know that the AMP M310W, any of your CHW policies speak to patient, right? So within Arizona Complete Health, we identify those that we serve as members. So when you're working to apply with Arizona Complete Health, that might be a recommendation to use member, because that's going to be speaking our language. Okay, start building those relationships. Reach out to their community liaisons or a person like me, their whole person care manager, okay, that can help get those conversations started within the health plan. Start that relationship leading up to that contracting conversation, okay, and find out all of those specific nuances, and that's going to be per MCO, per health plan. So Access and the state of Arizona, they're going to give all of your health plan and MCOs, okay? Your MCOs are your managed care organizations. Those are your REBAs, your regional behavioral health agreements, okay? But you also have other health plans that are not an MCO, okay? So yeah, start building those relationships, learning their terminology. I think I lost a thought, but usually it comes back. So when it does, it's like that train, right? It'll come back. So I blame it on the altitude. I'm from Phoenix. I'm kidding. So I'm not going to go through this slide in detail, but things that you want to think about are your revenue opportunities through your CHW billing. You have been working extensively with NAU and Louisa on that, as well as many other agencies here today. So you also want to remember that these come into play in your value story when you're looking at what you can realistically do within the billing codes and your hours of operation or any of those specific things, like weekends or weekdays, any of those specific things. This is going to be for, you want to look at eligibility. So the members, you already know what the members have. Within their eligibility and their chronic care conditions or must be at risk of. And then I said I wasn't going to get into it, and then I did. But, you're going to want to expand and expanding and billing for the CHW services, and you can do that through your strategic alignment with these priorities to help speak to the MCO, okay? So I really want to get to this step-by-step process and walk us through. So this step-by-step process, if you will, can act as an alignment guide, okay? And really to help map out your CHW scope of practice in connection to the HEDIS and quality measures. Okay, show clear value to the MCO or that health plan, okay, and build case for contracting and sustainable funding. This is why you need to fund us, okay? And if we start here with step 1, this is about clarifying your CHW scope of practice. Your goal here is to really start with the clear written description of your CHWs and what they can do and what they can't do, okay? So if you have not already, I encourage you and recommend that you take the AMPM 310W and the FAQs, the CHW, CHR FAQs, couple them together, become one state policy of your scope of practice, right? Take those and build a CHW policy, if you will, for your agency and that workflow process. So from certifying your CHWs to hiring your CHWs, continuing education, what they can do, how they work within the HEDIS measures, when the referral comes in, this is what we do, this is our outreach process, this is our health education process, really lay it out from those policies. And if you do that, you're really one step ahead. You can take that policy and process that you've created, and this can be your template for your value story because you already have now everything all laid out. Okay, and then you can use these templates. You've got several handouts, trees, on your table that we'll walk through as well for you. But you also have some hand sanitizers and pens, so please take them if you need them. And there's also a box of crisis cards. There's tribal crisis cards as well as English and Spanish. So if you need those for your work, please take those, okay? In the actions in this step 1, we're gonna wanna talk about, you're gonna list those core roles and functions. You're going to list the roles and the functions that your CHWs perform. You could even use the framework like the C3 project. And you've got a couple of handouts there on the C3 project. You've got a stapled one and then a two-sided, and those are colored for you, okay? So these give some great examples in listing out those roles to each of those different elements like cultural mediation or health education, care coordination, outreach, coaching, advocacy, any of your direct services and your assessments. Okay, so I thought that the C3 consensus really gave some good examples of how to document those pieces. Okay. Then we're going to want to specify the tasks under each of these roles. So for example, under cultural mediation, you may be explaining health plan processes to the member. And these health plan processes may be different per your health plan and MCOs. So as you're interviewing and finding out all of this information from your different health plans, you're going to want to look at how different their processes are, okay? Helping members understand letters and benefits. That's that health literacy, right? And within health literacy, it also includes health numeracy because we want to help our members and families learn how to read those charts and graphs and understand, okay, any of those terminologies and maybe even how to talk with their provider about using plain language. Okay, and understanding those pieces. You're going to want to specify specific tasks under care coordination, scheduling appointments versus arranging transportation, how your CHW roles may differ within each of those elements and tasks, or how they differ from closing referral loops. Okay, whether it's within an automated system or within its legacy, traditional referral, okay? Within health education, you're going to want to talk about teaching about diabetes or self-management and, any of those specific tasks under teaching about diabetes or teaching about cancer screening or teaching about prenatal care, okay? You're also going to want to note limitations of practice, you know, what your CHWs can do and what they cannot do. I use CHW as an umbrella for today, but it does include all of the different identified titles of CHR, CHI, care coordinators, navigators, okay? But we're going to want to see the limitations, and you're going to want to see the limitations because this is going to speak to compliance and risk management, right? And for a health plan, it's not about seeing the limitations as negative. It's about knowing that we're in compliance and lowering that risk management. And for a health plan, it also helps us, well, we're going to want to work with this agency over here because they can do this and they can't do that. And then we're going to work with the agency over here because we can do this and we can't do that. So it really helps for that informed choice as well. I would recommend at least drafting a 1 to 2 page CHW scope of practice, whether it's a policy or that workflow process, okay? You can pare it down from there, but you know, they get pretty robust. So if you start with a 1 to 2 page, I think you're on a good roll there, okay? It says handout. Oh, those are your C3 project handouts for you to walk away with. Step 2 is about identifying those priority measures. And the goal here is to really focus on the measures that matter the most to the MCO or that health plan and that your CHWs can realistically do. And here it's okay to have aspirations of what we think that we want to do. And that may come to fruition, okay? But we're going to want to focus on the things that we can realistically do and make an impact on those measures, okay? And then we can bring forward those aspirations and really open up, and maybe there's other measures that you want to work with, or maybe other categories that you haven't worked within, you know, like cardiovascular, for example, and you want to, then you can start building any of those aspirations or things that goals that you want to work within as well, okay? So here, the actions, you want to request and review with the MCO those top priority HEDIS measures. They usually center around diabetes, hypertension, cancer screening, outreach, follow-up after ED visits, and antidepressant medication management. And this is not an all-inclusive list. There are many more, but these are some common ones that they traditionally work around. And if I didn't say it before, maybe this is the train that came back, right? Each of those HEDIS and top priority measures, the state will give to each of the health plans as a holistic goal, okay? But there may be some specific nuances within those HEDIS and priority measures, and they may be priority population based, they may be geographical service area based, okay? So that's why it's recommended that you connect with every health plan to find out what their top priority measures are so that you can identify any of those specific nuances to work with specifically with them. So any of those population segments, members with SMI, pregnant people, high ED utilizers, so that's your emergency department utilizers, or within specific zip codes. If we're using the terminology of vulnerable population or underserved population to a health plan, we're only going to want to recognize those categories if they are data-based. So your data must identify the definition of why this population is vulnerable, okay, or underserved. So these are some like little secret ingredient into working with the health plan, okay? Within the group measures, they could center around preventative care and screening. So for example, here, this would be around breast cancer screening, cervical cancer screening, colorectal screening, cancer screening, well-child visits, immunizations, social determinants of health screening. when you're looking at chronic disease management, this is where you're going to have diabetes centered around the AC1 controls, hypertension controls, or asthma medication ratios. Under behavioral health and substance use disorder, that's your SUD. This could be centered around follow-up after hospitalization, medication adherence, or substance use disorder treatment engagement as well, okay? Your access and utilization, for example, may center around emergency department overuse or any of those missed appointments or any gaps in primary care. But it doesn't have to just stop at primary care. It could move on to specialty care or any of those other pieces within their care. Okay, here the recommendation is at least, a 1 to 2 page priority measure naming, naming each of the measure, the population, and why it matters to the MCO. So when we start getting into these next steps, and remember, you can take picture of the slide. It's okay. You want me to stay here for a second? Okay. I just don't want you to miss it. I saw you writing. So in step 3, you do have the handout for step 3. So if you want to look at those, these are your orange ones here. You can take these templates and start the process today, maybe write some notes down specific to those templates. And you can go back and create your own templates at your organization, okay? But here the goal is to really focus on the measures that matter most to the MCO and that your CHWs can realistically do. The action here is to create the matrix template. So this is your matrix template. So what's going to happen and how to complete this is you're going to take that HEDIS and quality measures that the MCO gives to you, and you can put, say they give you 1, 2, 3, 4, 5. You could put, all of them in there, or you could put one in there. You can put the target population to that HEDIS measure. Okay, any key barriers. You can identify your CHW activities. Okay, you'll also want to identify your data and your documentation for this HEDIS measure. You're also going to want to look at the expected impact of this HEDIS measure, okay? Then on the right-hand side, this is where you're going to write your description. So you're going to name the measure and a brief description of it. You're going to, in the next box, you're going to put who the measure applies to, and that's that targeted population, okay? You're going to put down in the third box why members miss the measure, and those may be identified with some of those key barriers. You could even use this template to talk to a health plan. What are some key barriers that you have identified to help get your members engaged with managing their diabetes or their A1C levels? And the health plan may say, well, transportation, or members not willing to come out of their home, member has, we haven't had contact with member, we need somebody to reach out, do a home visit, any of those things. So now you have some identified barriers, okay? And then you could even ask the health plan and the MCO, what data would you like, do you expect to have, okay? What documentation do you expect? Or what do you think the expected, what would you like the expected impact to be? Maybe they're saying, well, our goal as a health plan is to make a 5-point percentage impact on the A1C controls. And so how can you contribute to that 5% increase? That's, again, going to show that value, okay? And then you can talk about what and how the CHWs record their work, okay? And how they document that anecdote of that visit and what happened, okay? You could also, in the last box here, talk about how activities move the measure, how you think that any of those CHW activities can help move the needle on that impact, okay? By doing home visits, by doing this and this and this and this, we can make an impact. Any questions on step 3? Okay, if you don't right now or today, you also have on your table a closed loop referral lunch and learn flyer. My email is on there as well as Unitas. So we do a lunch and learn every month. We co-facilitate with Unitas. And the reason why I mention it because it's on the same email address. I also run a CHW collaborative every month where we do technical assistance, and you don't have to be contracted with us to attend. So we're trying to help. If you want to learn more and start that relationship, just reach out to me and I can get you into that collaborative and we can talk more about this. And you can also email me any questions that you think that you might have after we walk away today. Step 4, you also have a handout for, and the goal here is to really turn that previous matrix into a reportable workflow that MCOs can see, okay? So I'm not sure if you're the CHW or the CHW provider type that's gonna do the billing, okay? So help take this information back to your leadership in helping to make that alignment. And we want this reportable workflow that MCOs can see, measure, and fund, okay? For example, this is a workflow connected to colorectal cancer screening. So here you have the trigger. That's the risk flag, okay, the condition or the identified need. And it is impacting members age 45 to 75, flagged as overdue for colorectal cancer screening. Okay, you receive a list from the MCO or that health plan of overdue members, okay? So here we're gonna learn that a referral from a health plan is really a care gap list. And that care gap list could have anywhere from 1 to 300 members on it, okay? That becomes your referral in essence. So referrals may be different from a health plan or MCO versus a clinical provider or other types of behavioral health providers in the community, okay? And then your outreach. So from that previous matrix, you identified that one of your CHW activities is outreach, right? So now we're gonna do outreach. You can identify your first attempt, maybe a phone call, if no answer, text. Okay, maybe you have a second attempt. You're going to repeat call, still if no contact, text, but now we're going to initiate and trigger a home visit. Okay, maybe work through your 1, 2, 3 steps. Okay, you're going to want to talk about the engagement and documentation. So if you see from that previous matrix, now you can explain those screening options, okay? And you can also include your culturally and linguistically appropriate ways. So we work in a community that has many different preferred languages, right? So on your table there as an added support, you have an interpreters available poster that we do encourage you to carry with you. If you do come across any members that speak different languages, they can point to that language if we are having a disconnection. So that's another element that you're gonna want to learn within a health plan are those language access services, okay? Whether you can utilize the health plan's language access vendors or not utilize them. But by federal requirements and law, they require any provider working within the healthcare system, there's that train again. What was I talking about? Language access, okay? That every provider providing services within healthcare, okay, they have to have contracts with language access vendors because within a health plan, we're only gonna work with agencies that have certified bilingual staff or that use certified and licensed interpreters from other vendors, and they must be licensed within the state of Arizona. So this may impact the work that you do if you are translating translating any of your product into other languages or your services in oral interpretation or sign language, okay, you're going to want to identify with those different nuances and requirements, okay? So your follow through, and you're going to identify what you're going to do to follow through and confirm those screenings and home kits were received and returned. Your documentation, you're going to record any of those outreach attempts, member-informed decision barriers, successes, and also maybe some not successful areas. And then your completion status as well. And then lastly here on the step 4 box, you're going to want to talk about how this supports the HEDIS and quality gaps. And so in the example here, that it increases screening completion rates, reduces no-show rates, right? And improves member experience. Okay? And those are what we're going to measure there. Any questions on step 4? Okay. Step 5, there's no handout for, so you can take a picture of this slide. This one here really defines the performance and the evaluation metrics, so measurable, trackable, and evaluable. Okay, so the goal here is to show the health plan and the MCO that CHWs work within measurable, trackable, and evaluable, and that it's not just nice to have. Okay, so you're going to talk about, again, in the process matrix, you can pull what the CHWs do over. You can pull in the outcome adjacent metrics. These are really your leading indicators, such as appointment completion rates, your screening completion rates, and so forth. Okay, you can also link to the HEDIS and quality outcomes for each of these measures separately. So you're going to want to separate them out and do this for each one of them. So you're going to have your baseline. The current performance, for example, is 62% colorectal screening, okay, is what the health plan has identified. That becomes your baseline. Okay, your target, this is where you come in with the realistic movement of what you think that you can do within your CHW scope of practice. And if you think that so for example, this sample organization thinks that they can do 70%, they can move this performance up to 70% in 12 months. Through the work that they're going to do. And then they're going to identify their CHW contribution, okay? Which CHW metrics will move the needle, whether it's the outreach rate or the appointment completion and so forth, okay? So this becomes your step 5. Any questions here on step 5? Because that was like in fast forward, right? Okay. In step 6, I don't think that you have a handout for this as well, but you do have a handout on your table that is a stapled packet of 2 examples of 2 fictitious organizations and their value stories, okay? And underneath them are all of the core elements, just like in this example. So on the left here, you've got your core elements that should be in your value story that we've already talked about. That's that problem statement, the current data highlights, okay, the opportunities to advance performance on X, Y, and Z HEDIS measures, okay, within maybe a key zip code and specific to this priority population. And then you've got your CHW solutions. And then you've got your CHWs as trusted community members, these members who can reach and engage members through and by da-da-da-da-da, okay? You can, in here you also want to align to the measures. You want to use your CHW HEDIS matrix to really illustrate that measure-by-measure connection. That's why I really encourage and recommend that you get those HEDIS measures and break them apart in each of the roles within your scope of practice, okay? Illustrate those workflows, the documentation process, data sharing capabilities, okay? Your measurement plan to govern those goals. and your present process and outcome matrix, reporting frequency, and how you will collaborate on improvement. Okay, health plans are big on collaboration, so we may want to know who you're going to collaborate with and how. Okay, so over here on the right, you have an example of this value story with each of these elements in there. Okay, so this is just an example and enough to fit in this box here. So any questions on the value story or any of these core elements? Okay. Okay. Wow, that's awesome. That means I'm doing a great job, right? I love it. Oh, thank you. I'm like Tinkerbell. If you don't clap, I'll just die, right? So step 7 is to provide that concrete example to the MCOs. Your goal here is to make it easy for the MCOs to see, adopt, and fund your model. Okay? This is your case. I do suggest and recommend that you provide attachments or supplemental information when you are submitting a letter of intent to work with an MCO or a health plan. You know, we're going to want to see your CHW scope of practice policy. We're going to want to see your scope of practice workflow. We're going to want to see CHW HEDIS alignment matrix. Maybe you provide a blank template on what you use and then one pre-filled out on an example. Okay, we're going to want to see standard CHW workflows. If you are already working within any of these identified conditions, if you're working with prenatal, well child visits, diabetes, cardiovascular, any drivers of health assessments, we're going to want to see your process and your workflow because they may differ between each of those priority HEDIS areas. We're going to want to see sample reports, okay? Please provide us with dashboards and tables illustrating your metrics and closing those care gaps. If you're not working within these areas, it's okay to provide an example of how you would measure something and a mock graph of tracking that. Okay, that gives us an idea and a snapshot of what we're going to expect. Because remember, all of the fluffy anecdotal and the story of being with that member is very valuable. But for the health plan, you're working with the quality improvement department. They're going to want to see the numbers. Okay. So that's where I really want you to focus on. We're also going to want to know how you data share and privacy overview. Anything that's connected to HIPAA, we're going to want to see how you work with that data sharing and protect. Okay? So here in this sample template, you can take a picture of this one too. Oh, I think you have a handout for it. So you can put here the template 1, you can put for each measure. So if you're doing 1, 2, 3, 4, 5 measures, you will have 1, 2, 3, 4, 5 templates. You put the measure, the population, the key barrier, the activities that are expected, the data and documentation expected impact, and you can break it out into each of those steps. Okay? And really focus on identifying and really delineating out that process. So here, again, you have those alignment examples for you, okay? So you could even use these to help jumpstart your conversation in your organization or to help to start to write your value story and then curtailing it or specifying it directly to you, okay? These are things that you already do. This is the closing slide. This is not only things to remember, but these are also things that the health plan is going to want to see and the things that you already do. We're going to want to know how you conduct your drivers of health assessments. Those are your SDOH and health-related social needs. Okay, your social determinants of health are broader conditions, while your health-related social needs are more intimate. Okay, we're going to want to know how you translate those drivers of health findings into the appropriate Z codes and providing them within the claims, because we're going to track the Z code utilization. Okay, we're also going to want to know how you apply class standards. Access's whole person care initiative, those drivers of health requirements, are all outlined by class standards. So we're going to want to see how you apply them over your program. Okay, we're initiate and track closed loop referral systems. So we're going to want to know how you initiate referrals and track them. We're also going to want to know to support whole person care by addressing physical, behavioral, emotional, social, and you may not be supporting all of them, but we're going to want to know which ones you support and how you support them. Okay, how you're going to help close those HEDIS measure gaps. Hopefully those step-by-step processes will help identify those for you and with you. How you're going to reduce barriers to care, such as transportation, housing, childcare, insurance, navigation, any of those specific pieces that directly impact those HEDIS performance measures. We're going to want to know how you strengthen care coordination across the system, as well as improve member engagement, and how you're going to enhance those organizational performances by improving those drivers of health data quality gaps. That's everything that I have for you today. I don't know, my time is here for you. So I know that we're 1 minute over, but if you have questions or want to see something again, I will totally stay and do that for you. They are not. Isn't that the funny thing? Here's an example. Okay, so I'm not allowed to give you the PowerPoint, but I can give you certain pieces, let you take pictures, and let them record it. But I can't give you the PowerPoint. Those are some of those nuances with the health plan. Wherever that they post, that it'll be there, but I will flip it back. You tell me which one, right? Step 5, I'm like, Chris, you have it right in front of you. Step 5. Provided as a handout. That could be,
And like Chris said, we are recording. It'll take us a week or 2 to get the final recording up on our YouTube channel, but once it's up, I'll send out an email to everyone that registered today.
Thank you, Nick. Step 6? Absolutely. Okay. Oh, you're very welcome. And thank you for spending your afternoon time with me. I really appreciate it. And if you do walk away with any questions, our priority here is to help set you up for success. So reach out to me at any time, and whether you're contracted with us, we will help with any technical assistance with this piece. Okay? Step 1. Yeah, absolutely. Yeah, it's on the closed loop referral lunch and learn, or if you want to take a picture of the first opening slide, it's got that there. 7. Please take as many of these templates or information that you want. Share with your organization.
2, 3, and 4. I think we're wrapping it up. And I saw the little snack cart coming, so we have to, once they get the plastic off that, we can go eat it. Well, I think people are just trickling back in, but I wanted to kind of have an open mic situation, and if you maintain eye contact with me, you better watch out because I might hand you the mic, so watch out. You should look down, look up, look anywhere but me. I'm just warning you. But I wanted to just thank everybody for coming, all of our holdouts, the longest standing folks that are here. I think I don't have any real awesome words of wisdom except for the fact that we have a lot of strength and power in our groups, a lot of expertise, and a lot of passion and examples of how to go forward, and maybe potentially a lot of lessons learned on how not to move forward. So I hope that everybody that came today feels connected to at least one new person in the room, feels like that they could call them. Maybe you're on a text message basis. You always know if you're on a text message basis, then you're in. But I hope that you feel like you've made some new friends, new partners that can support you along your journey. So I'd love to just, if there's anybody that would like any speakers or anybody that would like to say anything before we take off and kind of we're going to have a little social time if people want to stay, or you can just grab your food and go. If anybody had some lingering questions, we're going to be here. But any thoughts from anybody that was able to talk or share, or no one's looking at me. Oh, we got one. All right, I'm coming in. We'll be quick. Thank you.
I was just going to say how much I appreciate what you guys put together today. I feel like it's a really good networking opportunity to learn about community things that I didn't necessarily know about. So I'm grateful for the opportunity to be here.
And where are you coming from? What agency?
So I'm with North Country Healthcare, but I come from Springerville Eager.
Yep, awesome. Well, thank you for what you do. Thank you. Awesome. All right, any last people? You're good? You're feeling good? Feeling love? Brenda, your hand is almost up. I almost put the mic in it. Almost put that mic in it. Are you going to say something, Nora? Okay.
Sure, why not? Thank you so much. This was such a great opportunity to learn new things, to share. And it's great to see how different sectors of health, care, and community are represented from the city, from the counties, from hospitals and CBOs, and it's just great. So at least I feel like we're part of something bigger, and thank you. It was great.
Thank you. I appreciate it. All right. Got the thumbs up. So for those of you that are just coming in, we were just wrapping up and thanking everybody for coming. It's been a long day. We know you all are extremely busy, and we really appreciate you spending all day with us today. I did mention that we have that Northern Arizona network. I'll send that out to this group in case you want to show up anytime and maintain your connection with anybody that you met today. We meet the first Thursday of the month at 1 in the afternoon, and it's a really low-key, open environment where you can come and learn and share. And we know we have some really incredible examples. I would say Navajo County really is shining bright, and that's a county that we should be looking at over the next couple of months, or I think months, not years, to see how they leverage all of the opportunities that they're seeing. We have some really cool, exciting experiences maybe with other nonprofits in the room as they move forward. And obviously we have Navajo Nation here and Wallapai Tribe who are also pursuing their pathways towards supporting their large workforce. So thank you for coming. We're always here. We're at NAU. We live in Flagstaff, so we're here for you at any time. And I welcome you all to just stay, enjoy some sun. There's snacks and stuff outside, and we won't be offended if you have to take off either. So thank you all for coming. Appreciate you.
And we do have the space until 6, so feel free to hang out as long as you want. I know all of our partners are here to network with you and talk. But if you could take 1 minute to complete our post-workshop survey, it's also on, I think, like the second to last page on that program. If you want to take it home and do it later, that's totally fine. But this is more for me, just to make sure when we do these in the future, I can make them better. And also, there's one question on there that any future topics that you'd like to have us kind of bring up, do these free public health workshops, let me know. We're always looking for new ideas. And honestly, these ABRC workshops are just awesome opportunities. If you have an important topic, reach out. We might be able to do a workshop on it. So thank you all so much for coming. Really appreciate having you all here.
Thank you, Nick, for